Good morning, everyone. I extend a warm welcome to all the participants, students, and the delegate for the scientific global digital gathering at the 10th World Nursing Healthcare Management and the Patient Safety Committee. Welcome, everyone. Finally, we can meet face-to-face, we can meet physically. Also, I would like to welcome people attending online. However, we're still in pandemic and some of the countries is still closed, so a lot of people were not able to come in person and attend. But they can join us online. So we are doing hybrid now. In the beginning, I would like to present myself. My name is Dr. Rasha Ahmed. I am a physician. I am working head of quality and clinical audit in Al-Futim Healthcare here in Dubai. About the UCG conference, I would like to handle so you can have a hint about the conference organizers.
Hello everyone, this is Priya from UCG, and now I would like to say a few words about our organization. Utilitarian Conferences Gathering offers a wide range of events, meetings, and conferences. We have a dedicated team who are aimed at acquiring the technologies, adopting the knowledge of business needs, and accelerate with best ideas and strategies. UCG is a pioneer in the area of event management, collaboration. We are a full-service event provider specializing in the field of medical, clinical, healthcare, life science, pharma, environmental science for academic and industrial sectors. We stand out distinctively from our competitors for our commitment to quality round the check and unmatched price. We are able to provide you with the best event, meeting, experience under one roof. We at UCG make sure that you as a client choose the most appropriate event. I thank you all for finding time in your busy schedule to be here today. Today marks a major activity in the brief existence of the UCG conference. Yes. A moment where we are interacting, sharing experience, and reflecting on various areas. Then NHP UCG 2021 is a remarkable event which brings together professors, researchers, and students in the field of nursing, healthcare, and patient safety, making the conference a perfect platform to share experience, foster collaborations across industry and academia, and evaluate emerging technologies across the globe. We cordially welcome you to join us and witness the advance in the field together. The conferences has attracted attendees who have come from all over the world, across the continent, and the subject of the conference is surely of global importance. UCG thanks all the individuals and organizations who have worked to make this conference a grand success. UCG program committee has put in long hours with many creative efforts, and finally, I would like to extend my appreciation to the participants of this conference. We hope you enjoyed the conference and that our participation will contribute to our professional development and relationships. Because of the COVID-19 pandemic, we have provided both the platform, in-person presentation, and the live presentation from virtual space. Many of our attendees who are willing to present in person are unable to attend due to the new variant and travel restrictions. In the context, I would like to introduce you to Delight No Sugar Added. Delight No Sugar Added offers you many options to satisfy your sweet tooth while still cutting out sugar out of your diet. We offer a variety of chocolates that are 0% sugar added and made of completely clean and natural ingredients. Delight products are 100% safe for all types of people, including diabetics and children. We use a natural sweetener as a substitute for sugar that is extracted from a plant, which doesn't increase the level of sugar in our blood. So you can confidently eat as much as you desire. We are glad to have them with us today, and their representative will be giving their workshop. Please don't hesitate to get in touch with the Delight team if you would like to know more. So they are already sitting there. Note, yes, this is your part.
Yeah. Thank you. Thank you. So let's start because we are already late. The first speaker is Dr. Ali. I would like to welcome Dr. Ali. Dr. Ali, he is a public health consultant, medical communication expert, keynote speaker, and leadership coach with over 24 years experience, leading team involved in direct medical intervention, building healthcare system, providing advisory and transforming medical communication for government and the public organization in Europe, Middle East, and Africa. Dr. Ali can speak in different language. He provides coaching in Swedish, Arabic, French, and English. And today he will present to us a lecture about simplifying doctor-patient relationship, how to talk with your patient. This is a very important topic and we'll cover a lot of things. Welcome, Dr. Ali.
Thank you. I will record for myself.
Okay.
So, good morning, everybody.
Good morning.
Simplifying doctor-patient relationship. I don't know how many of the people here are meeting directly patients. Not so many. 1, 2, 3. Not Dr. Tamara. Dr. Tamara. I know only Dr. Tamara here. Yeah. The relation between the public health or the health providers and the patient, which is the point, how we can achieve our goals. The goal of hospital, the goal of clinic, the goal of doctor, the goal of nurse is to satisfy the patient. Is it correct? Do you agree with me? Not everybody. Yes, you agree with me. Thank you. Yeah. So today we will talk a little about how is our relation with the patients, how we should talk with the patient. We meet different patients. How should we manage that? We are in Dubai. Dubai, we have more than 200 nationalities here. If you work in a clinic or in hospital, it means you have to know too much about many cultures here and to understand them and how to deal with them, especially in Dubai. When I worked first in my life, I worked in Palestine, and it was easy for me because I treated only Palestinians. It was easy, yeah. My language, everything, it was easy. But then I started to work in Sweden. Sweden, I worked there and I met different cultures and how to deal. I don't know how to deal because I am new there, even if I studied in the college, but I studied only the medical and dentistry, but I didn't study how to talk with these patients, how to deal with them, how to say good morning to them, how to convince about my treatment, how to improve myself as new doctor in very high level of the countries in Europe. And it was very tough for me. That's why I started to study the level of understanding patients, the cultures. So, simplifying doctor-patient relationship. My name is Ali, as we talked before. And I don't know how to change this. If I click here, no. To the next page, no. I am extremely bad in these programs and PowerPoints. I want to jump to the next page because it is the most important page in the PowerPoint. The most important. You will be surprised now. Yes. Nobody react. Nobody react. Yes, please. Thank you. So, as Dr. Ashashi said, I am Ali. I worked in Palestine first. It's important what I want to say about myself. I worked in Palestine, Sweden 10 years, and then Dubai now 10 years. But I am not very old. I'm only 24 years old, not experienced. This is wrong written here. Yeah, some years, absolutely, yeah. So medical communication and leadership expert. When I was in Sweden, I started to study the public health and then how to develop the understanding of the management of the health. So medically professional to understand cultural sensitivity in leader in healthcare. When I was there was a project to help the immigrants, new immigrants in Sweden, to involve them in the healthcare system in Sweden. Healthcare system in Sweden is very developed, like Canada. But we, like Arabs, like other nationality, we don't understand that. We go to the emergency department and we want to be treated immediately. And this is not the case there. You have to wait very long time. So everybody says it is very bad healthcare system. But all the studies shows that Swedish system is the highest and the best in the world. Why we misunderstand that, why we cannot understand that, this we will handle and talk about it today. So I help healthcare facilities to find the way to succeed. PhD in public health focused on prevention and general oral diseases. My background is dentist and I love my work. Dr. Tamara, she worked with us also. She's dentist. Master in international public health in Sweden, educator from Stanford University. This was a great program, to be honest. I would advise everybody to check there. This is a chronic disease self-management. When you treat patients and they have chronic disease patient, diabetic patient or whatever, and they feel extremely upset, they feel the anger all the time. This program is 4 weeks education to educate your patient and your staff how to deal with them so they will feel much better, how to integrate, to understand their disease, how to deal with their disease, and how to feel much better. You can check that on Google, Stanford University. This is the only program in the world. I planned with somebody to make this program in Saudi Arabia, if somebody from Saudi Arabia, yeah, but I don't know, it was a little difficult for us, but yeah. Professional Diploma of Hospital Management, certified by the Swedish Dental Board. So we go now to the doctor-patient relationship. One of the significant elements in a doctor's professional life is doctor-patient relationship. When I say doctor, I say it like health provider. It can be nurse, it can be dentist, it can be whatever, who meet the patient, health provider, DPR. To develop a good DPR is one of the basic requirements of primary healthcare unit, without which diagnosis, treatment, and health of the patient will be compromised. This relationship is defined as the one based on mutual consent in which the patient seeks doctor guidance and the doctor provides the patient with the best possible treatment options. Do you agree with me for this definition? That the doctor will meet the patient. Patient, he wants a treatment, he wants help from his doctor or nurse or dentist or whatever the health provider. So the doctor should be very well prepared and the patient should help the doctor to get the correct diagnosis. You agree with me, doctor? Sure. You are the only one agree with me. Nobody agree with me. Yeah, you agree also with me? Yeah, but I cannot hear you. No, you have to shout. We are big Sal here. Many people, they want to listen to you. Yeah, we just joke. Yeah. When I worked in the first clinic in my life, I treated almost 50 patients in 2 hours. You can imagine the number. 50 patients in 2 hours, because it was, I am from Gaza in Palestine. So it is extremely crowded and we take patients, just put anesthesia, wait in the waiting area until the anesthesia works and we make the extraction with the fillings, etc. Then when we change all the career to Sweden, I cannot treat more than 8 patients per day. This is the luxury, to give them time. So, oh, now I am visible much more with the online, yeah. Everybody online see me? No, okay. So there is still a thread of delicacy in this relationship where the patient discloses many secrets to the doctor, tells him truly about his disease and confidence in him about the concern regarding his treatment. Okay, so we go ahead. The rights of the patient. Everybody talk about the rights of the patient and the responsibility of the patient. When we talk about patient in Dubai, for example, everybody is scared. He will complain in DHA about me, but he has a responsibility to do. We should understand. If you do your treatment by very good way, don't be scared from any complaint. Yeah, you are very well done in your treatment, your consent form he signed, and you explained everything and you wrote that and he understood that. It's important that patient understands what the health provider tell him. It is mentioned and documented, so don't be scared. Nobody can complain against you. No mistakes there. So the rights, as everybody knows: informed consent, withdraw consent at any time, refuse experimental. When patient come to us and refuse to sign the consent, we don't treat him. When the DHA asks, DHA, it is the Dubai Health Authority, ask about any patient, the first thing they ask in their file, send me the consent form, signed consent form. So if the patient can refuse experimental or research treatment, obtain a second opinion, and be treated with care, consideration, and dignity. The responsibility of the patient. Patient must come on time, of course. I come 15 minutes before my time today. Patient must know the medical history, including medications taken, keep appointments or advice, informed in every possible case, stick to the treatment or advice, informing the doctor they are consulting on other doctor, know their role and behave mannerly. We will talk about behaviors later. Rights and responsibilities of doctor. Why you don't take photos for me, Dr. Tamara? Really, yeah. Doctor must give logical data on illness, diagnostic, and the treatment choices accessible to the patient. When the patient asks for his file, he can get his file. Everybody knows that. Doctor is additionally answerable for tending to the patient's interest and taking informed consent for the therapeutic activities. Doctors must regard the patient's choices in any event when they conflict with them. They should maintain the enthusiasm of their patient over their guardian. They should never utilize their clout for any reason other than the well-being of the patient. How to talk to your patient. Now, the first thing when I do in my clinics, as we are private clinics, we are not in public clinics, so we need to take too much care of that patient. When the patient comes and sit in the waiting area, there is long process we deal, how we can receive the patient from the waiting area to the treatment room. We cannot just say, done. He will be very disappointed. Number two, in Dubai, you have to provide the best possibilities of the services you can, whatever it is, medical or restaurant or whatever, because it is Dubai. So let's take it point by point. Is it interesting until now? Oh, I cannot see very well. I need 2 glasses now. So get to know your patient. I can see her much better. Introducing yourself. Everybody, I hope, do that when we meet the patient. Yeah, my name is X. I am X. The patient will feel comfortable directly there. Explaining your role, taking proper consent in patient's care, making notes of their medical records and asking them basic knowledge is mandatory to start any investigation. Trust of the patient. Trust is essential element beneficial to both the doctor and patient for good recovery and treatment of the patient. This is important point, how we build the trust in very few minutes, because you don't have very long time. When you receive the patient, let's talk about me. When I receive the patient, hello, how are you? And said, how can I serve you? Then I try to build that trust in these 2-3 minutes which we have, because then I will work with him. I don't know what's the issue. So how to build that, we will talk about this. If he believes in you, he will accept your treatment. If he will not believe in you, he will not. He will just, yeah, I am in a hurry, my parking, my car, somebody waiting for me, and he will run away. Relaxation, yeah, relaxation to make massage for the patient, yeah. The patient is comfort in the foremost check for a doctor. Do your best to let the patient feel comfortable while expressing his disease. Listen to your patient, don't interrupt your patient, which we usually do. When he talk, yeah, I know, yeah, come, we fix that, yeah, I know. Talk, listen to him, yeah, give him the time. Asking the right questions, inquire as to whether the patient has concern. Not simply questions, open-ended questions. I hope everybody can use this. Yeah, not, do you like ice cream? Yes, no. No, we don't ask such questions, open-ended. Yeah, what do you like to eat? And let your patient talk. Yeah, how that pain came to you yesterday, how? So open-ended question, let him talk, yeah, to express everything and listen carefully, which is difficult, correct? No, it's not easy to listen, really. It's not easy. Involving the belongings of the patient. Patient confidentiality should be the priority of a doctor, but this is not true in every case. In some sensitive issues, the belongings need to know about the illness of the disease of the patient. Identification of the barriers and limitation. You may comprehend and understand the barriers to education, and patients may confirm them. So we go ahead. Active and passive listening. The ability of the doctor to inform and instill confidence in the patients and convince them of the need for their compliance. For example, can make the difference between successful and unsuccessful treatment. Active listening, meeting and listening to the patient in isolation. Make sure the sitting arrangement is peaceful and quiet. The place should be free of unnecessary voice and interventions by the staff. Appropriate eye contact during the session with the patient. I don't know if everybody believes this is correct, the eye contact with the patient. The health providers here, you do that? You look at the patient when he's talking? Yeah. Do you think it gives good result when we talk with the patient like that? We look at the patient eye to eye, or we just keep like that and we listen to the patient. There are two methods, and it is extremely difficult for the doctors. We will talk a little more about that. So you think it is a good idea, eye to eye, and we will talk a little more about this point. Attending the verbal and non-verbal cues, clarifying the comprehending briefly the information provided by the patient, responding with yes or no during the session, concluding the statement with remarks, and assuring if the patient has understood all the critical terms and the procedures. So, how we can assure the patient understood? By ask questions. Usually patients don't listen to you. Really don't listen to you. Yeah, you talk, and then I tell the patient you have to use mouthwash 3 times a day. When we finish, yeah, I told you how, do you remember how many times you have to rinse your mouth? Yeah, they don't know, they don't listen to you. Yeah, this is a good way to ask, to repeat to them, but to protect yourself also, from any issue, which may, inshallah, will not happen, complaints, you need to write in your notes, I explained to the patient and patient understood. You have to mention that, so you are protected for that. If patient will say, no, doctor didn't tell me that I have to take my antibiotic. So passive listening, in comparison to active listening, passive listening is not an acceptable form of listening when it is noisy, it is so many people around, so you cannot talk with the patient. Yeah. Which doesn't elaborate the true meaning of the information provided the patient to the doctor. Not meeting and listening to the patient in isolation, listening to the patient inquiries while your center of focus is something else you are thinking. The new married girls, usually they don't provide very good service in our clinic, because when the assistant, she's working, she's still thinking about her fiancé or about her lover, about her husband, etc., etc. So she's like that, working so somewhere else, even doctors, of course. Yeah, so when you are somewhere else, you cannot provide services. Unnecessary voice repeated interventions by the staff, everybody's shouting, everybody is fighting in the clinics or hospitals, not attending the verbal and non-verbal cues. So does and don't in communication. Use the patient name. When you go to the waiting room, yeah, look at the patient. It's my suggestion. Yeah, good morning, how are you, Tamara? Would you please follow me? Look at the patient. Yeah, he will fit us that. You know him already. That. Yeah, and he will, and look at him when he is working or her. Yeah, him, and let him work. How are you? How are you doing? Yeah, until you reach the room. I believe mostly the nurses from India, from Philippines, etc., they are shy. So would you please follow me? Going like that. No, be strong. Every time I take the stuff, be strong. Talk to the patient and good morning, eye to eye, as we talk, eye to eye. So he will feel, yeah, it's my family here, it's my place here. I know everybody, they know me. They know me. Write in the notes also, if the patient is working in the bank or working wherever, patient works in NBD bank. So next time when you see the patient, how's your work in the NBD? You will be very surprised. Yesterday I had patient, she's working in do the telecommunication in Dubai. I treated her in 2014, but I put in the notes, she is director in do. She told me, I am sure you don't remember me. Told her, how is your work in do? She was extremely happy. We make 45,000 from her. Well, yeah. Because she feels she's with us. Because this is business. Okay, so first impression as essential and using patient's name, greeting them of the initial meeting is a way to make excellent first impression. It shows respect, being good listener. Dr. Rashid, are you a good listener? Sometimes, yeah. Yeah, sometimes. It's extremely hard to listen to your patient, really. Listen to all the details provided by the patient, but yeah, to understand your prior diagnosis and suspect all linguistic and para-linguistic aspects. Don't give unrelated patient advice. Yeah, why you married? It's not good to marry. Yeah. No, really, and you involve yourself in something else. Because I remember I was in Geneva one conference, and one judge, he explained to us that patient who will complain against you is your friend, not stranger patient. The stranger will not complain against you. You're a friend. When you have good relation with your patient, started good relation, and you give his number and he call you at 2 a.m. I have pain in my stomach, what should I do? So he knows you now. And after 2 months, he will complain to you that you didn't provide good service for him. So don't mix your private life with your professional life. You agree with me, doctor? No?
I mean, we don't mix the personal.
Yes, yes, yes. Because many doctors, they give their private number to their patients and they open all the doors to the private discussions, and that will deal to probably good relation, but the good relation is not sure. Yes, yeah. Don't give unrelated patient advice. Avoid misguiding or sharing inappropriate information to the patient. Avoid talking about yourself. Don't talk, yeah, I am blah, 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 blah. I did blah, I am the best, because patient, when healthy provider talk bad about another healthy provider, patient will not respect you. But this is the case every time. And never I heard any health provider disagree with this point, but always I heard when patient come, yeah, I went to doctor and he says your work is extremely bad. It's still like that, yeah. In all cultures. Understanding and assisting the patient, appreciate relevant questions regarding illness, allow the patient to make notes about the consultation, ask and repeat essential information, explain the complex terms of and the procedures in the man language, simple language, must offer an early follow-up appointment, provide all information in written or suggest prescription in writing, allow the patient to reconsider or discuss the second option available for the respective task. Disputed patient and problem solving patient. The most difficult patients are the health professionals. You agree with me? When dentists and my team treat my teeth, I am the last patient because I will scream too much and we need to close the clinic doors because I am so scared and I make headache for my dentist really. When they give me injection or whatever, I am talking about myself. When I receive doctors or dentists to treat them, I should prepare too much for them because it is not easy. And they ask you 1 million questions, absolutely. And finally, they don't want to pay. Yeah. So health professionals and certain types of patients and their families are exceedingly challenging to deal with. Refuse diagnostic tests and the treatments, yeah. Become rude and aggressive. Become angry when things don't go their way. Ask for undue favor. Yeah, would you please write for me 2 doses of cocaine, something like that? Yeah, we have all. Make unprofessional demands. Yeah, can we meet outside in some bar, some cafe, somewhere? Yeah, become too dependent and clingy, yes. We will talk a little more about that, how to manage this. Train yourself, you can hear, to relax. Whatever the patient talks, you need to listen. And you need to listen, and you need to listen and say yes. Train yourself well in the principles of effective communication and counseling. Learn the relaxation techniques to manage your own anger and feelings of frustration. Patient will come to you and say that you did very bad work to me. And I visited another doctor for second opinion, and he says it's extremely bad work. When they talk about your personality or your work, it affects you extremely bad. This is bad, and you will feel bad, but you cannot show that to that patient. And this is a very big problem. You have to be relaxed. Yes, I understand you. Yes, I understand you. This is what we can tell the patients. Approach difficult patients with tolerance, patience, and use of principles of active listening and unconditional positive regard, keeping you cool. Allow the patient and family members to express anger and validate by statements such as, Your anger is understandable. I can understand your feelings. For difficult patients in particular, define the objective and duration of consultation in advance. Offer referral to colleagues or senior consultant, particularly if you are not making any headway. Involve family members, friends, or significant others in the life of the patient for support as well to help them understanding the patient's issue. You are a health provider, you told me, right? Who is doctor or nurse here? Yes, how you deal when you have angry patient? Patient come, doctor, what you did for me?
I'm a pharmacist.
A pharmacist,
So,
yeah.
we basically sometimes face a lot of like that. We need to absorb that in the beginning, first of all. Quite very simple that, hello, how are you today? How can I help you?
Yeah.
Just to break the ice in the beginning.
Yeah.
The iceberg is really it's coming on fire. The ones we saw that you are too open, so open to him or to her, they will dramatically calm down.
Yeah.
Yeah, better than just to keep. You're gonna keep talking and you're gonna do the same way. So you're gonna end up with your complaint now.
Yeah, you agree with that? To make them just talk and you don't answer. You don't comment.
They take first say what they want to say. They take proud because most of the time when they like that they skip. And so we need to make them know that I can see this. And you give me the opportunity that I can know. What would you like?
We will see if that works or not. Yeah. Yes, yes, yes. So the online, you miss too much online, the online teams, yeah. Counseling, because I think online they see only this area, right? Not everywhere. Nobody here. Who can answer me? Okay, nobody. Yeah. Alhamdulillah.
Do you need some names?
No, I'm checking online how they see what? They see the screen, they see me, only the screen. Oh, poor online people, yes. So counseling skills, your personality as healthy provider, how you can talk to the patient and to give advices, establish a relationship of mutual trust and care in which patient or their families feel secure and able to express themselves to a positive way. Give the patient or family to seek a clarification of terms, issues, and misgivings. Provide opportunity to the patient or whoever being counseled to freely express his or her feeling, her emotion. Provide reassurance. Achieve deeper and clear understanding of a health-related issue based on scientific and evidence-based data. Identify the various choices, options, alongside their pros and cons through a process of discussion and dialogue between the counselor and the patient. Help the person to make a decision. Help the person to make decision. Do we have dentists here? Only Dr. Tamara. Non-verbal communication in a cross-cultural scenario. Actually, competent healthcare professionals must be professional in understanding, interpreting, and conveying, difficult word here, conveying, I don't know, non-verbal communication. Following scenarios will help better understanding of the misunderstanding that may result due to failure of correctly using various aspects of non-verbal communication. Now we don't know. Now we just go here, greeting, as we talked about that, yes. And you work in Dubai, you work in Canada, you work in Sweden, whatever, and you will meet all the nationalities, how to greet them. If I am a Swedish man, and I saw that too much, and I go to a woman with hijab and I want to say hi with my hand, and the woman will say, so the man, the Swedish man, he doesn't understand what's going on, why she doesn't want to greet him, sorry. Yeah, but He does not understand the culture. He doesn't know, so this is his mistake. Yeah. Is it my photo? No? Okay. The signs of a greeting may vary in different cultures. Japanese gratefully bow and also shake hands with Westerns, while most Indians, a namaste would suffice. Latinos, very warm welcoming. Latinos, I love Latinos. We have somebody from Latin America, no? Yeah, welcoming and shake hands. Even sometimes hug a stranger out of respect. This is great. Yeah, I love. No, really, when I have Latina patients, it is easy to communicate, and hug is super. Yeah, handshaking can help also have different meaning according to the culture. Most Americans use it as a sign of a greeting and welcoming someone. Chinese often use handshakes to greet to Western, but consider any other form of physical contact inappropriate. Arabs and other Muslims will shake their right hand, and using their left hand is considered uncivilized and a harsh social insult. Facial expression can be pretty hard to interpret when communication in a cross-cultural setting. There are 6 universal accepted facial expressions: praise, joy, sorrow, anger, fear, surprise, and disgust. Different cultures have different norms that define these expressions. For example, smiling may be expression of happiness in American culture, but some Chinese may smile when they are discussing something sad. We have somebody from China or Japan? No. The Chinese patients, they are very nice patients, but it is extremely hard to deal with them. But the good thing, they pay good. Yeah, really. So I love Chinese patients, but we cannot talk very well with them. Yes, but they are very nice, but you don't understand if there is a reaction. The specialist of Chinese is Dr. Tamara, mashallah, yeah. Yeah, she loves Chinese community because she's near Chinese community here. Yeah. So we don't know if he understands you or not, but he has some ideas in head. He wants to do it and finish. Japanese often hide their sorrows by using a smile, and smiling too much can be linked to shallow person in Korean culture. Similarly, crying is often suppressed in public by most cultures, but Greek and Italians people don't hesitate in showing their emotions and even exaggerate them like Arabs. Eye contact, we talked about that before, can also be linked to variety of emotions in various cultures. White Americans make direct eye contact with the communicator to show that they are actively listening, while if the speaker is making eye contact with the listener, he may be interpreted as hostile or angry. In Chinese and Japanese cultures, making direct contact is a sign of showing disrespect to others. So we don't need to make eye to eye with the Chinese. Indians often stare at the floors while communicating with the healthcare professionals, while the Arabs and Latinos are expecting an authoritative person like the doctor to establish eye contact. Yes. You agree with me with this? For the Arab, there is really respect for health providers in Arabic communities. You know that. So the patient will not look at you like that. You have to do that in opposite. This is what I was surprised when I wrote this, really, that it means in Japan, it means money, this sign in Japan. But yeah, in America, it is okay. Yes, very good. In Japan, it is money. many Europeans believe that it is 0. So you cannot use your hands with cultures you don't know what's the meaning of what you are doing as you are used in your own culture. How to sit. This is very sensitive in Arabic culture. Very sensitive. You agree with me? Yeah, if I sit like that, it is disrespect, but it is very normal in Europe and America. Yeah, can also convey powerful meaning while communicating, and like other forms, its meaning high variable. Slouching is considered disrespectful in Taiwan culture, while most Americans think that standing with hands on the hips suggests power or pride. Sitting with foot resting on the opposite knee is strongly discouraged in Arab countries. Time. Time. It is the really problem. Yeah, I missed. Yeah, when I was in Europe to start to work, and when we meet with the director in the department, he mentioned 5 or 6 answers why patients say that they are late, and they were talking about immigrants. I missed the bus, my daughter is crying, my baby is ill, something like that. So it is like culture, they are always late, and this is bad. So, sorry, I am late. Time is also very important and often underrated form of nonverbal communication. Patients of different cultures have strictly different ideas about time and its use. American culture, punctuality is a virtue and is linked to a person who is well managed and civilized. But many Americans may find it surprising that punctuality is not that big deal in other cultures, and some cultures even consider it as rude. Latino America arrive late for appointment and consider it as a sign of respect, but Germans consider it lateness inappropriate and sign of laziness. You agree on this point? When you are a health provider and you are waiting for your patient and your patient come late 25 minutes and he doesn't care about this time, it feels bad. Really, it feels bad. Yeah, it is not good. That's it. Obstacle. So, doctor-related obstacle and educate training in effectiveness and communication, lacking of empathy, and willing to recognize the autonomy and just behavior, affected by emotional factors. Yeah, doctor has some issues, so he cannot communicate very well, distracted due to the external and internal factors, emotional burnout, patient-related obstacles, affected with a severe life-threatening illness, extremely anxious, embarrassed or denial, confused by medical complex terminologies, reluctant to ask questions. Okay. Now I will talk about the 3 cases, I think, and then I finish. I talk too much today, right? No reaction means everybody sleeps. Yeah. So Laila is a 26 years old female from Afghanistan, presented to gynecology clinic in East Lansing, Michigan. She's deep into her second trimester and all vitals are normal. Scans conducted to the fetus revealed that it's a boy, but afflicted with severe encephalocele. Laila has 2 children, both girls. In this case, the physician needs to understand the importance of the male child in conservative Muslim families. If the information is revealed directly to the mother, she might go in shock, thinking that her chance to give birth to a boy is lost. You agree with me? Nobody agree with me, only 2, 3. Yeah, for us, yeah, my cousin, for example, he had 6 girls and then just continue to give birth until he has boys. So it is like that. Yeah, it is like that. We need male in our families. Yeah, and this, I think not every Western or American health provider knows that. So the physician must not reveal the gender of the fetus and should preferably reveal the conditions of the fetus to Layla's husband. He should not say that it is boy. Yeah. Case number 2. 27 years old Muslim doctoral student visits an ENT specialist in Bradford, UK. His complaint is having oral sores from 3 days and is not eating due to it. He has problem with the mouth. The doctor examines him and tells him that he has deficiency in vitamin C, recommends him supplements and mouthwash. I don't know if everybody knows or not, but there is some more mouthwash contains alcohol, and this is haram in Islam. So we cannot give him mouthwash contains alcohol. Yeah, so we need to give him non-alcoholic antiseptic and mouthwash. So Monica, 31-year-old Jewish woman from Long Island. She is married and has 2 children. Her husband works at a local grocery store and they are economically unstable. Monica understands that they can't afford any more children. Her husband is reluctant in wearing protection and she is fearful of getting pregnant again. She is consulting as gynecologist about her concern. Of course, when I'm talking about Jewish, they are also conservative. They want more children. They want big families. This is the traditions of the Jewish religion, or I don't know the culture. Yeah, I am from Gaza, so I know how it is in Israel. In this case, her gynecologist can easily suggest an alternative birth control method to Monica, but she must advise her on taking her husband into confidence. It's better that she invites Monica and her husband to her clinic and tell them of the situation without revealing Monica's concern to her husband. It is like by secret way, she will not tell her husband because her husband will not accept that. He wants more children. So doctor should meet the couple, to talk about that. Monica's concern to her husband. In this way, her husband might understand the words of the physician and their relationship will not be affected. So thank you. I talk too much. My name is Ali, and I hope I give something new to you. Thank you. Oh, thank you very much. Thank you very much. I showed the camera here. Me? Thank you. Make again photo. Why one photo only?
Thank you. Our next speaker, she is not able to come today physical, so she will do the presentation online. We have Ms. Roa Aman. She is a nurse specialist in Irada Mental Health, Dammam, Saudi Arabia. She will tell us about enhancing nurses' knowledge and skills in COVID-19 through learning need assessment.
Assalamu alaikum.
Alaikum salam.
Can you open just for me the share screen to?
Echo is there, Ms. Roa?
Because I am in the 2. Just now. Just 1 minute.
1 second, Ms. Roa, we are fixing the screen.
Can you please check?
Check it's not on the screen.
Can be now because share screen is still we have it. So we share screen.
Sorry, everyone. Due to technical issue, we'll invite Ms. Anit Van Jenkel. She is from Princess Noura University, Riyadh. She will tell us about healthcare worker wellness. How safe is our patients? Welcome. Sorry, Ms. Roa, we'll fix the connections and we'll come back to you.
Okay.
Good morning. Dr. Ali, you speak my language. I'm also looking at patients and communication. I am working as a nurse for 37 years. 37 years.
Don't say 37 years.
No, bad.
3.5 say something like
3.5,
yeah.
But I'm 26 years old, halas.
Yeah.
I'm healthy.
Yeah.
So for many more years, I worked in critical care units. At this moment, I'm working in pediatric ICU. And you know, pediatrics are different. You need to speak the language. 3 years ago, actually nearly 4 years ago, I had the opportunity to have my 25-year-old son who died of cancer. So for me, it was hard because now I am a critical care nurse. I am well equipped to do whatever I need to do. And now I'm a mummy. And yeah, it's hard. It's absolutely hard to see your child pass on, and healthcare workers don't talk to us. The first doctor who did his scopes and everything talked to my son after he got conscious sedation. Nice. And you know that we work with him. He ignores me for the whole time, and he misdiagnosed my son. So that was hard because how dare you? It's not that you did it for me for free. I paid you to do this. So yeah, that is my story. So after that, my life changed and I started to be a health and wellness coach, transformation coach, diabetic educator, and I'm changing my whole career. At my age, and you know what, I'm so blessed. I still think about my son, but I don't think about he died. Actually, he gave me a new life, and he wants to see me where I am. And I am grateful. I'm here from the 9th, so of course, I don't know if you know where I'm from. Most people can't say, because I'm from not China though, from Russia, Bosnia. Yeah.
I just heard it. South Africa.
I'm from South African. I'm a South African. And I'm called the crazy South African because I do things that is Malahi, you know? And I am married to Egyptian. So now you know. We're both Africans. Don't tell that to an Egyptian. I'm not an African, I'm Egyptian. I'm not an Arab, I'm Egyptian. So now I learned, and he's a list person. I'm not a list person. I am actually all over the world.
No.
I'm globally. What is very nice for me is to engage with people. It's so nice. Is there any Filipinos here? Yes. Okay. What does it mean?
Yeah, a lot.
It's rude. Tell it to Arab. Shoya. So it's rude, sir. If you are a Filipino from Philippines, I don't talk about Arab because if you go to other countries, you're actually westernized. I can work anywhere. Dubai, you are very lucky because people speak English, not in Saudi.
Yes.
The old aunties say, yalla. Excuse me, it's 10 o'clock. You need to get out of bed. We need to do things. For me, it's, yalla, I'm older than you. You're doing this to me. It's rude. But the way you speak to your patient and their family is so important. But I want to come back to my son. He went for his last MRI and CT scans. So for 24 hours, he didn't have his morphine, he's terminal. So when I talk to the nurse and say, yeah, my child says he didn't get morphine. Yeah, he's not per mouth. Oops. Tell me, you're a pharmacist, huh? Do you get morphine IV? Do you get patches? So why didn't you give him? Why didn't you give him what he needs? He's dying. Let him die at peace.
1 second, please. You don't have presentation?
Yeah, she's so busy.
Yeah.
It's coming, Yalla, it's coming.
Yeah, I prefer that you go and we see your presentation.
It's coming. No, that is not part.
Yeah.
Okay, now you must just.
Okay.
Yeah, they had a little bit of a clinch.
That's not your presentation, right?
No. So it's very important that we talk to our patients.
Yeah.
Healthcare workers, is our patient safe? Do you think your patient is safe? How we contact them, how do we speak to them? It's easy to say, yalla, come. It's a bit slower in the Middle East. People are much slower. If you're from a Western country, whatever, come, yalla, let us do things. It doesn't work like that. Take it slower. I learned to be slower. It's not easy. It's not in my personality. So everything must be fast. There. Share the screen. So that is why, Dr. Ali, I enjoyed your presentation.
Thank you.
Because sometimes you just need to look at your patient and see how they are reacting. In pediatrics, it's more difficult because you're working with parents. And parents can give you a hard time. But I always have stickers and I give to these children. If you hurt that child, you give stickers to them. I bribe them with chocolates. I like that idea of the sugar-free chocolates or ice creams because you need to show the mother and the father that you are care. You care. Right? It's not going. It's not going. So, what do you think is a patient? Dr. Ali said that. Is somebody that goes to a healthcare provider for some treatment, diagnosis, and some advice. That is what they come to us. Yeah. They don't like us. So who wants to go to the hospital? Not all of us. Okay. Healthcare workers is a professional that are licensed to do a certain thing. I can't say I am a pharmacist. I'm not licensed to do a pharmacist. I'm a nurse. That I can do. I'm busy doing a course in wellness. They'll ask a lot about nutrition. What do I know about nutrition? But I'm learning. So hopefully one day I will be well knowledgeable. The role of the healthcare worker is to prevent and treat common health conditions. They guide patients in treatment options, recommend treatment according to disease and symptoms. There's one thing that I learned. You can't force people to do things. If they say no, they say no. You can't change them. You can give advice. There is where social workers comes in. It helps. It helps you to get through to the patients because they've got other abilities. Not that they can do the same as a psychologist. Safety goals. I need to talk about, because we talk about patient safety. Identify patients correctly. The patient is not the COVID patient. The patient is not the patient who had a cabbage. They've got a name. Do you know how many Mohammeds there are? Do you know how many Adels are there? Plenty. So make sure that you've got the right patient. They must always be identified. And in Saudi, it's Abu or Mama. Mama Yosef. The baby's name is Yosef. Mama of Yosef. Baba of Yosef. Always remember to acknowledge them. And you learn it very quickly if you work with pediatrics. Goal 2, improve effective communication. I'm not going to go into that because we learned a little bit about that. Goal 3, high alert medications. There's the pharmacist. You can't just give medications. You need to be knowledgeable. And unfortunately for the pharmacist, I will ask you a question. If I don't know, we all know that we've got Lexicon. I don't know if they have Lexicon in Dubai, but in Saudi, we've got Lexicon. If you are not sure, ask. And you know what? Everybody's on Google. Google. If you don't know what's the action of the working of the medication, Google. There's so many names. I think, what is this? It sounds like this. It sounds like that. Make sure you know about the medication and check. I'm working in ICU. I check. The thing is, I'm not very much mathematical. I can take an ampule and I can work it out, but don't give me a calculator. But always make sure your patient needs to be safe. Ensure safe surgery. Now, you are the dentist. Maybe you take a wrong tooth out. I will sue you. It's my tooth, son. Or you do take one wrong kidney out, or amputate a wrong leg. That is why it's so nice you get time out. Stop, everybody. Is our equipment correct? This is the patient's identification. What medication did you get? Is all our equipment ready? Before you do an incision, before you do the procedure, you go again with the whole thing. It just makes everybody aware. And sometimes in different countries, but I must say in Saudi, inshallah, it's okay. Stop, everybody, let us go. In my country, yalla, yalla, come. Let us finish this. Why do you need to run? Why do we need to do 12 operations in one day? Cabbages, 6 in one day. Yeah, it's too much. And this is what's happening. And then mistakes can happen. Goal 5 is reduce the risk of healthcare-associated infections. We all know we did competencies regarding putting up central lines, putting up a catheter, mixing medication, but we get so laxed. We don't follow the best practices. And it's so easy, then people putting up IV lines. It drives me nuts because you need to have a little bit of aseptic technique. And then you see, you put this and put this, you put all over. You don't even change your gloves. You don't even clean the area correctly. So then we want to know why people get infections. I promise you, if I've got an infection because of your not doing what the best practices says, I might sue you. And it's starting to happening into the Middle East that you get sued or you're getting legislation and all those things. And you know what? It's okay. Because I need to do every time the same. If you do it every day, it's fine. But if you take shortcuts, it's a problem. Reduce the risk of patients' harm resulting from faults. Tell your patients, I'm giving you a narcotic. I'm putting up the cot sides. I'm putting the bed low. Here is your bell. When is people falling the most? When they want to go to the bathroom. So we don't help them. You lie there, now they're too scared. Can I ask for help? An elderly person, especially a male, and it's a young female, they don't want you to do things because it's seen as I'm weak. You're allowed to be weak. Healthcare workers in the COVID area. So what is happening is I ask questions from different countries, not only Saudi, not only South Africa. And I ask questions like, what was it like during COVID? How did you feel as a healthcare worker? How did it impact you? How did you feel? And what did you do then? What was your best strength? And did you use your best strength to combat this hardship? Remember, with COVID, a lot of things happened. And that is my question. Is your patient safe? Because you get through a lot of things now. So the answers that I've got, what was it like COVID? People say it's an insane period. I was just stuck on a ship for 4 months. You're isolated. You're scared. You don't get paid. And it's just COVID. Remember the first time when COVID, February last year, I think. Yes. All of us were scared. We were locked down in places that you don't want to be locked down. You can't get hold of your family. Your family are scared of you.
Me and my wife, yeah.
Yeah, because you...
It was extremely scary, yeah, 24 hours, me and my wife.
Yeah, and that, I think she was more scared of you because, wallahi, it was a lonely fight. What if I am the one who actually spreading the disease? How few were scared? They were actually washed with heavy scrub in the hospital and go out with other clothes. Is that not what happened? We were scared. We were very, very scared. I was locked down in South Africa, and now I'm scared. I've got a contract in Saudi Arabia. What am I going to do? Yes, I did some contract work there to prepare them for COVID, but my work is this side. And also, it's locked down. You can't go. You need a permit to go anywhere. So, yeah. It was daunting and devastating. I contracted the virus 2 times. I'm scared I'm going to die. Is that not true? Yeah, because in the beginning, everybody's dying. Now, what we see now is younger people is getting it. And a lot of people say, I actually only have like a hot flash symptoms because we're vaccinated.
Sorry, you had COVID?
No, it's answers. It's answers. No, I'm very good. Alhamdulillah. Scary hospital, forever busy, fearful of contracting the virus. We are lucky. The hospital where I work, yeah, we were busy. But there's other hospitals with 50 positive people. Maybe you've got 15 staff members. How do you do it? How do you do it? You get tired, your immune goes down, you don't eat, you don't drink, you don't rest. And don't put me on nights. You will kill me. So what's going to happen? Your immunity goes down. Mentally, I get really cuckoos. Cuckoos means monsnoons, huh? It's stressful and unpredictable. I moved to a new country. I don't know the people. The first day when I go to Dubai here on the 9th, I was lost. I started a little bit of panicking. And I need to say to me, stop. You're a grown person. See what you can do. So now in a new country, you don't know what's happening. You don't know the processes. And you need to cope. How did it impact you? They feel that I'm the healthcare worker. I need to be strong. I cannot show my emotions. We are social human beings. We must show our emotions. My husband must be strong. He doesn't want to tell his problems to nobody, but I can sense when there is something bothering him, but I don't dare to ask him. He will tell me it's time. So if you're a man and you show your vulnerability, it's bad. It's seen as you're not strong enough. We're always scared. The Westerns or the Greeks, no, they can cry if they want to. I need to motivate my staff. Some people isolate themselves. They don't go shopping. They don't go out. They're in this little small room. And they're getting depressed. How many of people that you know who commit suicide? Mental illnesses regarding COVID. And they are fearful, they're depressed, terrified, and they are fearful to losing a family member. Some people, they need to get out. I'm a go-getter. I need to get out. If you want to put me in a small little room, you will kill me. I need to get out. Yes, I don't go in groups, but there's other places to go. And then, of course, my family. What did you do then? Some people go a meditation, but some people, you can't even go to gyms, so you can't do that exercises. And in Saudi and in Dubai time, summer you can't breathe. You need to be indoors. Now everybody goes out because it's cooler and we enjoy it. Some people are studying, some people are writing a journal, and then some people are talking to their family. There's one thing about what COVID did is we're doing things virtually. Imagine you couldn't see your family member. I want to see that you don't lie to me, that you actually are fine. We sometimes pretend. If you're an expat, you pretend. You don't want your family to worry about you. You don't want your patients to see that you're also worried. And then people pray, you try to be positive. Some people says, what is your best strength? I'm a leader. I'm able to motivate others. I'm a perfectionist. Now, perfectionist, I don't always think it's a good thing because you put so much stress on yourself. Huh? You don't give yourself time to feel vulnerable. I need to be perfect. You cannot be perfect. People are supportive. Some people are able to bounce back. And then some people are patient. Just wait. And I think some cultures, they are patient. They can say, okay, inshallah, it's fine. You know, if people say to me, inshallah, I said, yeah, it's not going to happen. If they say harder to me, I said, okay, it will happen. And then one doctor from Syria says to me, Anne, do you know what inshallah means? I said, yes, I do know. But it means that you're not going to do it now. And sometimes, you know, they know me because I sometimes say things very quickly. For me, I'm a positive person and I'm grateful for the opportunities I get. And it's not easy. I get also down maybe for 2-3 days and then I bounce back. Did you use your strength? Yes, some people said, you know what, I learned new skills. I learned to be more tolerable. I learned to cope. When my son heard that he can't come and visit here because of the lockdown, he says, Mom, it is what it is. 26 years old and this is what you say to me? And I was surprised because he learned there's nothing we can do. Yeah, I could tantrum, I could shout, and I could actually be nasty to my patients. It's not their fault. They've got the same fears, no? Okay, so the emotions our patients and healthcare workers has: fear of dying, lonely, helplessness, worry, discomfort, and isolated. Our patients, remember the time when everybody looks like moon people. You get into your patient, you go in and you go out. You don't have time to communicate to your patients, isn't it? You go in, you go out. And sometimes you need to talk to them. Sometimes you need to say to them a little bit longer. It will be fine. I want you to do this. I want, explain to them. But then the healthcare worker, we're anxious. What if I go into the patient's room and I contract it? They also stress, fearful, helplessness, worry. Who of you couldn't sleep? No, you were anxious because you're going to have a fun days, huh? So, but in COVID time, there's a lot of people that have insomnia. Sorry. Headaches, discomfort, and exhausted. You can't think clearly if you're exhausted. You can't. How many mistakes did you make? And nobody knows at that stage what COVID is doing. How does it look? How many mutations did COVID have? So what we see is that previously the elderly and the older people with comorbidities got COVID. Now it's more younger people. It's not so much the older people. So the question is your patient safe? What is your patient's safety needs? Did you know that your patient has needs? They don't, when I was younger, they say the patient don't need the most expensive equipment and everything. They need to be heard. They need to be heard. They need to be, people need to respect them and their decisions. They need a clean room. They need food and a TV. Not TV so much anymore because everybody's got a phone. And they're watching all types of movies and everything. So they don't want us to do any harm. They don't want us to do any diagnostic errors, medication errors, injuries, or any preventable harm. Talk to your patients. Tell them exactly what's happening. If we talk about communication, and like in Saudi Arabia, most of the people are speaking in Arabic. And did you know how many dialects of Arabic are there? The South don't understand the West. The West don't understand the North. And now, how do you want me to understand you? You can't understand them. You think, oh, wallahi. So translation. You know the translator app on your phone? It helps. But sometimes you can giggle too, because it tells totally different things. And the patients, especially with kids, you come, yalla mama, yalla, come. Let us do the translation. And together, we try to find out what we want to say. In our hospital, we don't have translators. And sometimes it's difficult, but if you have a translator, make sure it's a translator that tells the truth. Because sometimes you'll think, what I said is not what came out. And it can be different. Especially you're a pharmacist, you tell this person, drink this medication and finish the whole course. Okay, I'll drink all today. Is that what's happening? And don't be hard on your patients. If they don't understand, show them that you want to help them. For me, I communicate easy. Sign language and sit with them and try to explain to them things actually goes far. And don't be too quick because they can't understand you.
Sorry. So you work in hospital here?
Yeah.
And you don't speak Arabic? No.
Sure, yeah.
Yeah, but you say you need a translator, but you cannot find a translator.
No, we don't have translators.
Yes.
But we do communicate because there's certain things that I can speak. But if you go deep in, it's a little bit difficult. And where I am, the doctors are so helpful. They are really, yalla, come. Yeah. I want to say this.
Yeah.
And it's difficult, but people tend to accommodate you if you take the first step. And sign language. Be kind. Sit with them and talk softly. Use simple words. And I do speak Arabic, but not much, because it's difficult. I and an A and an R, really? And at least they can say because we can say don't say it to Filipino because they can't do the they say Philippines. It's Philippines. So, but it's difficult. But we do get, and with children, it's easy to communicate to your child because you play and you sing and you dance. Yeah, and put them at the center. Oh, okay, roadmap. A roadmap to patient safety is encourage your staff to incident reporting. Are we doing that? Or we see it's as punitive? It's very difficult to say to people, please report a safety event. Oh no, but people will think I'm doing the wrong thing. No, how can I make sure my patient are safe if I don't report it? There's not consumables. There is not medication because it's out of stock. Maybe inshallah it will come by shipment or whatever. It happens. Implement and monitor improvements. So so we've got a patient experience project in our unit. How am I going to know that we do a good job? Get feedback. So what I'm working very closely towards the patient's experience people, let them go in, let them go and talk to the family. Because maybe my personality is all over the world and they might see it as rude or I shout. I don't shout. I'm a very dramatic person. And you talk and I show my feelings. And maybe the patient won't see it like this because it's different culture. Use your patient input. Never see the input as a threat because you can only make it better. Foster down culture of safety. So you want me to do something. We've got a policy to say certain things. Medication must be, start medication must be with a patient within half an hour. Yes, sure. But did you buy that medication? How many times do you have medication in your hospital? And they say to you, no, the people who are buying it must still buy it. But you made a policy from top management, you said it must be there within half an hour. Excuse me, where is it? Some pharmacists must go to other hospitals to get narcotics because it's not available. So the safety culture must come from top. Make sure that the people on the ground floor actually has it. Increase safety culture of healthcare professional. Make sure that they do the correct things. How many times do you have needle stick injuries? But your sharpens is actually not of a good quality. That is not a safe practice for your healthcare professional. And also, we take shortcuts. Nurses take shortcuts. That is a fact. The doctors don't take the shortcut because they don't do it. They just say, yalla, I put a prescription there, go and shoot on track care. We are taking the shortcuts. Huh? Monitor points along the care continuum. I believe in stats. I want to see how we're doing. So in my hospital where I work, there is not a lot of audits. Where I come from these audits, how can I say that you have 89% compliance towards safety for your patient if I can't measure it? You need to measure it, and it must be visible. Why can't the patient not ask, what is your healthcare associated infection rate in this unit? Why can't they ask? They Google it. So be open to your patients and say, you know what, we're working towards it. It's a very good question that you ask. We're working towards it. We had this and it's actually like this. Now, not everybody is not literate. In my hospital where I work, 60 to 80,000 female students. Imagine, they all go to university and their families and everybody comes to us. So it's not people that are not literate or cannot know about certain things, but we need to explain to them. And then Team communication, like Dr. Ali said. I can't put you down in front of patients. I can't even put you down to my other colleagues. What did I do to make you better? And that is the thing. I see a lot of bullying in the healthcare facility because we don't want to see other people excel. And this is the truth. This is what's happening. How do we measure patient satisfaction? Online surveys. Let them speak and tell them, we want your input. Results are shown on a dashboard and real time, and we as healthcare workers must attend to it. Have an action plan. Make sure everybody is aware that how does the patient feels. And everybody knows about KPIs. Don't do the KPIs on the board and forget about it. Work towards it, because you know, if it's Magnet and JCI and Sabahi, oh, everybody is printing. Everybody is doing also this showcasing. But what is happening back at the ranch? Are we actually putting patient safety first? Or do we want to do that? It must look very, very, very good. And back in my country, I'm an auditor. So you can't showcase. I know exactly where to look at, even if I'm in a different hospital. Employee satisfaction. This is a big thing now. You know that you can't get Magnet if you don't have employee satisfaction. How many of your staff members are safe, are satisfied? And if your staff are not satisfied, your patients won't be satisfied. Actively listen to their concerns. And you need to have a wellness program. How many of your hospitals has a wellness program? With COVID, it's there at the back. It's there at the back because everybody's just talking COVID. They don't talk about the wellness of our patients and also their families and the staff. People are scared. There's people who didn't even go home for 2 years. They didn't see their families. They didn't interact with their people. They had families who died that you can't even go home to bury them. I remember one doctor who worked with us. His dad died and he's from Egypt. You know, you bury your family members that same day. He couldn't be, and he's the only son. He couldn't be with his family. How does you feel? Who gave him support? No, you must just work. Is that not what's happening? How can we ensure patient safety? We must have a program and a system, build a rapid response team. We've got the adult ones, and then we've got the pediatric ones. And that is before your patient is declared a code. You can actually see certain things. And I see with us, we get less codes now. In Ramadan time, what's happening? You get code blue, code purple. What is happening? People are fainting. That's not a code blue. They faint because they're fasting and they didn't eat. Also, make sure that the employees know and understand the safety policies. Develop a safety compliance plan and practice patient-centered care. I am so privileged. Where I worked, we've got a round every day with a consultant, with the RT, with whoever cares, who is supposed to be in that round. And the consultant always go to the patient's family, sit with them, explain. That is where we talk about explain in the same culture, also the same language, and we just go on and talk about that. And what our doctors does, when they go out, I say, doctor, excuse me? And they know what I want to say. What did you say to the family? Because I just carry on with the same message. Our patients are happy. Our children are happy because we communicate continuously to them. And with that system, there's always a doctor in the unit with us. They will come and say, Yella, we want to speak to the doctor. Call the doctor. Don't say, oh no, the doctor is not here. They want to speak to the doctor. Halas, let them speak to the doctor. and communicate the whole time with them. Communicate safety information to patients. I must tell you, I'm very forward. So we had audits doing before we came to do JCI. So I taught the mothers, every person come into your room, you say to them, yalla, PPEs, and wash your hands. So when the auditors go into their rooms, they say, yalla. They did that. Give the parents or the patients some authority and say, you are not coming to my room without the PPEs, without washing your hands. And the mummies were very proud because they're telling everybody, including the doctors. And they say to me, Yalla, you told me I must do that. Come, wash your hands. And this is what they want to see. They want to see that we do the extra mile for them. Sorry. Incorporate safe hospital design. How many of your hospitals are old and they are not equipped to psychiatric patients? Can you put them in a normal ward? No, they will commit suicide. Bipolar patients, I don't know a lot about psychiatry. I know about wellness, but not psychiatry. If you put me with a bipolar patient or schizophrenic, I don't know what to do. I won't know what to do because how do you keep them safe? Patient safety to be the utmost priority where you're working. So there must be policies and procedures. Follow it and make sure the policies and procedures are talking to the best practices and what is happening. Invest time in safety and make sure that you've got input and say, you know what, this is a big problem for us. We need to walk towards it. Identify risks and hazards. Culture measurements, prioritize safety and get feedback, and then work for support. Look after your staff. Give them the tools to do their job. There's one thing that I hate. I don't want to struggle. I don't want to work with a very sick patient. Then I must look for PPEs. I must look for medication. I must look for whatever you need. I want it available. I don't want to look. My patient is sick. That is my first priority. And then the patient and family involvement. Ask them what they want to do. There's one thing that we did in our hospital. It's time consuming, but it works. We have a little board. My name is on the board. The doctor's name is on the board. The diagnosis is on the board. Your precautions is on the board. And I put my goals in, but the family member, the patient, or the parents are putting their goals. Today, I want to walk. Today, I want to be from high flow to a simple face mask. That is their goal. Not my goal, that's their goal. And if they achieve it, it's great for them. And yeah, it's new in our hospital and it works, but we sometimes do forget to fill it in. Roles and responsibilities, I'm not going to talk about that because it was said. Patients need to be truthful. If they are not truthful, your management plan and treatment plan might not be the same. And our as healthcare workers safety, do what the OC health, wear your PPEs, dispose of your shops correctly. Violence, bullying, also burnout, and mental problems. Mental illness is seen as a problem, as a weakness. You want to tell me today I'm feeling every day the same? I'm always walking, I'm always working, but there might be one day that I said, Khalas, carry on, do whatever you want. That day I'm useless. Why? Why can you not be? You're just a human. And then that the same shift works. Not everybody works shifts. The doctors here, if you are a consultant, if you are, sometimes you're working like 24 hours. You are also tired. You're also a human being. You also need to eat. You also need to sleep. Protect health workers from physical and biological hazards. That's what I also said. It's very important that we look after ourselves, because if you don't look after yourself, you can't look after your patient. The summary. Patient and healthcare worker safety are of the utmost importance. That must be your first. If you don't look after yourself, you can't look after a patient. Sometimes time out. I normally don't take lunchtime so much, but do you think it's actually wrong? It's wrong not to take time out, to take a cup of coffee. There's one thing about Arab people. They love coffee. They are walking so slow, and they're the missus. In my language, we say they're the missus, the madam. Walking with that cup of coffee on their time, inshallah. But sometimes we as Westerners must also do that. Zip your mouth and switch off. Breathe, even if it's just for 10 minutes. Then you can work again. You can do things again. But we tend to just run around, especially with your personality. Surveys regarding patient-employee satisfactions are valuable. We can make a difference. Safety event reporting systems needs to be used, and transparency is of utmost importance and must be used not as a punitive, but is a way to see patients important and also the patient and staff safety. Safety hurdles important, and awareness regarding patient safety must be part and daily running of healthcare. I only learned about safety hurdles in Saudi Arabia. Do we do it in other countries? No. I put in a lot of safety events, but we don't talk about it. So the manager get the report, must answer, but it's not taken back to the people on the ground floor to say, you know what, this is our problem, this is what's happened. And all of us can actually make it better. Patient-centered care ensures patients' compliance and safety, and healthcare workers' mental and physical well-being are important. Support needs to be provided to them. There's one program, Amsterdam, New Amsterdam. What is that guy always saying? The people are kiri the whole time. And he says, stop, stop, stop. I hear what you say. What can I do for you? It goes a long way. What can I do for you? Okay, now you're not shouting anymore. Okay, he is actually listening to me. One does not improve patient safety without involving your patients. You need your patients' input and embrace that. So that's all from me today. Thank you. Yeah,
we can receive certificate and run away.
Let me give her the certificate first. Thank you.
Thanks a lot. Thank you.
I think it's interesting to talk with you about the subjectory. There is no time or what?
Yes,
Yeah.
We can discuss. Then we can go to coffee break for 10.
Can I talk?
No, I wanted to say something about the public health while this corona, the Western public health, which failed really to deal with corona. So when you say that you are Western, you're working hard while there is Arabic there taking the coffee, this is not true. I'm sorry. We all failed to face this corona, and we couldn't manage that. And until now, we don't know really about the safety. Why didn't appear this before 10 years or 15 years?
Yes.
Okay. Now, everybody says you have to wash your hands. Okay, before it was doctor only need to wash his hands. Now, to wash your hands, it will protect you from COVID-19.
But what about the other diseases?
Yeah. Yes. So we don't know. We have to work hard, everybody. I want just to comment about you in Saudi Arabia. If I work in Sweden, I cannot talk Arabic with my Swedish patients.
No.
You have to learn Arabic.
It's very difficult.
Correct?
But I do.
Yes.
But it's not fluently. It's difficult.
This is what I want to tell you. So by that way, you will provide the best health services. The best, believe me, you are, as you said, Western, with very good education. You speak their language. You are confident with yourself. You will take your cafe and you will walk like Arabs also.
Well, you know what? There's one thing I learned about the Arabs. You know, they're so calm.
Not always.
No. I tell you why.
You don't feel confident because you don't understand what's going on around you. They know what's going around them, so they take their coffee, they go around. This is how there's confidence. You agree with me?
It's also personalities.
Personality.
Yeah, personalities.
Yes, personality.
Yes.
Pascal?
Yeah, beautiful presentation.
Yeah.
So in the United States, you know, as nurses, our suicide rate has increased compared to the general public. Also, you know, the nurses have compassion fatigue, burnout, they're emotionally drained. Have you seen that in Saudi Arabia or in other parts of the country?
Yes. If I talk in South Africa, it's very evident because we talk. We are talkers. What I see in Saudi, if you talk to a Filipino, you know that their culture is you always need to smile. Doesn't matter if you are drowning. That's true. And they will never see if something is a problem. But if they trust you, they say, my flight is cancelled again. And then you need to really support them. Even if you are staying in Saudi, you have family in Saudi, they are scared. I don't know about suicide really in Saudi because it's haram. Yeah. And also you don't hear about it. But yeah, there is a lot of mental illness. There is a lot of depression. And it's true. This is what's happening. But what I want to say about, I've got my best friend is from Gaza. Excuse me. Maha is Jordanian, but she's also Palestinian. And it's so easy to talk to her because she's my friend. I feel safe. With my husband, I feel safe because we can talk about anything. And he's this calm engineer. And I am this Wallahi person. And this is yours. And I've got a Filipino. If she does this to me, I know I must tone down. Because not everybody understands your spirit. Because I can work the whole day. I don't need to stop. But I learned to go to other people and say, calm. Inshallah, it's fine. Don't stress. Have a cup of coffee. And your patience, this is one thing, then I will go and sit. I learned something in my years of working. Patience, it's okay if you want to drink coffee or you want to eat. Finish, I gave you medication. Are you okay? Do you need anything from me? Okay, Mom, I want to eat. Akil, Mama, can I eat? Yes. Okay, I've got somebody here. Here's your bell. Call me if you need me. Khalas. When you go back, you say, I'm back. You need to do it, but you also need to be a little bit softer to yourself. Khalas. Thank you.
Thank you. Thank you. We can go to a coffee break for 10 minutes, okay? Then we can continue. Thank you.
We continue the presentation. We will, you can just stop it from here. Your presentation you have sent it, I think.
That was before I redid some stuff last night. So
you can.
Yeah, I'd like to use the new one because I made it a little smoother and I think I can be able to go faster.
Make care. Sorry. Oh, you will take picture. Yeah. Yes.
Ask them to provide something on that so that I can attach my if it is possible.
معانا ناخد صورة حلوة بصراحة. Go back to that position. That's fine.
Traveling to this.
Yeah. Doctor, she doesn't want me to take photo. Yeah. Well, she doesn't. Thank you.
We just want to fix something in the laptop.
Yeah.
Presentation in the big too.
So I will do that. Or else you can actually.
Yes.
Somebody says something from here.
area of the hospital that you work in or in healthcare, there are patient safety bundles that are available in every area. So please, I stress the importance. I'm going to show you the beauty of an obstetric bundle and how I've implemented and used them, and to take this back to your facilities as well. So basically on obstetric bundles, we're going to be focusing on the leading causes, preventable causes actually, for maternal morbidity and mortality. That's a postpartum hemorrhages, severe hypertension, and venous thromboembolism. Today, I'm just going to focus basically just on the postpartum hemorrhage. Hemorrhage is still the #1 leading cause of maternal morbidity and mortality in obstetrics today. And I would love to have a big initiative across the world that we could just address, because we can prevent a lot of these deaths. Women in the year 2022 coming up should not be dying from childbirth. So WHO in 2017 reported about approximately 810 women dying from preventable please, causes related to pregnancy and to childbirth. It's still 94% of maternal deaths occur in developing countries, which we are in the region for. And you can see the numbers here. Roughly 295,000 women died during the year. And all of these occur in low resource and settings. So I'm going to challenge you, how can we make sure that our setting and our facilities is the safest place for our patients to be? This is the UNICEF's maternal morbidity and mortality pie chart or ratings for complications. I just wanted to show this to stress the importance once again of how hemorrhage has such a huge impact on our OB patients. The ACOG Practice Bulletin 183 from October 2017 defines a postpartum hemorrhage as greater than or equal to 1,000 ml blood loss, accompanied by signs and symptoms of hypovolemia within 24 hours after birth. I understand clearly, being an OB, of our vaginal deliveries, we will give them up to 500 before we consider it a hemorrhage. On C-sections, anything over 1,000. But I really like this all-encompassing, because the key for me on this, and I've seen it in practice, I've had 25 years clinical experience in high-risk obstetrics and women's health in the US, and I'm telling you, you do see these signs and symptoms that come later, because everybody doesn't always give you the right EVL. Once again, I just want to remind everyone the 4 T's on these are the primary. There's primary and secondary causes of PPH, but for today, we're just going to talk about the primary. Just once again, simple things we can do to prevent complications or morbidity and mortality with our moms. First is tone. 70 to 80% cases of all PPH are related to uterine atony, which we can prevent. Tissue, retained products of placental fragments, or if there's an accreta, whatever other complications there. Trauma, we have lacerations that can occur anywhere in the birth canal and cervix, and thrombosis, which we can see when we know these patients begin to bleed. They use up all their clotting factors, and then we end up going into DIC. So how can we prevent maternal deaths? We need to make sure that we have deliveries that are attended by skilled healthcare providers. That can be our physicians, that can be the midwives, and make sure that our nurses are all well trained and that we are prepared for any obstetric emergency. Make sure we have the proper equipment and supplies. Refer women in a timely fashion. If you know that your facility cannot handle a mom with quads, then you need to refer her to a regional medical center where she can have the appropriate care. And make sure if we are able to manage any complications that can occur. And you can see the list there. So when an emergency happens, it can happen anywhere in the hospital, but we know in obstetrics, time is of the essence. And we're dealing with 2 lives, not just one. So I want to challenge you today. So to initiate and look at your patient safety, look at whether you can improve your patient safety and your patient outcomes with any bundle. So what is an obstetric bundle? Just for today, please understand, I'm going to use the ACOG obstetric bundles. So that's just an example, but you can use any of the bundles that are available and cater that towards your facility's requirements. Why do we need them? Because they're evidence-based. They're processes that decrease, that have been proven in research, that the decrease in we can make a difference in mortality and morbidity. They provide guidelines with step-by-step directions. And this is what I love so much, because I love when, and I've been in this business long enough, when it all goes crazy and there's an emergency, people start running, things start flying. And I love the fact that you can just pull up an algorithm or pull up your checklist and just go down. So you can walk in at any point during an event and you can say, have we done 1, 2, 3? If you've done 1, 2, 3, then let's go to 4, 5, and 6. If you've got those done, then you keep going, working your way through the algorithm. And it just saves time. So like I said, I love the checklist, because sometimes if you rely on the human memory, in the event of an emergency, we don't always think clearly, or we will skip a step. So once again, I strongly encourage this. So if you're wondering, so these bundles sound like a great idea. Where can I find them? They are everywhere. So IHI, the Institute for Healthcare Improvement, is a wonderful place to start. AIM, which is with ACOG and A1, who has their own set of bundles, like I said, for multiple situations, and the Royal College of Obstetrics and the midwifery. So you can find them anywhere on the internet. And like I said, you pick the one that you feel would serve your facility the best. Okay, so let's take a look at what a bundle looks like. They remember that it's just defines the standard of care. There's no guess about it. You minimize variability. It makes it a very lean and very agile process. You decrease the reliability on having to remember everything in the event that every crisis happening. The emphasis is on patient safety, because that's our first and foremost thought, and reduction in redundant efforts. We want to make it streamlined. So on the obstetric hemorrhages, just remember, most of this is we need to be aware, we need to recognize, and it is preventable. So we need to do proper risk assessments during the pregnancy and throughout the entire intrapartum postpartum period. Make sure we are ready. And I will discuss with you about your blood bank and about your massive transfusion protocols. And that needs to be incorporated into your planning of how you will handle an emergency. Do you have a card and medications? And we'll review that. Make sure the team has, I believe in drills and practicing. Make sure they are ready. Make sure there's a response. We need to have those checklists. We need to have those quick references. And then we need to have our debriefing. We need to have our review of the events in a non-judgmental place where we can sit down and look at what the gaps were. And it needs to be multidisciplinary. So once again, the whole point of everything that we do is to save lives. So once again, let's just start. We need to be prepared. We need to constantly be looking and assessing and evaluating because things can change like this, especially in obstetrics and especially in labor. So prenatally, let's look at our patient. What risk factors do they have that could lead them to any complications during labor? When they're admitted to labor and delivery, the midwives and the nurses especially need to make sure they do a proper and thorough assessment of the antenatal record, the past medical record, and review and talk with the patient as well to see what all is happening at that moment with their pregnancy. That way we can begin to identify. So you can see here on the list, here's a checklist. So if you have a patient with multiple pregnancies, well, we already know that uterus is overstretched. If we know that she is a grand mal tip, as we've seen in this country, women come in, it's their 6th, 8th, 9th, 10th baby, we know those uteruses are tired. So it's just being aware, if we have macrosomia because of the diabetes, we have these big babies, we just need to just keep it foremost in our mind, she's at risk. And then you can just, as the checklist goes, then you can just check off whether she's medium risk or high risk, and then you're going to take the appropriate interventions. You're going to start preparing. Do we need to go ahead and get a type and screen, or do we need to get a type and cross? Just to be ready. And as we go through the interpartum period, she's admitted, let's go through labor. Now we need to consider and remember, keeping in mind that as these, if you've got a patient that's going to be induced, she's going to be a 2-day induction, and she's been prolonged rupture of membranes. You now are going to be set up with chorioamnionitis, and it's been 2 days. She's contracted, not making much progress. We just know, you know it's coming. So it's anticipation. So I just challenge you to anticipate. The checklist just makes everybody on the same page. So when you do your handover from one shift to the other, we all have agreed, yes, we need to be aware, anticipate, anticipate, anticipate. And then once again, we just got to do the proper interventions, making sure we've got our blood ready, if our type and screen's ready, or if you need a type and cross, depending on the risk factors. Well, here we go. Let's start. So then we're going to have a delivery. And we're going to have where they've had at least 1,000 mLs EBO after delivery. So if you don't already have an IV line in, now's a very good time to get one in. I've had the pleasure to commission 2 hospitals in the UAE in the past 7 years. I have set up in those protocols that the women will never have less than an 18 gauge when they walk in labor and delivery. I have staff want to argue with me, but it's so big and whatever. I don't care, because I have watched too many times over the course of my career that things can change on an absolute second, and then it's different, and then time is of the essence. So we will automatically put in an 18 on that first line. Then we make sure we have plenty of fluids available, because we want to start with fluid volume replacement. Remember, if they start bleeding, remember our basic anatomy. We have to keep those bladders empty so the uterus can contract, because uterine atony is the #1 reason why we're going to have these bleeds. Do our proper fundal massages, and we're going to continue through the steps. Make sure you have your medications available, and make sure that your blood bank has available in blood and that you notify them. One thing that I've learned in this country, coming from the US to here, is when you have a blood bank in your hospital, you may not have all availability of all the blood and the blood products that you may want in the event of an OB emergency. So what you have to find out is then you need to coordinate and work with your blood bank and your lab. Okay, we only have 2 units in the hospital. It always gives me a panic attack, oh my God. So if we can have at least 4 units in the hospital at all times, then you need to figure out the process. How long does it take to go from our hospital to the government hospital or what other facility that you're going to be obtaining the additional blood or blood products from, and then learn how that timing for the courier to go back and forth. You can be able to get it in 1 hour, you might not, it may take them 2 hours. So as you're planning your process and planning your safety bundle, you need to know, I may have to initiate a request for blood a little bit sooner because it's going to take, I don't have it sitting downstairs. I have to get it from across town. So just please look at the big picture of how you're going to implement it, and then you just make your processes work for what you have available at your resource. Ultimately, the whole point of all of this is to save time, save lives. So once again on here, the blood bank is very important, knowing your availability and how long it's going to take. And then we just need to find the reason and then start preparing if we need, anticipate if we need to go to the OR. Is your OR available 24/7, or is your OR, you have to call a team in from home? All of those things are going to impact your decisions as this emergency starts to unfold. And you have to think quick and move quickly. I'm not going to go into it, but once again, as you can see here, these are the medications. This is the US names. And medications that are recommended by ACOG. You can keep these in a box in the medication refrigerator, and then they're readily available as we go. Once again, I always just like to reiterate tone, tissue, trauma, and our thrombosis. I had to put this back in because anytime I do reading again and refresh and try to keep up to date, I found this so prophetic that the ACOG bulletin still says that prophylactic oxytocin, whether you give the 10 IV or whether you give 10 IM after delivery, is still the most effective medication that is with the least amount of side effects that we can give. And it's so readily available and it's so economical compared to Methergin or Carboprost, Hemabate, any of those. So the article that I was reading, or this practice bulletin, just reiterated we don't have clear research proving that if you add on, if you've started with your oxytocin, syntocin, as we say here, then if you add on Cytotec, Methergin, Hemabate, any of those, it's not going to change your outcomes much. So we need to, and when we notice that we have uterine atony, that we react, we anticipate immediately. Now, when do you give this? Well, it's debatable in the literature, whether you're going to give it as soon as you deliver the anterior shoulder, whether you're going to wait till you deliver the baby, whether you're going to wait till you deliver the placenta. I mean, it's so many debates. You have to decide in your own practice and within your facility what is acceptable. Okay, but the point is we need to be ready and just go ahead and give initially to stay on top of things. Stage 2, basically here, I'm not going to go into all the details. You guys are welcome to review this and have access to the slides. But basically here, we've continued to bleed. We have not stopped the bleeding. It's continuing to increase. We're over 1,500 mLs at this point, and it's time. So what we have to do, put in that second line. I encourage, my 18 is going to be there. So I encourage when we go to the second one, I usually suggest you can do an 18. And I'm just speaking because of my clinical experience. Well, I have been on thousands and thousands of deliveries, and I have seen so many events. And I just automatically will take it to the 16 on the next one. And the staff are like, oh, you know, they don't want to stick the patient with it. I said, I don't think at this point she's going to really care. So you're just going to go, you're going to draw your coags, get your baseline labs, and then you're just going to go ahead. Do I need to call my OR team in? Do I need to give them a heads up? You need to talk to the lab. Let them know you have someone bleeding. Where are we with the blood? And you need to start coordinating with anesthesia. You need to have great communication. And that's part of the setup of the whole team and the drills. So there you can see, and then you can add on the TXA if needed. There was a lot of great support for uterine atony. Do the medications, do the massage, keep the bladder empty. You can have the fundus can be firm, the lower uterine segment can be still boggy. That the balloons or either packing the uterus can be of great support. So I encourage you to look into that if you don't have those things available within your facility. And then here, once again, we're just going to continue about as the patient deteriorates, the bleeding is getting more severe. We're going to take her to the OR at this point. Then we need to notify the ICU if they have availability. We need to initiate a massive transfusion protocol and make sure that people know what that is in your facility. And I know you think I'm crazy, but literally, if you have these policies and have everything set up, but you really need to know, if I call you, do you know what to do in your lab? You know what your chain of events will be if I tell you I need this. And a lot of places don't. And remember, in the event of an emergency, I don't want to give a lot of details. I basically want to look at someone and say, initiate the MTP. And then there it goes. It should automatically go into play. So this needs to be practice. I do believe in the drills and getting these departments built together on this. Most people, when I've done the drills, when I do an multidisciplinary drill, most of them have never done drills, people from other countries, and they've never been involved in a team. So what's really fun is when you do it, actually do the walkthrough. Actually take that bed down to the OR, you actually make the phone calls, and you all work together. It gives a whole new perspective on the importance and the team. So I do encourage you to take the time to do that. They all want to grumble and complain about doing it, but it's worth it. You just need to do it. So the other slide just says we're going to continue to go downhill. We're going into ACLS and ICU, and that's what we're trying to prevent. Also, part of the management is not just the medications and addressing the tone, the tissue, the trauma, and making sure we can keep the coagulation under control. There are surgical managements. Uterine curettage, once again, remove those tissue fragments. Uterine artery ligation, it's done. Repair uterine rupture, we've seen those. And the B-Lynch suture, and I've actually seen that happen in Nashville, Tennessee in the US. And last resort is to actually do a hysterectomy, which is all what we want to prevent. So on this slide, I'm not going to go into the details, but I just want you to just see the massive transfusion protocols, excuse me, and how you need the steps. Set this up in your institution and practice it, like I said, with the other departments. And once again, this is just, you can use this as a checklist as you go through to check how your drill went and to check your process. One of the things, I love things to be quick and easy and efficient. So one thing I've set up in different hospitals is the obstetric hemorrhage card, the PPH card. So on the cart, you have a list of recommended instruments. Make sure your OR has the instruments ready for hysterectomy, easily available. Like I said, not all facilities have an OR ready to go 24/7. So make sure the team knows where they are. Make sure when you call them in, I need to make sure we have the hysterectomy tray in the room, okay? So we're gonna set up, on my PPH carts, generally it's the cart that's designated and labeled. On the top is basically a binder. And in that binder is forms to complete. Scrap paper, because I'm a realistic person. I know in the event of something, we're going to put that piece of tape on our leg and we're going to write on it. So it's blank piece of paper. You can continue. Your checklists are there and your algorithms. Now the policies and all of that can be in the back, but I'm telling you, no one's going to look at it in the event of an emergency. So basically you need the things that can get through the crisis. So instruments, they're in one local place. The cart is on wheels. You can take it anywhere you want to go. Your medication kit is designated and you do not touch unless it is used for a PPH event. And then when we're finished, things start to settle down. Where's this patient going to go? Is she stable enough to go to the postpartum unit, or does she need to go to ICU for closer observation? Once again, we need to initiate and make those arrangements to provide that patient the best care. Also, we need to debrief with our teams. We need to talk what was good, what was bad, how can we make it better? And the last, I don't want to even put it in third place, but it just bothers me. We forget to speak with the patient's family. Sometimes we even forget to speak to the patient in the event of an emergency, and that's always been something I've taken the time to just look at her in the face as you're running down the hall, put a hand on their forehead and say, we're here for you. You can't promise something you can't deliver. You can't promise everything will be okay. You can promise, though, that you're going to do your very best to do everything you can for them. And don't forget to speak to your patient. They're terrified. People are running, things are happening, and nobody's talking. So I always take the time. It doesn't matter what your role is, someone just speak to them. When all of this happens, we don't talk and stop because time is of the essence to speak to the families. So as soon as you get to a point, or as soon as someone in the team can get free, they need to communicate to the family and reassure them. Give them an update. You may not have all the answers. That's okay. It's not that they don't need all the answers at that point. They just need to know where they are and how things are going, and that you will get back to them. And then of all things, document, document, document. I just want to, as we close, I want to make sure that we have to, as you said, Annette, as well, it cannot be a culture of blame in your institutions, and it does have to stop at the top all the way down. We need to use our incident reports to identify gaps and issues. We need to sit down and have huddles. Now, people don't want to because they all want to run back to where they were, but it's so vital. And if you actually take the time to sit and do those huddles and get everybody in and talk about what the challenges are, it will really help you streamline and make your process more lean and more effective. And the whole idea is we're trying to save lives. So it's everything we can possibly do to try and make this as effective as we possibly can. And then we monitor our processes. We continue to see how to improve. So once again, I just want to remind everyone that we need to consciously be aware. It doesn't matter if your patient's in ICU, you need to be aware of sepsis. What are your signs and symptoms, and how are you going to manage this? You constantly need to be assessing, and we need to anticipate. We need to educate the staff. We need to give them tools, whether it's any kind of bundle, patient safety bundle, checklist. And I know they think, oh, I don't want more work. But Wallah, this is so important because we're trying to save lives. So just incorporate, plan in advance for any emergency, wherever it is in the hospital. Use that multidisciplinary approach. And then also we just standardize. Take something. We don't have to reinvent the wheel. It is so much on Google that you can just search. Those organizations that I listed are just top. So you can even go from there, use it as a guideline. And as I said, you can tweak your process to whatever fits your situation. But the point is we just have to be ready, and we have to have everything at our fingertips. So thank you very much for your time today. I appreciate the opportunity.
Thank you. Thanks, Ms. Carter.
Thank you. Very good.
Thank you so much.
Thanks a lot. We can go back to Mr. O. It's working, right?
Hello, hello, mic check, hello. Hello.
Assalamu alaikum.
Mic check, hello, 1, 2, 3. Hello, hello.
Assalamu alaikum.
عليكم السلام.
واضح؟
أهلا مستر O.
صباح الخير.
صباح
مقدر
الخير.
العرض واضح؟
أهلا. Sorry for keep you waiting. We had a technical issue here. So now Ms. Roa, she's a nurse specialist from Irada Mental Health Care, Dammam. She will talk about enhancing nurses' knowledge and skills in COVID-19 through learning need assessment. Welcome, Ms. Roa. You can start.
Assalamu alaikum wa rahmatullah. Good morning for all. First, I would thank for the UCG Group's organization for this conference. And I would like to say also good morning for all audience. And I'm very, very sorry to be not with you in this today for personal issue. Just until now, I'm very, very sorry to be not with you really. Today, I'm talking with about enhanced nurse knowledge and discuss COVID-19 through learning need assessment. This study research done by the group of researchers in the cluster 1 in Eastern region in Dammam specialist التجمع الصحي الأول in Eastern Health. And after we done, alhamdulillah, it is a publisher in journal Nurse and Healthcare. Our preparing for this study to be when the direct contact with the COVID patient as a case of the play of the major role prevention of separate COVID-19. And to be the aim of this study, it will be to identify the nursing skills and knowledge deficit and related for the COVID-19 to provide nurses with education that be for the patient care. Questionnaire contains socio-demographic data, knowledge domain, and the skills domain questionnaire, including their current knowledge and the skill COVID was distributed. Changing in today in healthcare, service require nurses to stay updated in knowledge and the practice according to the Sandra and Gibbs. Continuing education and the staff development are fundamental component of being a professional nurse. The learning need assessment is a systemic process of collecting and analyzing data to bring out the discrepancies and the individual's knowledge base of health practice. It is also a critical step in educational process to enable best practice for the patient care. Coronavirus disease. The COVID-19 cases have been reported globally, and it was very sensitive for everyone who hear about this COVID-19. According to ANA 2020, what is understood about the COVID-19 till now is that it's spread person to person among a close contact via respiratory drugs through cough or sneeze, and touching infected surface and touching the nose, mouth, or eyes with an incubation period lasts at least 2 to 14 days. Symptoms associated with COVID-19, including mild to severe respiratory illness with symptoms of fever, cough, and shortness of breath. Enhance nurse knowledge and the practice to being the maximum knowledge and the skills related to COVID-19 can make them more competent in protection themselves, their patient, and their community at large. The gap their current knowledge and the practice with COVID-19 will be identified through the learning assessment survey that will be conducted in the Eastern Cluster, province in Kingdom Saudi Arabia. Our literature review dealing with the COVID-19 pandemic challenge reinforced the need for assessing nurses' knowledge and skills through knowledge and skills survey. In the COVID-19 crisis, nurses are forced to deal with the cognitive challenge, affective challenge, including many nurses experience fear and concern for what ahead, and psychomotor challenge, including nurses need to be protected with the COVID-19 protocol that excite when caring for suspected or confirmed COVID-19 cases. The global challenge for COVID-19 started in 12 of December 2019 when acute respiratory illness named a novel coronavirus, severe acute respiratory syndrome coronavirus, SARS-CoV-2, struck in Wuhan, China. The outbreak was thought to be initiated from an animal sources to a human who visited the local animal and fish market in Wuhan, China. The World Health Organization, WHO, termed this illness as coronavirus disease 2019, COVID-19, and was updating the global surveillance for human infection with COVID-19. In January 2020, the WHO considered the outbreak of COVID-19 as community health emergency of a global alarm, which activated the need to release the resource and funding. After a few weeks of endemic infection in China, the WHO declared the COVID-19 as a pandemic in 8th of March 2020. Besides in how fast this disease was spreading and number of people that were getting affected with serious respiratory symptoms that were leading a large number of the deaths. The Ministry of Health, MOH, in Saudi Arabia was protective in dealing with the crisis by clear guideline and updating all the time about what happened for guideline to protective and pathway for quarantining, screening, and diagnosis suspected and confirmed cases through the Saudi Center of Disease Prevention and Control. From 2nd of March 2020 till 1st May of 2020, according to the Ministry of Health, total confirmed cases in Saudi Arabia were 22.753, and this we have figure for how daily cases it will be increases in death, and also the recovered case were 3,162. The total death case were 162. The death percentage from total confirmed cases was 0.71%. The recovered percentage from the total confirmed cases was 13.90%. And also this one figure here, it will be showed how be the daily comment cases in this period. The increases as the COVID-19 cases have an impact on the nurses' knowledge and skills how to deal with this novel virus. One way to limit and control the impact of the disease in every country is the combination of a clear and coordinated management guideline for COVID-19 handling. However, the implementation of the basic infection control protocol is possible only when people and employees are aware and updated of the introduced policy, as well as giving them a clear guideline. Awareness level and compliance of conducting health education for healthcare professionals play an impact role in the effective and timely prevention and control of public health crisis. Healthcare crisis such as the COVID-19 outbreak, and as all journals coming to be showing how it is challenging for critical care physicians who need to strong comprehensive skills to respond effectively. Critical care related to continuing medical education has an important part to play in preparing for and responding to such is a vital for the COVID-19 in this period. Similarly, the recent pandemic created an opportunity to have a nurse training so that they are aware of need and are capable to address their learning need professionally and practically. This includes their knowledge in preparing to care for mild to moderate and even sick COVID-19 patient in every healthcare system. To be able to plan for space, equipment, and manpower to include suitably training and adequate number of training critical care nurses. Reports indicate that nurses in many parts of the world are grappling with shortage of much needed supplies that include personal protective equipment, PPE, such as a mask, gloves, and gown, which actively embrace the challenge presented by COVID-19. However, nurses who play vital role as the primary contact with the patient infected with the derived COVID-19 virus must receive the highest level of protection for themselves and for their individuals and communities they are attending to. According to Nemeth et al., understanding or having enough information regarding source, clinical manifestation, transmission routes, and the prevention ways among healthcare workers can play a role for this goal assessment. Nurses will need to be flexible, which may require working in an unfamiliar situation, working environments, and other people who are outside their usual area for benefit of the patient and communities. Assessment staff learning need has different phases, including learner, definition, condition of assessment, analyzing assessment, assessment of data, and development of master education plan. The CDC and WHO are continuously giving information on how each healthcare worker should protect themselves and be safe in dealing with COVID-19 patients. The hospital and KCA are now conducting active research and studies to learn more about the coronavirus to know how to deal with it, like the MERS, the COVID and crisis in 2018. Since health crisis will affect many nurses, we are then obliged to assess variation in learning need among nurses working in cluster 1. Healthcare cluster with respect for nursing rule being provided. The study aimed at identifying nurses' skill and knowledge deficits related to COVID-19 in order to provide nurses with an education that enables them to provide safe and effective patient care. Our methodology of this design research in order to assess nurses' learning need related to COVID-19 and the plan for continuing nursing education event. Descriptive quantitative design was used in this study. A survey is used as method because it is cost effective. It could be distributed to a large number of participants. It is anonymous and it is formal method with a permanent record of a stakeholder input. Our sample, the target population in this study were all nurses within cluster 1, E1 in hospital that included team leaders, charge nurses, educator, nurse managers, clinical nurse coordinator, supervisor, director, and also student were included. Any nurse under nursing administration was eligible in this study regardless of age, gender, units, experience, and position. The target sample size was calculated based on the number of nurses working within cluster 1, healthcare cluster, against the level of confidence interval. 1,000 nurses currently employ all hospitals. Setting, this study was conducted in the first healthcare cluster, E1, hospital in Kingdom of Saudi Arabia. It was the area Eastern province in the Saudi Arabia. Instrument, the survey was divided into 3 different parts. The first part included demographic data of the participant, age, gender, position, and also the second part evaluated nurses' knowledge domain questionnaire, indicated their current knowledge toward COVID-19. The third part evaluated the nurses' practice domain questions, indicated their current skills with COVID-19. Violet, the survey piloted among the co-authors and senior expert nurses, number 6, for construct validity, then it reviewed and modified it to the journals. And after that, this questionnaire coming with the survey sent as a group of nurses, 107 nurses, to test content validity. Ethical consideration, the final survey submitted to Chief Nursing Affairs Cluster 1. The study proposal was completely submitted to the Hospital Research Committee seeking IRB approval letters. Participant in this study was voluntary and the identification of information of participant was not recorded anywhere in the survey. Our data collection, that when the final course approved and designed the link and ready for data collection through emails and via WhatsApp application. The survey was invitation to participants sent to all nursing leaders within healthcare cluster, requesting their supported in sending the link to all frontline staff and encouraging them to participate and voluntary. Discussion, the novel coronavirus COVID-19 poses direct threat to an overburden in Saudi Arabia. Healthcare providers, especially nurses, are the front line of response efforts and they have close contact with the infected patient. Nurses play a critical role in health promotion, disease prevention, and delivering primary and community care. Their up-to-date knowledge and skill can be cornerstone in the prevention of virus spread. Saudi Arabia is one of the top countries in the Middle East that have a highest indication and highest incidence of infection and investigation. Nurses' knowledge and skills about COVID-19 can be an essential step in controlling infection disease. The current study of 1,022 nurses working in Cluster 1 healthcare cluster hospital relieved the predominant promotion and of a participant 93.5% were female and only 6.5 were male. This result concerned us with the study conduct about the knowledge, attitude, and behavior for all response about these studies. Majority of the respondents had high level of awareness and knowledge toward COVID-19 infection. About 90% of nurses know about the mode of transmission, 98.2% about causes, 96.1% about the definition, 96% about the WHO declaration of a global pandemic, and 83.5% about the clinical symptoms. This may be explained the fact of extensive effort by Saudi and successful distribution of educational material beside the WHO and other credible website initial online training courses about COVID-19, which may have significant impact on keeping the nurse up to date and refining their knowledge during the pandemic outbreak. The study demonstrated the same principle of measure related to hand washing, respiratory hygiene, social distance, and the proper use of PPEs. This study, the majority participant was aware of practice safe waste management, environment cleaning, percentage 97.8%, and also how they know a sterilization, patient care equipment, and linen. These findings were similar to study that was done in Nigeria about knowledge and the practice of medical waste management among healthcare workers, and relevant the nurses practice safe waste management, environment cleaning of the hazards sequence of emperor medical waste handling. This study showed that 98.3% nurses reported they must ensure optimal patient care and psychological support for the patient according to the Zahang 8. All absence and the absence of mental health and psychosocial support system increase the risk of psychological distress and the progress of psychopathology. So it is important to provide psychosocial support for the isolated patient, suspected patient, and close contact, primarily through the telephone and internet. Unfortunately, a higher percentage of respondents agreed, 97.6%, to place all suspected cases together in the same ward unit when single room are not available. This may be interpreted as a knowledge deficit or can be connected to the fact that nurses have observed it in some health facilities. Overall, findings showed the majority of nurses in the first cluster hospital had excellent knowledge and skill about COVID-19, but unfortunately, we found some knowledge deficits related to infection control standards, precaution that call for appropriate enhancements to gain the maximum knowledge and the skills about COVID-19. Recommendation and implication for nursing practice: despite the knowledge deficits related to infection control standard, precaution that was found in this study, each hospital in Cluster 1 healthcare, including senior manager, management, nursing service, infection control and prevention, and the quality department must be continuous, enhance nurses' knowledge and skills in COVID-19 to keep their nurses and patients safe. At minimum, topics to cover include surveillance and detection, isolation, quarantine, and contaminant standards, contact and airborne precaution, proper hand washing, cough and respiratory selection, and appropriate use of personal protective equipment. Limitation, despite the useful result and above listed recommended, the study has some limitation. They are not limited to. Study had focused on assessing knowledge and the skills related to COVID-19 and did not involve the attitude domain in learning environment. There are three dominant: cognitive knowledge, psychomotor skills, and effective attitude. And these TCA counterparts the identify and the state of the training objective, and then according we could set educational program to enhance their performance beside their objective in these three domains. Study design was descriptive quantitative. The integration of both quantitative and qualitative approach will provide more data and percentage perception. They're called significant assess nurse deficit in knowledge and the skills related to the COVID. Hospitals had a great knowledge about COVID-19, and the majority of them are competent in dealing with COVID-19. The deficit was related to knowledge and infection control standards, precaution that should be enhanced. However, more information still must be provided by the WHO and MOH for nurses for the better control of the disease. Further qualitative and quantitative studies are still needed to assess nurses' attitude as equal to knowledge and skills. Thanks for, we will, as authors for this studies, would like to thank all nurses, service administrative in each facility in cluster one for this support and encourage their staff to participate in this study. Hospital Research Committee and King Fahd Specialist is also appreciated for this approval of this study. We didn't have any conflict interest disclosure. There are no conflict for these studies. And thanks a lot for our UCG conference to sharing with you this paper and studies in this conference. Thank you.
Thank you. Thanks, Roa. We will have your certificate. I don't know if you are able to see it. Maybe the team will send it to you by email.
Inshallah.
Okay.
Thank you.
Thanks a lot. Thank you. Thank you, everyone. So let's go to the next. We'll have a workshop with the chocolate. Where is the chocolate team?
Delight.
We need some energy. Yeah. But it's no sugar. This is the first chocolate I see sugar-free. So let's explore the option. Whoever loves chocolate can enjoy.
This is the video that I want to show after presentation. So can you so yeah.
Before we start the workshop, yes, I think we need to know each other. I believe everyone sees now. Yes. So I will give the floor to Dr. Ali.
No, just to give to everybody. Yeah. Well, I don't know. My voice already very hard.
Yeah.
No, we don't know each other, right? Yeah. So it's much better to present each other.
So let's play the game of the ball. Yeah. I will throw the ball. Yeah. Whoever will take the ball will present himself, name, title, from where. Like a short. No, we do the ball.
So can you scan it?
I'm Dr. Nadine Helmi Modi. I'm from Egypt, but I'm from Palestinian origin. My doctor. I'm the hospital plus YouTube primary care system. And I'm pleasure to be here. My nationality is I'm Saudi, but my mother is Japanese. I can speak Japanese as well. We are very proud to see a female surgeon. Yeah, this is good. Can you close the board? Don't get here.
Hi, my name is Dr. Pasqua Spinelli. I'm from the United States. I'm a psychiatric nurse practitioner. Our role in the United States as a psychiatric nurse practitioner is similar to physicians. We prescribe, do psychiatric evaluations, have admitting privileges, and I'm so honored to be here and finally see everyone in person. I'll be presenting tomorrow morning.
Hi, my name is Carol Newsom. You've already met me. I am the Chief Nursing Officer at Untitled Hospital in Leeds. I am from the US. I've been here in the UAE going on 8 years, and I was in Doha prior to my arrival here. So I've been out of the US almost 10 years. Thank you.
Hi, myself Anis. Work for Alphatein Healthcare, work in the quality department as well as management officer. I'm in the country for the last 10 years. Usually I was with last DM Healthcare, was in operations department. And currently working in quality department. Dr. Rasha is my line manager.
Hi, my name is Sean. I'm the Chief Nursing Officer at Alphatein Healthcare Group. I've been in Dubai 10 years, originally from the UK. Pleasure to be here.
All right, hello everyone. I'm Sarah. I'm Jordanian, and I come from the Life Motion Act Suite. I am a medical technologist by degree, and I also have a master's in healthcare management. So I am enjoying the conference actually. So thank you so much.
Hi, I'm Sarah. I'm from Melbourne, Australia. I've been in the UAE for 5 years. And yeah. And I work for Alphatein Healthcare and I've been working.
Hi, good afternoon, everyone. I'm Vincy Anthony, the quality officer. I work for Untitled Healthcare as well. Dr. Asha is my line manager. And it's really nice coming here and meeting all of you. Wonderful session. So, let's take the catch. Okay. Where will plans to? Yes. Yeah. I have 10 years experience. Thank you. I with my friend. Yeah.
Hi everyone, I am Khadija Salam Arwahi. I'm pharmacist. I have quality and safety in healthcare management. I'm actually working in the Ministry of Pennsylvania.
Thank you.
Hello, I'm Annette van Ginkel. It's more Dutch. The client is South African. I'm here in Saudi for 3 years and yeah, I'm still enjoying it. My plans is still to stay there.
Hi, my name is Sindhu Matthew. I'm originally from India. I'm in UAE for almost 17 years now. And currently I'm working as the lead in clinical education department at Untitled Health. And it's lovely to be here today and thank you.
Hello, good afternoon, everyone. My name is Marinette. I'm a nurse supervisor for Untitled Health. I'm coming with my colleagues here. I've been here in the UAE for more than 10 years now. Thank you. Lovely to meet you all.
Hi, good afternoon, everyone. I'm Jerlyn from Untitled Health. I have been here in UAE for almost 12 years. Nice to meet you all. Thank you.
Good afternoon, everyone. My name is Glenn Monteverde. I'm working here as a medical records officer from Untitled Healthcare and working under Dr. Asha. She's my line manager also. I've been here for 13 years. I was working with Mediclinic and Menas Healthcare before. Thank you.
I get it? Can I get it here? Can I get it here? What was it?
I'm Salome Mohamed Ali, University at the region. This is the first time for me. Nice to meet you. The first time for me to in the conference today. Yeah. Thank you. Oh, we missed. Yeah, I'm going to be the first one. She's waiting long time. But good you didn't.
Hello, everyone. My name is Sarah Idris. I'm from Saudi Arabia. I work as a healthcare project manager. I have a bachelor's degree in healthcare administration and I'm currently pursuing my master in healthcare administration as well. It's a pleasure to be up with you all here today, and looking forward to all the speakers and their speeches. Thank you.
Oh, okay. Yeah. Oh, sorry.
It's okay. So, good afternoon, everyone. And so far, we have been having a very good conference on the very first day. So, I'm delighted to be here. I am an internist by training. I was initially trained in India. I did my MBBS and then MD in internal medicine from Christian Medical College, Louisiana. And then I moved to Canada about 12 years ago. I'm currently working as a professor in clinical medicine at Ross University School of Medicine. I also have background in healthcare management. I've done an MBA in operations, a master's in health systems management, as well as master's in healthcare management. So that's about my background. I also am a quality buff, having done Lean and Six Sigma. I am a green belt in Six Sigma. So thank you very much, and continue to enjoy your beautiful conference. I already presented myself.
Well, no.
Just one. No, yeah, I am seeing it. Yes, yes. I am Muslim. I can.
The chief guest and he came here first.
Sorry?
I said he's the chief guest and he came here first. Yeah. Everybody else, came up.
Thank you, Dr. Ali. Now we can go back to the workshop. Thank you.
Good afternoon, everyone. I'm Aya. I'll be presenting about live no sugar added sweets. It's an honor to present our chocolate to you guys. Okay. I look here. Yeah. Okay. I want to.
You will give us chocolate or not?
Yeah, for sure. No worries. Okay, so let me introduce the live no sugar added sweets. So a sweet is a main course in Arab's region. So we thought about an idea to bring sweet, but to still keeping our health in mind. So we found the best sweetener to be added to our product, so it will be healthy and guilt-free together. So let me start with the. Okay. So our chocolate is no sugar added, 100% free from hydrogenated oil, 100% free from preservatives, additives, artificial colors, or gelatin, salts. So it's 100% safe for diabetics. Okay. Our chocolate is suitable for diabetics, for individuals who are aiming to eliminate their sugar intake, for weight controlling, for a healthy lifestyle at all. It's also suitable for lactose intolerant individuals. Yeah, because we have vegan options also from both. Also for keto diet individuals.
We will try.
Yeah, sure. No worries. Okay. We've been trying many sugar alcohol to be added to our chocolates, but we came to conclude that monk fruit sweetener was the best, since it has no sugar added or zero calories, zero carbohydrates, as you can see, zero sodium or fat. So it can be, it doesn't impact the blood sugar level. Till to date, there's no negative side effects for the monkey fruit sweetener. So this was, and it has no aftertaste after eating. monkey fruit هو البلانت. لا مو الكيوي. monkey fruit. monkey fruit يعني picture of the high showing there. The only disadvantage for the monkey fruit that it's hard to find, so it's very expensive. Yeah, it was hard to find the best sweetener. يعني it's not, it's in Belgium. Yeah. It's famous in Belgium. It's famous there, and the chocolate also is from there, so it will give the best healthy product. Okay, here we have a simple comparison between monkey fruit sweetener and other sweeteners such as stevia, erythritol, or maltitol. Other sweeteners may have side effects, may cause bloating, gases, may have allergic reactions for some individuals. Also, they cause some bitter aftertaste. Monkey fruit doesn't. Also, other sweeteners like stevia, erythritol, and maltitol need to be processed with high glycemic sweetener, which will impact the blood level. Monkey fruit doesn't need processing at all. It's used as it is. So no added ingredients to the monkey fruit. Also, the maltitol is not safe at all for diabetes. Whereas maltitol is not safe, whereas the monkey fruit is the best. This is the comparison also between nutritional information for other sugar-free chocolate brands and Delight. However, it's sugar-free, but still we can see amount of sugar there, added sugar. But for Delight, there is zero added sugar, no added sugar. This is another example for the same. Why we should eliminate sugar? Here in United Arab Emirates, it shows 16% of individuals have diabetes, and yeah, and it's going up by years. This was in 2019, yeah, for in the Middle East, there's 81 million individuals are suffering from diabetes. So we should offer them alternative, so they can enjoy eating sweet without guilt. So why Delight again? It's unhealthy alternative, and it will not impact your blood sugar level. Also, it's guilt-free, 100% organic, natural, made from scratch, and we are the first company to use the monkey fruit in our products. It's delicious also, you can see, you can taste now. And there's vegan options for lactose and keto diet. The vegan options are suitable for vegetarians, vegans, keto diet, lactose intolerance. We substitute the cow milk with coconut milk, so it will be suitable for them. This is our product, the signature box and the skimmed milk box for individuals who are aiming to control their calories intake.
I have a question.
Yeah.
Can you go back?
Yeah.
Can you remember?
Yeah.
How much each money?
We'll talk about that later.
I want you to answer. Yeah, sorry.
No, it's
easy.
Yeah, it's fine. It's fine.
Free. Compliment. I will let you talk.
Okay. No, it's fine. We have 12 unique flavors also. Our best seller is the almond cream flavor. Okay, we have also this chocolate bars. We have the vegan options also for both the signature box and the signature box skimmed milk, and for the bars. We have plain, dark, almond, and hazelnut bars. We have this J also. We have this no sugar added chocolate lollipops for kids, so it will be suitable for them to eat at any time. In future, soon we'll have wholesale distributing in groceries, pharmacies, and all around the UAE. So, and we can offer customized services, special boxes or logo and weddings and events, hotels, conferences, and organizations. Thank you all for watching. Just can you give me a minute to show you a summarized video about our shop. Yeah, you can open it. It's fine. Can't be higher. The sound can't be higher.
Our chocolates contain 0% sugar added. We also use the finest Belgian cocoa mass to produce a smooth, stable chocolate. We take pride that our products are completely safe for all ages.
You will get a fire.
Yeah, I will get one.
Are you sure that's not right? No, I wasn't talking about you got it. Yeah, one line, that's fine. Okay. This is supposed to be
what makes this distinctive is that it is made from 100% factory milk, a good choice for a healthy and keto-diet sweets. Keeping in mind that our customers' health is our first priority, select chocolates are prepared according to strict standards, which include no sugar added, no artificial water colors, additives, and salt added, and no hydrogenated ingredients are being added to our recipes. As you can see, we always try to choose the healthiest ingredients for our products. This, however, does not restrict our range of products, which includes fine signature chocolate, skimmed milk chocolate, vegan chocolate, chocolate bars, chocolate dragée, and chocolate gift trays. Delight also offers customized services, such as special sized boxes with logo printing for many of our different customers, including weddings, events, hotels, government organizations, cafes and restaurants, airline companies, medical conferences, and diabetic organizations, hospitals, and healthcare. We offer special discounts for customers holding Facade, and wafer cards. Our shop and factory are located in Sharjah, Kuwait,
commercial. Thank you all.
Thank you.
The certificate of yes. Where? I told you don't have. Miss Sarah? Sarah Walid?
Please call. Please call.
Yes, come Sarah. Why you are scared? نديهم شهادات خايفة سارة. سارة يلا لا عليكي واحد واحد. سارة يلا quickly. Thank you.
Oh, thank you so much. Thank you. Photograph. Yeah, hers is also there.
Thank you. Aya. Thank you, Aya.
Still light on Aya. Nice and no? Right?
Thank you. Miss Lisa? Where is Lisa? Miss Lisa? Yeah. Miss Rosaline? Thank you, Lisa. Thank you. Thank you. Miss Rosaline? Thank you, Rosaline. Thank you. Now we are okay to go to the lunch break. 1:45, we'll come back here. Okay? Yeah, thank you. See you all.
So, where is the lunch? Where is the lunch?
Oh,
where is the lunch?
Outside. Dr. Rasha.
Yeah, okay.
MashaAllah, group photo. Yeah.
Any days. Yeah, yes. Yeah. But the lighting and the slides, we can turn it off. But we don't check. Yeah. Next to Dr. Ali. You get
yes.
You get that.
Yes. Yes. Everybody will come. Why you Fatem don't move with Fatem down? Yalla Fatem.
Fatem.
Come here.
Photo with Dr. Ali.
No, photo.
We're the same thing. Okay, impressed. Thank you. Yeah. Fatem. Yalla.
My biggest struggle is trying to get students to understand their empowers, that they will be supported, that they have a voice. They will be supported to use the voice.
How we will make 2 lines, 3 lines, how we will make Somebody guide us. Photo cameraman. Guide us what to do.
Bring my tea, take my papers, put in my gown. This is your Oh, that uncle.
Nurses are not your
So one here on the stairs. Here and there.
We have another group photo upstairs.
So is the lighting for
You can get on the table? Fine. You cannot get. Now we will show your skills. Show your skills.
Can I also join? Yes. You should. Yeah.
Yeah, get focus on me. Wait. Yeah. Thank you.
Thank you. There is another photo on the stairs. You will see it outside.
Yeah, I love it. Yeah. But this photos we received 26 December. Yeah, right? No, really, he said.
When will you receive all the photos? Is it charged?
I think it should be. I will charge again by chance if it gets discharged.
Yes.
Something is wrong with it. Trying to change it.
Sorry. No, make it a little earlier for the photos at least. Yeah. Hello, what I want from you, you take a picture now with my mobile. Yeah. Because 26.
Oh. Okay.
You know, we take a group photo. Can I share that?
Yeah,
Yes.
so would we be good for this too? Can you please join? Okay. Okay. Yes. So, but after that, you would be. Oh, yes, you should. Is taking photo, please? Oh, okay. That's all right. Oh. Yeah. Yeah. Yeah, at least I'll stay around. Oh, yeah. Yeah, yeah, I was looking forward to seeing her. Yeah, I think so. Yeah. Oh, yeah, yeah, yeah. They get on next up all the time. Yeah, where is it? They're coming to us. Where is your voucher? It's in your card. Bring your card. Oh, I gotta bring the card. Okay. I forgot mine. Okay. Where is at the back? Don't you have? No. كتير وكمان الامهات الكوفيد كمان الناس خايفه تسافر. خلصي وكملي يلا. It's not finished legally.
Is it working? This mic?
Yeah, it's working.
No, it's not. Hello? Hello? See?
Hello. Hello.
So speakers can't speak like that, right? So from here it should come. In the morning it was fine, but now it is not working. Hello? Yes, it's working. If you want to mute, then if you want to mute.
No.
No, because it was making some sound, so how can you mute that? Is there any button?
Sorry.
It's okay. Is there any button or something? Because we pressed it and after that it is not okay. Hello? Yeah, fine. Thank you.
Yes, yes. Should we start?
You eat your lunch, Lisa? What we
I just had a question. Because I was looking over the thing that came the script. So should I define here? So I don't want you to say.
I was just going to write out something. I could write out
You can start. 10 minutes left.
Is he here? He's online, is it? Okay. All right, good afternoon. I hope everyone enjoyed their lunch. So welcome back, and let's get started on the second half of the day. We'll begin the afternoon presentations with a keynote speaker, Ashik Masood, who is presenting with us from the US on precision oncology. Ashik, you can begin.
Thank you very much. I'll try to share my screen and.
Ashik, are you with us?
Yes, can you hear me?
Hi.
Hi. Can you hear me or can you see my screen?
He started. Dr. Ashik, we can't hear you. Could you please unmute yourself? It's unmuted.
I am unmute. You can't hear me?
I think there is a technical error from his side.
I'm sorry, just one moment, please. We have a small
Sure.
minor technical problem.
No problem.
To just check whether his phone.
Dr. Ashik, can you please check to make sure your microphone is on?
It is on.
It's on. Can you hear me?
I can hear you.
Hold on, we're not able to hear you at the moment. So just 1 second, please.
Sure. But I got a message from some people on a chat that they can hear me very clearly.
Okay.
Now you
got it now. We've got it on our end, so thank you very much, and I apologize for the delay.
No, it's my pleasure, and thank you very much for the invitation. I've been listening to some of the talks, which were very interesting. Mine is going to be a little different, but you're able to see my screen, sharing my screen on slide deck is there.
We saw it previously, but not at the moment. So can you please share again?
Okay, now?
Yes.
Okay, great. Okay, thank you very much for the invitation. My name is Ashik Masood. I am from the US. I'm the Associate Professor of Medicine here at the Indiana University School of Medicine, and it's my pleasure. So I'm going to talk more about the precision oncology. My goal is not really to make people an expert in computational biology and algorithms, but to show how a progress has been made as we move forward in the cancer care. So I have no disclosures, no competing interests. So all of us know that every patient is very different. So if you take a cohort of patients, and can you hear me? I'm sorry.
Yes, we can hear you, Dr. Ashik. That's not a problem. You can continue.
Hello?
Yes, we can hear you.
Okay, sorry, I have some glitches over here, but okay. So if you look at a group of cohort of patients, and every patient is different when it comes to cancer, but our goal is that we sequence these patients and try to figure out how similar they are, and then kind of tailor the therapy. And based on them, we treat these patients. Our goal is that we will improve their clinical outcomes. Now, before we dwell onto where we are, I think it's critical for us to understand the historical perspective of cancer genomics and how we reach where we are. So 100 years ago in 1930, Theodore Boveri, while he was studying sea urchins under classical or old microscopes, and he was seeing their division, he also found as they developed tumors, he also found chromosomal translocations in their genome. And he proposed Boveri hypothesis, in which he said that the cancer is a disease of genome. But for many, many years, people did not believe him, but eventually they did. So how does the tumor develop? One of the models that is very, very common, it's a review from Stratton's lab from UK. As you can start, all of us start from the fertilized egg, and as we develop, you can see we have intrinsic processes in our genome which lead to alterations. And then we have environmental and other lifestyle modifications such as smoking, et cetera, and we acquire these blue alterations in our genome. And as we develop, some of them will transform into this clonal expansion, then a benign tumor, and eventually a malignant tumor and metastasis or the spread to different organs. But remember, not all these alterations are deleterious. Some of them are passenger mutations, some are driver. What does that mean? That not all mutations will lead to cancer phenotype. Some of them are passenger mutations. Very similar if you're on a train, you don't have any control how the train is running. It's the train driver who's driving the train. It's a very similar concept. So just keep this in mind as the tumor is progressing. You're going in this model where you start with a fertilized egg as an individual. You have some intrinsic processes in your genome. And then as you progress, you get environmental and other lifestyle modifications, and eventually a cancer develops. But this has some implications as we move forward. So this is early 2000, and Hanahan and his group talked about how does the cancer develop in a normal human individual. And there were different mechanisms, for example, inducing angiogenesis, new muscle formation. As some of our cells in our body, as they get these mutations, it try to fix it. If they can't, they go and die, called apoptosis. And evading growth suppressors and others. But then they published again a review, which is almost 10 years. They again presented a new model in which, we looked at and we understood cancer at a much higher resolution. And as we understood them, we developed a number of drugs, for example, EGFR inhibitors, they're in clinic. Immune therapy is very commonly used in lung and other cancers now, in which all of us form cancer cells every day in our body. But what happens, our immune system recognizes them and kills them. But in some individuals where the cancer develops, they know how to evade or hide from the immune system. As a result, cancer starts to grow. With these drugs, we unleash immune system against these tumors, and we see dramatic responses. So over the last few years, we have seen something very dramatic. For example, in 1960, Philadelphia or BCR-ABL chromosome was discovered, and it took us 41 years when Brian Duker discovered first drug called imatinib. Then EGFR was 1978, drug came in 2006, and KIT mutation, BRAF inhibitors out. So we have made a lot of progress when it comes to the drug development after the discovery of key driver mutations. So, but this watershed, in my opinion, all began in 2009 when Human Genome Project, an international collaborative effort, was completed in 2009. And it was a big news. All of us know one of the landmark study was completed. It started in 1990 and was completed in 2003 and 2004. It took 14 years and a few $1 billion. So although it was still a rough draft, it has some limitations. However, it was a great stride forward. So how do we now do? There are some terminologies which are very important before we move forward. There are different ways we can look at a cell and do the analysis, whether it's a tumor, whether it's a normal cell. We can do a whole genome in which we'll take a complete genomic architecture of a tumor, take all of it from DNA, and this gives us opportunities to look at, for example, translocation. A part of chromosome broke and attached to some other place here. Then you can do only exome, where you only will do a transcribed part. So our genome has exomes and introns. Majority of that is introns, about 1% to 3% are exomes. So you can only study those. Or you can also do a transcriptome, means the expression profile as the DNA transcribed into RNA. With the exome, you can also look at the mutations like point mutations. We call them as missense, nonsense, and frame shift mutation, or you can look at the expression. So after the Human Genome Project was completed, the National Cancer Institute came up with this idea that they are going to sequence all major tumor types, around 11,000, and try to create a catalog of all the alterations in cancer genomes. Remember, it took 13 years to complete one first normal human genome, so it was a big stride forward. So this was really a large task. Multiple institutions in the US were involved. But at the same time, the institutions who were involved in a human genome project started to do a smaller project. The first one came from WashU, my previous institution, who did the first human genome which was ever sequenced, and they did a leukemia genome in 2008. And just to give an idea that how daunting task it was, like when you look at a genome, it does not only have alterations which are cancer causing. We have something called SNP, or single nucleotide polymorphism, means all of us have these alterations in our genome which are present more closer. We are a population, for example, Asians versus Caucasians will have much more difference in SNPs. So you can see them, they started with around 4 million and only validated 8 causing cancers. It was such a huge daunting task. It's just 12 years ago. Now we have much better algorithms and we are able to do whole genome, exome, transcriptome in a few days in a clinical setting. But then another big story which came out of WashU was this gentleman, Lucas Workman, who was at that time a fellow, had an acute lymphoblastic leukemia. During his med school, he got chemotherapy followed by transplantation. And then his cancer came back and he had very limited options. So what they did, they started to sequence his genome. He is sitting at the Genome Institute at WashU, and behind him are all these alumna. And they started looking at his genome. Can we find something for this colleague? Because he had a very limited options. So he has published his case it was a big New York Times, news. And he also published this case report in which he showed that when his tumor was sequenced, they did not find any alterations in his DNA, but on his expression profile. And they found this FLT3 receptor, which is kind of a unique for ALL. And eventually what happened, he was given a drug, sunitinib, at that time was approved for other cancer like kidney cancer. And he went into a remission in a couple of weeks and went on to get a transplant, and currently doing a research on APL, has his own lab. So this is while TCGA was going on. Another paper was published from the WashU, from my previous mentor, Govindan and Subramanian. And they kind of looked at the lung cancer, and just not to dwell too much into this, but to show you a bird's eye view of cancer genomes, how they look. So these colored bars that you see here are the chromosome. All of us have 22 chromosomes, and these SNPs are alterations in the genome, and these lines represent a translocation. A part of a chromosome broke and went at the other place. So you can see in smokers, we see this many mutations compared to never smokers. Never smokers is very silent genome. So it was kind of a very interesting what we already know, but showing that at the whole genome level. But then the TCGA started to publish their papers. For example, this is a stomach cancer we found. It's not only one disease, there are at least 4 subtypes. What was more interesting was we found Epstein-Barr virus subtype and MSI subtypes, and they have clinical implications. They respond very well to immunotherapy. Similarly, endometrial cancer was also found to have different subtypes, although they were treated same. But what was very interesting, on the left side, you can see this pole hypermutated phenotype has a very good prognosis.
So sorry, Dr. Masood, for interrupting. Could you please share your screen?
You can
see it? Yes.
You can see it?
Yes.
Now?
Yes, sir. Right.
You can't see it?
No.
Oh, I'm sorry. Let me do it again. Now?
Perfect. Could you please just give play it from first? You just show the slides.
Now?
Yes.
You want me to go back?
No, you can just play the video or play the slides. 1, 2, 3. Just give a minute and you can go to next slide.
Now you can see it or no?
Yes, we can.
So you want me to go
You can
back?
continue.
You want me to go back or what do you want?
You can continue. We will send your presentation to everyone. That's not a problem.
Okay. But now you can see my slide or no?
Yes, perfect.
Okay. So we could see this endometrial cancer has different subtypes. One of them is this hypermutated phenotype, and 100% of these patients do very well. So we learned a whole lot. So you can see how the cancer genomics has evolved over the last few years, rather very rapidly. What we know now. Many people then said, okay, let's combine multiple thousands of tumors. Can we find a common pathway so that we can target them? And very similar, you see them, they share a number of common pathways. So just to give an example, how do we use it in our clinic? For example, this patient is an 83-year-old female. She was diagnosed of a small cell carcinoma of bladder, which is very rare. The common cancer of bladder is transitional cell. She was treated with chemotherapy, then quickly had a progression of disease. And she had whole genome sequencing, did not find any alterations that we can target. And this is her bladder cancer and some involvement in lymph nodes. It's a very poor prognosis tumor, but what was in her tumor was something called high tumor mutational burden, means more number of mutations, more abnormal the genome. And this is showing, based on the Cancer Genome Atlas, how many mutations are there in a tumor, how many alterations are. So for example, thyroid median is around 1 mutations per megabase, melanoma, skin cancer has much higher, a lung squamous has much higher mutations because it's a tobacco induced. She had a very high mutation, not in any alteration. And then, so based on that, we know that if you have a very high alteration, these patients respond very well to immunotherapy. So what we did, we treated her with immunotherapy. So one of the important ways to look at the tumors is to look at their mutational signatures. So we do find this pattern, like all our DNA is made up of 4 bases: adenosine, cytosine, guanine, thymidine. So you can have a change in the alteration in the genome where, for example, this C is converted into A, but is this a random process? So more recently, a work from Alexandra model actually showed not really. When you take all these tumors on the right, you can see these tumors. When you kind of plug them, you see a pattern. You always see, for example, C to A pattern in lung cancer. So it's a smoking signature. And C to T signature is much more common in melanoma. CPG to thymine is very common. So these alterations have something to tell us. So in order to decipher those signals, we use a number of algorithms. One of them is called non-matrix factorization. So just to give you an idea, now you have a tumor, can you go back in time and try to figure out what happened to the patient? It turns out to be, when we looked at her signature, she was never a smoker, but we found signature 22, which was consistent with exposure to aristocolic acid. And these are present in some traditional Chinese herbs. Maybe she took them when she was growing up. Because she had unknown etiology, she was never a smoker, no history of tobacco to develop small cell lung cancer, small cell bladder cancer. She also has BRCA mutation. We know that she has ApoBec signature consistent with it. So we treated her with immunotherapy in 2016, and she had this large bladder mass. It was shrinking rather quickly, and she was in complete remission. So here's another example of a 79-year-old gentleman who had a history of cholangiocarcinoma, a liver cancer. underwent a large surgery, was found to have stage 4 disease. He was given chemotherapy, but given he was a stage 4, we know that his disease is going to come back at some point. So after a year, we got a CT scan. This is a CT scan after surgery, and you can see a liver here is fine, right? One side of the liver was taken out. But after a year, we saw these new lesions in his liver. We sent, when he presented to me a while ago, I knew that his tumor is going to recur because he was stage 4. At that time, he had no alterations that we can target. But then we also got his blood, and what happens as the tumors start to grow, they shred their DNA in a bloodstream, and now we can draw a blood and can find circulating tumor DNA. So we know that the circulating tumor DNA concept is since 1984, but now it has become reality over the last few years, where almost all patients in advanced stage disease do get blood draw, and we can actually, it's a non-invasive way to look at whether a patient with a cancer has mutations in the blood, or he has a cancer DNA in the blood. So actually what happens, tumor, somebody who has a tumor, it's a very dynamic process. It evolves over time. So it starts with a small, one cancer cell, and then these cancer cells start to grow, and it develops different alterations, like we show something in green. These red and orange ones are all new alterations. Then you give chemotherapy, kill majority of tumors, but then this red clone was upfront resistant to chemotherapy, and this clone eventually after some time will grow. And this is typically a tumor evolution model that happens. So in our opinion, what we thought was this BRAF mutation that we now found in this gentleman, was it already present that we didn't pick up in his initial genome? It turns out we went back and looked at his genome, and we found that it was already there, but it was at a very low threshold that the algorithm didn't pick up. But unfortunately, it was not a targetable alteration, and he has to go on next line of chemotherapy. So here's another example of a 68-year-old female was diagnosed of colon cancer. And was also found to have disease spread to her lungs. She was given chemotherapy at that time, was a standard of care. But then what happened, she also has something called microsatellite unstable tumor. These are tumors, they don't respond very well to chemotherapy. Eventually, we sent her genome, and she had these very large alterations in her genome. However, whether these are true, so this is an automatic report which comes out of a sequencing companies, and they said, okay, you have EGFR, all these drugs are targetable. But we had a suspicion that they may not be targetable. The reason being, one is, when we look at a pathway, for example, all these alterations that you saw are of RAS-RTK pathway, but these mutations are mutually exclusive. So what happens if you have a patient with a tumor and you sequence their tumor, you always have on that particular pathway, we will always, almost always, if not ever, will only find one alteration, which is good enough to cause cancer progression. So it doesn't happen that you need to have multiple alterations in the same pathway. You just need one alteration. So all of these alterations were not driver mutation. So it tells us that we have to be careful, looking at these reports and make therapeutic decisions in these patients. So we recommended immunotherapy, and patient did very well. Now, this is another 39-year-old gentleman, very unfortunate, diagnosed of pancreatic cancer at a very young age, was treated with chemotherapy, but he had this BRAF N486_P490 deletion, which is kind of very rare alteration. And then again, the report came out and said we should use vemurafenib if possible. But it turns out to be that's not the case. If you use vemurafenib, it will lead to paradoxical activation of his tumor, will actually lead to worsening. What actually needs to be done, he needs to be on this experimental LY3009-120. So we made recommendations not to give vemurafenib-based drugs. He should be on this clinical trial. So giving these examples, what I'm trying to make a point then that in order to deliver precision oncology care, it needs a village. It just does not need physicians, but pharmacists, nursing staff, everybody needs to be on a board to create this kind of quality care to the patients where we make right decisions. I recently moved to Indiana University. I haven't shown you a slide. It has one of the reasons for me to move was it has one of the largest precision oncology program in the country. We have sequenced more than 5,000 tumors over the last few years. And not only at the downtown location, we are offering precision oncology clinic, but we are also offering at other locations in Indiana. With this, I think that should be, so as I said, in order to deliver oncology care, it's becoming much more complicated. In order to provide patient care, we just don't need clinicians anymore. We need research scientists. We need well-trained pharmacists, a very strong nursing team to deliver effective precision care in our cancer patients. Thank you very much for your attention. If you have any questions, please let me know.
Does anyone have any questions for Dr. Sheikh? Thank you so much for such a wonderful presentation. We appreciate. All right, our next speaker for the conference for this afternoon is Ms. Rama Al-Laki. She is from the UAE. She will be speaking today on the highlights on healthcare management and patient safety. I apologize so much if I said your name incorrect. That's correct. Is it? Yeah.
To make it easy for you, it's nursing.
Thank you so much.
Thank you.
So you just forwarded it just now,
yeah.
Right? So it will down. Let's go.
بعد الغدا ضروري اعزمكم عندنا على البيت ان شاء الله. خلاص والله عشان كده انا ما جربتش. Okay. If you insist.
Assalamu alaikum. Good evening, everyone, or should I say good afternoon? Okay, so my name is Rahma. I'm gonna present for you today about the highlight in the healthcare management and patient medication safety challenges. So there's a conflict of interest. There's no conflict of interest to declare. Our content for today will be mainly about the healthcare management, the core and value of it, significant role in safety, ICMP, WHO, national patient safety goals, importance of that in our field, and a little bit in details of some practical life examples. So a healthcare management, the origin of that is everybody knows what is the healthcare management. It's most of the time we're talking about, it's like a kind of a health system that's providing a kind of program which was established in 1934 at the University of Chicago. The original idea actually, it's by the father of Molinaire, which is associated with the Catholic Hospital Association. The main definition or the significant definition of that, it say that what is the name that which is implied? That's the overall management of the healthcare facility, such as a clinic and a hospital. So we can say that the healthcare management is most probably like, we call it the umbrella, which is cover a wide job priority, clinical director, healthcare provider, supervisor, coordinator, and the home facilitator as well. So mostly it's depend on the choices, hierarchy of action, and goals. While the value on which these decisions are founded because it's a value guide our action. So according to the European Health Report, so the core value laid out in Health 2020, so it's like we can call it as a new European health policy framework that are health and healthcare, which should be like covering the high quality, equitable, and sustainable. Mostly actually the Health 2020, it's like a European policy framework and strategy, which is actually launched in 21st century, which is in 2012. That's a couple of years back. Actually, it's the mother of that is WHO, which is World Health Organization. And it's they have some special committee, call it as a Health 2020, which is covering two board forms. This form, we call it as a shorter policy framework and a longer policy framework. The shorter one that's mostly covering the policymaker with the Health 2020, covering the value and the principle, while the longer strategy framework covering the strategy, which is give more in detail in the term of evidence and practices. However, we said that it's kind of like the Health 2020 is a living guide that toward for have a very unique policy and strategy. So the core value are operationalized using a set of concepts and approaches, which have gained a lot of increasing momentum in a public health sphere over recent decades. So to be more continue with the European Health 2020, however, that to draw a rich history in collaboration with WHO in areas such as the policy and social determinants of the health, such as transparency, supportive environment, enabling environment, sense of belonging, self-control, sense of control, the government approach, empowerment, and etc. So, however, that we said that Health 2020, actually, it's a strong emphasis as a commitment, as well as a professional expertise and the engagement of the whole civil society. And it's also focused on a solution which will offer a practical and achievable flexible policy action and capable, which is being successfully implemented in the individual context of each country. So covering to that, actually, as I mentioned earlier already, that I'm working currently in Sheikh Khalifa Specialty Hospital, which is under visionary of leadership of His Highness Sheikh Khalifa bin Zayed Al Nahyan, the President of UAE. The hospital actually located in Ras Al Khaimah, which was built in the middle of the 5 Emirates, that's covering the Sharjah, Atman, Al Gawain, Ras Al Khaimah, Fujairah, and to cover all the medical services for those Emirates, which is leading to be like a goal of a leading medical facility in Emirates and referral center for the Northern Emirates. So our vision of our hospital, I can call it SKSH, the abbreviation of that. So it's a world-leading medical hub in GCC. Our value is actually every staff member in our hospital will place a patient as a center focus, that for the hospital purposes, and will achieve the excellent patient and customer experience via OKRA value like integrity, quality, respect, and teamwork. So what is the role of the healthcare management and safety? We can say it's a part of the organization management that's covering three most important aspects, which is the health and safety work organization policy, planning process for the incident and near-miss events, and the practice procedure resources for developing, implementing, and maintaining the occupational safety and the health policy. So that means the safety can cover two important aspects in the healthcare, which is medication and patient. To continue to that, covering with ISMP, which is Institute for the Safety, for the Safe Medication Practices, which is covering the medication safety in collaboration with WHO, that the mission of ISMP to educate a healthcare community about the safe medication practices. It's this kind of an institute, actually it's non-profitable organization, devoted entirely to prevent any kind of medication error during more than 30 years of history. It helped in different million lives and saving a lot of the healthcare provider and to how to guide them. Continuing to that, ISMP is a gold standard for the medication safety information and to serve a vital force for progress. The work alone has resulted in the numerous necessary changes in clinical practices and public health drug labeling and packaging. However, that the ISMP actually, it's kind of have a collaboration work with the system and the practitioner to advocate for the patient safety and promote the safe medication practices. So medication safety actually and the taking precaution steps are extremely important to prevent any kind of adverse reaction and overdoses. So among its many initiatives, ISMP ran only a national voluntary practitioner medication error reporting system that published a newsletter with the real time error information and can be trusted and can be distributed on a monthly basis globally among all the healthcare community, and offer also a unique educational program tool and guide. And this is an example, one of the newsletters. And based on that, it's an independent watchdog organization that receives no advertisement revenue and depends entirely on charitable donation, education grant, newsletter subscription, and volunteer effort to persuade with the life-saving works. To go in deep with WHO, there is we call it, WHO have actually created or have initiated or established a global patient safety challenges. And there was actually 3 public challenges among the world. The third one, which is the recent, was about the medication without harm. It was the creating by the Innovate, which is Sir Liam, that he had the whole idea about the patient safety in collaboration with the WHO member. So the medication without harm, this is the third challenge that have been published, reducing the harm from the risk, the high-risk medication and polypharmacy transmission of care. The high-risk medicine can cover choose based on the hospital practice, but also WHO only focus on the antipsychotic, insulin, opioid, heparin, and anticoagulation. Global Patient Safety Challenge also, it's an essential program that aims to improve and for the improvement and the risk reduction, plus that they actually covering the evidence-based practices, intervention, and any multimodal implementation to achieve the widespread engagement and commitment. So unsafe medication practices and medication error are leading to cause any kind of injury and to avoidable harm in the healthcare system, Globally, its costs associated with the medication error, which has been estimated $42 billion annually, which is 0.7% of the total global health expenditure as a per WHO. So based on that, the medication without harm is a purposed solution to address many obstacles in the world, which is faced today, and ensure that the safety of medication practices. I think the goal is that to achieve a widespread engagement and commitment, and to assure that the professional bodies around the world to reduce any kind of harm related to the medication. It's aimed to reduce a severe avoidable medication-related harm by 50% globally in the next 5 years. So more about national patient safety goal. It's a healthcare discipline that emerged with evolving the complexity in a healthcare system and resulting rise of the patient harm in a healthcare facility. Also, it's aimed to prevent and reduce the risk, errors, and harm to occur in a patient during provision of healthcare. Concerned to that, it's actually a cornerstone of discipline to in a continuous improvement phase of the learning from error and adverse event. As with any performance improvement, you need to have like a targeted goals. And if there's any difficulty in deciding where to focus, you can also recommend to review GCIA, which is mostly the Joint Commission of the National Safety, which is then have a cover actually at the 6 to 7 important goals, which is improve the accuracy of patient identification, the staff communication, safety of medication administration, reduce patient harm associated with the clinical alarm system, reduce the risk of the healthcare associated infection, better identity of the patient safety risk in the hospital, and prevent any surgical mistake. Implementation is one of the points of the quality and safety initiative, and it seems like a progress. It won't be significantly change the number of lives that save over the time, but admirably, it can reduce the central line of the any bloodstream infection, like for an ICU, by 80%. Maybe it's not enough, but to achieve the medical safety goal, the organization must actually create a culture of safety and to give a complexity of the most health system as well, revolving the leadership and changing in any reimbursement system. It's not an easy actually task or job or project to be done. So without a complete culture engagement, and to avoid any kind of like a blame community in new organization, you're gonna have with a better communication that will improve the thing, and especially with the support of your leadership in the organization. So what is that important of the safety in our field? It's mostly the patient safety is an institutional level start at the top. This means that the hospital leadership is not only dictating the rules for employees to follow, but it's rather fostering the culture of patient safety. And culture is no small thing to build or change, but it's a good area to start point of your hospital leadership truly, which is embracing the patient safety. So here will be actually more emphasized one of the life example that if you face any kind of like, if you heard about any counterfeit medicine previously. So WHO defined that a counterfeit medicine is like kind of label with the respect to identity, and the source may include a product, which is, can be the correct ingredient, but the fake packaging, or with the wrong and without active ingredient with insufficient or active ingredients. The counterfeiting can apply in the brand name and generic name as well, in the prescription medicine, over the counter, as well as the traditional remedies. The counterfeit may also contain a different ingredient for the harmless and toxic, or different quantity of the ingredients. So the counterfeit product may include a wrong ingredient, no active ingredient, insufficient ingredient, and fake packaging, such as mislabeling about its origin or authenticity. Concluding to that, there's an importance of the healthcare management, which have a basic aspect in safety zone. Any challenge can currently encounter with the measuring efficacy, consider how these challenges can relate to our framework of thinking about the health system efficiency. That's why we have to make a judgment about the efficacy throughout the health system and thereby improve the policy managerial decision. Thank you very much.
Thank you.
Great, thank you, Rahma, for that presentation. Really appreciate you on that.
I think you will receive it.
Yes, you want to come back up so we can get your certificate? Yes. Is going to be Bashma Rafi from Saudi. They will be speaking today about the Second Victim Support Program. Can you please come to the podium? Thank you. This one, right? Yes.
Assalamu alaikum. Good afternoon, everybody. Is my voice is clear? Okay, thank you. It's actually my great pleasure to be here, and I would like to thank the organizing committee and coordinator, Ms. Amal Ibrahim, and all the invitees and participants. Really, it's a good experience, and I hope, inshallah, you will enjoy the talk. This is about introduction of Second Victim Support Program and what is the importance of this program at healthcare institution, and a few slides to share our experience, how we introduced this program in one of the Makkah governmental hospital in Saudi Arabia. I'm from, as I said, from Makkah, healthcare cluster, and from Holy City, Makkah. Makkah Healthcare Cluster is covering 10 governmental hospitals plus 82 primary healthcare centers, in addition to Hajj and Umrah seasonal field hospitals open during these seasons. You know, we are in the transformation stage for picking the vision of the 2030, and toward moving the organization into to be accountable care organizations. ACO, when established at the beginning, it was a triple aim. So the triple aim: lower cost, healthier community, and improve patient experience. But actually, they update these aims to be a quadruple aim instead of triple aim. So they add provider experience. There are many published articles showing the direct relationship between improving the provider experience has a direct effect on patient experience. So now there is a much focus on provider experience. And actually, this was very targeting what we are aiming today to talk about is how to improve the provider experience in healthcare sections. 10 years from now, I think everybody familiar with Kim. She was almost 30 years working in one of US hospitals, and she was critical care nurse. And you know how the stressful life for nursing working in critical care, they will spend whole shift looking for one or two patients, and if her colleague is absent, she will look for more. In addition to that, she will, after finishing her duty, she will stay just to complete her documentation or whatever. Sometimes they forget even their, what we can say, their break time or off days. So on 2010, she got a mistake that she gave a baby 10 times dose higher than the required for that baby. The baby died, unfortunately, 3 days after this incident. And this was the first medical error we can say in her whole career. Immediately, she was fired within 5 days from her working hospital and lost her job. In addition to that, they suspend their nursing license and to be and to work under supervision. So actually, she didn't find a job and nobody wanted to hire her. At the end, a few months later, unfortunately, she committed a suicide. Actually, this was a very traumatizing story for like hard worker nurse like her, and I'm sure many experience different kind of these stories in their institutions. Our role as a policymaker, as a responsible people, as a governance, we need to look at those cases seriously. We don't want to repeat this story again and again in our healthcare institutions. So before start, we need to go through our main topics. Number one is who is the second victim? And actually this terminology is a new one introduced in 2000 by Alberto. First described the second victim as doctors who make the mistake need help too. But further detailed definition was established by Scott in 2009. They define clearly who are the second victim, that they are healthcare providers who are involved in unanticipated adverse event, medical error, or patient injury, and become victimized in a sense that the provider is traumatized by the event. These individuals feel personally responsible for the patient outcome. They have this guilty sensation all the time, and they are mentally and psychologically traumatized. Going further about second victim, actually it's not only second victim. The circle is more bigger. So whenever there is a medical error, a serious public health problem, and the third leading cause of death after heart disease and cancer. When the error occurs, it has a domino effect and include 4 groups. So the first group, patient and family. The second group, as we mentioned, healthcare providers. Imagine if there is one baby exchange happening in one hospital or infant abduction. It's not only a provider issue or a patient and family issue. It's rather hospital reputation that impacted. And it's not this one only, rather the patient who are harmed subsequently, because the patient will not would like to be treated in such hospitals where there is an infant abduction. So the circle is bigger than talking about second victim. the circle is bigger. However, our focus today will be about second victim. Yes.
So very good. Very interesting. Can you go back?
Sure.
It's very interesting. So you mean that the affected person is the family and the patient?
This is the first.
The number one. And then the healthcare provider, the doctor, for
because
example.
everyone will pinpoint that the provider is the cause of this event.
Whatever doctor or nurse, whoever did the mistake.
And then,
because they will feel guilty, I give you wrong medication.
Yeah.
So everyone will look at me, I'm bad. She gave the wrong medication or she did the wrong surgery. So everyone look at me as I'm a criminal. So I will suffer from a lot of psychological problems also.
And then the hospital reputation, and patients who are harmed. What it means, the first point, I don't understand. First point, false victim.
Yeah, this is a patient who harmed subsequently because that, for example, if the hospital had a bad reputation, the other patient who want to be treated at this hospital will be like they don't like to be treated in this hospital because of this event or this error.
The accident.
Yeah. So this has an impact even for those who are previously visiting this hospital or treating in this hospital.
It's very interesting.
Yeah. Okay. So when we're looking for the prevalence, how frequent we can see these victims, actually it's varied from 10% to 43%. And this variation is, these big variations because of some are silent. They're not talking or not speaking up. Almost 50% of healthcare providers experience at least one time in their career that moment of second victim. Indeed, there are always second victims when there is a serious patient adverse event, but mostly silent because of their fear of litigation and absence of well-defined reporting system. Common reaction can be emotional, cognitive, or behavior. The coping strategies used by second victim have impact on their patient, colleagues, and themselves. So this is based on the studies. They found that in hospitals, most of the malpractice sessions are related to surgical or infusion error. This is the commonest error in hospital basis. For OPD care, mostly related to unnoticed or late diagnosis. So the cancer patient, for example, was discovered after 6 months. So this late diagnosis, although the patient is visiting the OPD frequently. Specialty related, yes, the effect were strong among physicians specialized in surgery, anesthesia, pediatric or obstetric and gynecologies. Definitely there are invasive procedure and more complex situations there than other departments. Nurses, pharmacists, and other members of healthcare team are also susceptible to error and vulnerable as well to unanticipated patient harm, because usually these errors happening unintentional. It's not intended by the healthcare provider, rather it will be a crime, but it's an unintentional error, but they get blamed and they get legal litigations as well. So this is shortly what was the meaning of second victim. Let us say why we need to focus on this support program. These are studies showing the relation between burnout and patient outcome. It was a meta-analysis and more than 82 studies there, and 210 healthcare providers involved in this study. And there is a strong relationship between provider burnout. Burnout can be emotional, exhaustion, depersonalization, and reduced personal accomplishment with the quality and safety of healthcare. So there is a negative correlation between these two, and it was statistically significant. Another meta-analysis showing that the impact of burnout as well, it's not showing here, but I will just little bit, I will try to make this one down. Okay, so this is again, it was meta-analysis for 19 studies involved, mostly with the nurses, physicians, mainly in US, followed by other European countries. Between the cross-sectional studies between 2006 and 2018, they analyzed the relationship between burnout and adverse patient safety outcomes. Again, there was a direct effect with p-value 0, which is statistically significant. It's not moving, I don't know if it can. Okay, so as we said, there are also systematic review showing that again, a relationship between organization-related outcome with nurse burnout. This is for nurses, really. I just pick up some for the nurses because this symposium is about nursing and quality. And really imagine how there is a direct relation between patient safety, quality of care, nurse organizational commitment, nurse productivity, and patient satisfaction. All these impacted due to the nurses' burnout. So, University of Missouri, and this is one of the really big organizations that they look after second victim program, and you will find a lot of publication and even free link to their website. They are providing all the tools needed for this to help you for supporting the second victim program. So they stated that they add actually in their safety culture survey, annual survey, they add 2 additional questions and they found that 15% in staff member plus 175 experience a patient safety within the last year that caused personal issue, anxiety, depression, and concern about staff ability to perform one job. Actually, this is alarming that 68 of these clinicians reported that they didn't receive any organizational support. So Scott actually, he said that said in his published article that the second victim phenomena, the same as that, similar to the stage of grief identified by one Elizabeth Kubler-Ross, that any second victim will go through stages when there is an error or there is harm to the patient. So from denial, anger, bragging, depression, and acceptance. So there are stages, and in summary, there are 6 stages. So the first stage can occur simultaneously or one after another, which is like we can say like denial shock. You will have like what happened. No, I'm not I am not the cause. I am not. So this is a denial and can be happen simultaneously. And then we'll have to the steps of recovery. So the steps of recovery is very important. Our support program should be in this moment we need to intervene. So if you go to the last stage, which is moving on, there are usually 3 outcomes after any event or error occur. Either thriving. Thriving means that the provider will take this error as an opportunity and he will be an advocate. So for the other healthcare provider, he will keep what we can say that he will consider it as a lesson learned, and he will spread his experience in a way that to avoid any future error happening to other patients. So he will be like sharing his experience in a way that to be educational or learning culture. So he will be positive and he will be motivated even after this error. And this is our aim from support program. We need the providers after committed the error to have this recovery stage and even to spread their experience in a way that no other patient can be harmed with the same similar causes. Surviving means that the provider will continue his job, but sometimes he will do his job because this is his job to do. He will not be any active contribution to the organization. Rather, I found some surgeons, they did some operations, and really they are excellent surgeons, but he never do this surgery again because of this complication happening to one patient. So he continued his practice, but again, just to be to work as to do his job, and that's it. And this is actually we don't want, because we are really losing the talent and losing good people in such a manner. The latest one, which with the case scenario I showed it at the beginning, which is dropout. Either they will leave the organization or they will change their entire career. They don't want to be healthcare provider. They will go and look for other jobs. And this is actually our aim to prevent such kind of recovery. So this is how I show you why important to have a second victim program. So a lot of theories till now, data and theories, but now we are going to implementation. How you can implement such a program, second victim support program in healthcare institution. Again, this is from Joint Commission resources. This is established article by Joint Commission. They stated this organization, they are offering free link to their website and showing the experience and how they implemented second victim program and can be adopted for any organizations. And actually very nice references. You can go through this article down. You will find all the link for this organization. But because of the time, I will select for you some. One of the things that they usually not name the second victim program. They're not using this term actually. They're trying to avoid this term because it has like some kind of, usually you will link the victim with crime. So usually they are trying to avoid such kind of terms. So they're using a different, if you see all these organizations, they are not using second victim, rather they're using for care for caregiver or one of these, this is called lavender. And actually, I found a lot of articles just talking about code lavender, and each organization, they have their own, what we can say, program for code lavender. But if you saw code lavender, that means they're talking about second victim support program. So, for example, this is one of the pilot program, one of the US hospitals. They are providing this code lavender kit, chocolate and sweet and lavender essential oil plus positive words in a card for the employee, just to give them motivation and to give them relief. And then they measure, and it was done in a critical care area and emergency for healthcare provider there. And then they measure the effect of this program before and after. And actually, I shared this article because of this, which is like when the provider will activate or call the vendor, or they feel that they need to be supported. So this is a really nice reference, all showing when they need the help. So conflict within the healthcare worker is a cause of distress and work stress and burnout even. So important, very important for the organization to manage the conflict within the organization. If there is any bad outcome happening to the patient, multiple patients with bad outcomes, unanticipated patient death, patient violence or aggression. Sometimes the patient harm the providers. So sometimes the provider being blamed for an event, blaming myself, patient family emotional response affected me, and patient situation reminded me of my family. So if there is a loss of dad or mom or whatever, the provider get emotionally even harmed because he remembers some of his family, the same story or same similar situation. Lastly, unanticipated negative clinical events. So all these are emotional stress factors that can be provoked for the providers during providing the care, and these are the percentage. So actually, this article showing that 100% they found the program helpful, and 84% would recommend this program for the others. Anyhow, this was just to show what are the causes that you need to give a provider support. This is, yeah.
So I need to understand a little more.
Yeah.
Because I see chocolate also.
Yes.
Yes. Yeah. This is how we support the healthcare providers.
Yeah.
To make them happy.
Yes.
This is what do you mean?
Yes. They every organization they select a tool to support the providers. So this tool was implemented by some organization. They use a toolkit like this. they put a card with positive word, like you are doing great, you are whatever, positive word, plus they're putting chocolate because they said the chocolate can be stress relieving element, like delight. Today they shared with us. And called lavender oil because they link that lavender has like a stress relieving effect. So they put it in this kit. Some organization using aroma code, or I found another names they're using for this program.
Yes, Dr. Brown, this is so important that you're mentioning this. As part of psychiatry, we started cold lavender, but I changed the name because during surgery, when they yell out cold lavender, they think something, medical event is happening. So we call it cold comfort. And it's always, when an event, if my patient dies, my patient commits suicide, or we're in the middle of a hostage where someone brings in a gun, staff assault. It's so important, this, because the symptoms we get as nurses, doctors who go through these critical events, we end up with post-traumatic stress disorders. And no one wants to, as medical professionals, we don't view that we could get that, by viewing these events or being part of it. And a lot of nurses are leaving the profession, like you said, because of the impact of these events over time. It affects you for a lifetime. You get hit by a patient, the injury goes away, but these emotional events last a lifetime. They change the way you sleep, the way you eat. You socially isolate yourself. And if organizations don't take this seriously and put something in effect, there will be no nurses.
Yes.
Every nurse and doctor, everyone in the healthcare team is affected.
Yes, you are right, and I like your sharing your idea about post-traumatic stress disorder, because this is really one of the mental health team. You will find that the importance of their presence in any organization just to support even the providers as well as patients. Thank you very much for your contribution.
With Dr. Ali, that those are evidence-based in the literature. The lavender oil helps with relaxation. It almost sedates you. When you're feeling super anxious, chocolate helps too. It's holistic, but what we did in an extra step is to send us out as mental health providers and go to the nurses at that critical point in time, which helps too as part of the whole package.
Yes, thank you very much for your input. Yes, great to share experience as well here. So.
You are done?
No, not yet. Okay. So this is one of the Boston.
This one?
No. Yes, that's the one. That's the problem. Okay. See how they are even providing support, comfort room for those providers that ensure privacy, and as well as using the code lavender as a background, and plus the color of lavender color. Just all these giving a sense of relaxing or environment the staff are working on, and even sharing their whatever their concern or the stressful events. So I will just show you in the couple of slides how we implemented in Hira Hospital, and this is one of the Makkah Healthcare Cluster Hospital that implemented the program. But before sharing this one, I really want just everybody to be aware about patient safety culture survey, because any program you implemented, you need to measure the impact of this program. Is it effective or not effective? And you need to translate, because we are dealing with some emotional and psychological, and more about something you need to make it measurable so you can see the impact. So this 1 minute video showing what is the safety culture survey about, and this should be done. We are doing it in annual basis, and how the impact of this program in introducing such kind of program on safety culture of the hospital. Is anyone playing mode? Is it working? Yeah, it's not working. Anyway, this survey showing how organization is supporting the safety culture in the hospital or not, and then showing also the interdepartmental relationship between one department to other. Yeah, because sometimes the conflict can have a negative impact on safety culture, plus the provider experience within the department itself. So the staff not feeling they are overloaded or we have a conflict between them. Lastly, even some subjective questions like how you are feeling the organization is supporting you or not. So this is like some kind of questions that showing the safety culture.
Why should your organization choose the ARC surveys on patient safety culture or SOPs? Here are 5 reasons. 1, the surveys were developed with extensive input from healthcare professionals and experts to make sure they ask about the most important aspects of patient safety culture. 2, the surveys were comprehensively tested, so they will reliably assess clinician and staff perceptions in your organization. 3, the SOPs databases include survey data from hundreds of health culture. Why should your organization choose the ARC surveys on patient safety culture or SOPs? Here are 5 reasons. 1, the surveys were developed with extensive input from healthcare professionals and experts to make sure they ask about the most important aspects of patient safety culture. 2, the surveys were comprehensively tested, so they will reliably assess clinician and staff perceptions in your organization. 3, the SOPs databases include survey data from hundreds of healthcare organizations, so you can compare your results. 4, you can use your survey results to identify strengths and opportunities for improvement. And 5, ARC offers free technical assistance and resources to help answer your questions. Using the SOPs surveys will help you raise awareness and improve patient safety culture in your organization. Learn more at ahrq.gov/SOPS.
So in our organization, from 2016, we started this survey, and actually it is implemented in all Makkah Healthcare cluster, the same survey, because on 2019 it was mandatory even by national. Can you close the YouTube? So this was implemented in our organizations, and so we have like on annual basis it is done. So you can see the raise and drop in a lot of measures, and this is one of the tool that used by organization to measure the safety culture. Because when you say, talk about culture, culture mean it's considered like a set of values, behaviors, so perceptions of the staff about an organization. So all these has an impact on the culture. So these are the components that usually measured to measure the organizational safety. And if you see, this was done on 2018, and there are like the area that's green colored. This is like when we benchmark with AHRQ and really doing great. And then there are area like with the red color, and this is really, we have like some of them like away from the benchmark that we use the survey. So one of the elements that really we need to address that the supervisor manager expectation and action promoting the patient safety, and staff non-punitive response to error, and even the staffing, because here you as an organization, you see that you have good staffing, but the staff themselves, they are perceiving that they are understaffing. This means that some staff are doing the work that's supposed to be done by 2 or 3 done by one. So this discrepancy because of overloading some staff, and some staff are not loaded, so they will feel like they are understaffed. But actually, even if you have good staff, so this is staff perception about the staffing. All these things we need as an organization to develop a program to improve these figures, because after doing this survey, you need to have an action plan how we are going to improve this. We need to move to the safety to be a learning organization, a safe organization. So what we did actually, so we identified the strengths to promote, and we identified that you saw the weak area that we need to focus on for the coming years. So actually, we established this program starting from January 2020. After a lot of studies we did to make sure that this program, how we are going to implement it. So whenever you have like this program you want to introduce at organization level, you need to take an approval from governance. So we took from Quality Management and Utilization Review Council, which is chaired by a hospital CEO, and then you can assess the staff readiness, and you will study the gap, and then after that you can establish a program, and then we establish a team, and then after that the structure, and then the awareness about this one. Our references were one of those that organizations that are sharing this experience, because we will not start from zero, rather we will go through and adopt some already existing programs with the nice outcome and references. So these are the main our references in our implementation program. And then we had that like 6 supporting elements need to be there in order to establish such a program. So number 1 was internal patient safety culture preparedness, and this is what we show it to you, the measurable elements that we use to have a baseline. We took it as a baseline, and then subsequent years we measured how was the impact on after introduction of this program on our safety culture. So these are the checklists again adopted from these all the references. You will find it at the bottom of the articles about the slides. Every single slide I'm sharing you, there are references and references as well. So what we found in Hera General Hospital, HGH, is our we had a lot of survey culture data, and we took it as a baseline. And we have something called disclosure policy, and this is mandated again from Ministry of Health in 2019 to be disclosure policy is any error or harm happen to the patient, how you are going to deliver this bad news to the patient and family and to give them a support. So this program basically was meant for the patient disclosure, and there are some primary disclosure and secondary disclosure and a lot of things. We work for that. But actually, on 2020, we need to have something for the staff. So we adopt this second victim support program, and we call this program as a code lavender. We found that this is by voting, so we found this is the nice word. But actually, our code this is the silent code in the hospital. It's not something by overhead paging. It's a silent code that we give an access for any healthcare provider working in this hospital to email the event with the special, I will show you how in the following slide. So this is silent code, not announceable code. So this was approved by our the Quality Management Utilization Review Council in the hospital, and then we introduced this program on January 2020. Who are the support team? Actually, the chairman of support team was a quality and patient safety director, and it was advised to have one of the C-suite member to be a chairman, because they need to have direct reporting line with the hospital CEO. So any support you want to provide to the frontliner, it is communicated to the highest in the organizational structure. Some members, yes, they will have a good great input if included in the team. Plus, we have representatives from major clinical branches. like one from physician advocate, one from nursing, and so on. So this is how we select the membership of this lavender response team. And then we need to have a flow chart how we are going to announce. So any organization, they have like incident reporting system. So if you go to the left side, first victim support, usually if there is an incident happen within 24 to 48, the provider going to report an OPR or occurrence variance report, and then secondary disclosure will happen and the root cause analysis or whatever. This is the usual flow chart that we have in each organization about reporting system. But the proposal was made, what about the second victim? He need to have some flow chart also to report, because where he is going to report, it's something for him as well. So the first proposal was the employee activate the code lavender to have an additional support from response team and then so on. But actually, when we went through the literature, we found that most of the healthcare providers will suffer in silence. They are not going to report. And these are the one of the articles showing that despite this, only they found 73% of the provider reported that their institution, this is in the US, they have a second victim support program, but only out of 18% of responders, they said that their management or automatically referred team member to support service following an adverse event. Because this looking for proactive approach of the managers and supervisors, they are the one. Whenever they will find an incident or error, they are the one they should proactively approach the employee. Otherwise, the employee will not talk. And this is really happening only in 18%, and this is reflecting a negative pattern, because the employee will not feel be supported. But rather, if the employee approached by the senior or manager, even if he didn't call, he will feel delighted and he will be more happy that there are somebody taking care of them. So usually the clinician will suffer in silence, and they have negative feeling, guilt, embarrassed, self-doubt, and fear. Many support programs depend on employee support, a supervisor or risk manager to connect affected healthcare worker with the support service. So you need somebody in between to carry the message to the supervisor or the managers to get the support. So in this study, there was a conclusion that organizations need to adopt improvement as referral by departmental leaders and proactive approach to support the clinicians after an adverse event, regardless whether the support appears necessary. Regardless if the provider report or not, we need to be proactive and approaching them. So the final flow chart, we agreed that whenever there is a second victim and employee or any advocate, and we mentioned about advocate down, like code lavender support team, patient safety officer, risk managers, and for example, multidisciplinary committees. We have a lot of committees, and then we are studying some cases. We need to go on back and look after those who are really involved in that event and deep dive more about how they are feeling. Are they feeling responsible about these events? We need them to speak up. So we can pick up those cases, and then we put like a checklist. Whenever there is one of these things need to be activated or alarming, that they need really support. So from the previous reference I showed it to you. And then actually this is one of the wonderful that guide us a lot in the support program. This is Scott 3 tiers. 3 tiers of support. This is like first tier, and this was our focus, main focus in our organization, because you need to involve direct manager and supervisor how to support their team. And this is something, the skills that you need to teach them sometimes, because not everybody trained for this kind of support, because this is, we are talking about emotional and psychological support. Imagine this support done by non-psychologists. So it's easy for mental health people to do this practice, but actually we are not trained usually for this kind of support. So emotional support needs some kind of skill, but we are not here talking about support by non-mental health physician. When you will involve the mental health, there are criteria when you are going to refer to the expert. You need clinical support. Till this level 1, departmental level. Level 2 is the trained peer support team, which is like called Lavender team. They are a trained team for that. And then referral team number 3, there are certain criteria that you are going to refer the provider to the mental health specialist to be treated, because this, when I will show you now soon. So actually, when you are going to the literature, you will not find any cookbook solution. So each case scenario needs to be dealt individually. So again, this needs some, but of course, you need to have some guideline for the team member who are running this practice. So actually, the support team, their role only to do screening or first aid when you are going to refer and when you are going just to stop. So this is classified in eustress or distress or dysfunction. Eustress, that you will find from one session, you will find the provider motivated, no action is required. One session and enough. If you will find the provider sometimes crying, sometimes laughing, sometimes is distress, this give him another session. So 2 sessions maximum. Third time, if still he is not performing well or impacted with or not working or absent, at that time really you need to refer him to mental health. And then again, we refer to some criteria that when you are going to refer the provider to mental health specialist, in summary, there are 6 points. If the condition start to affect physically on the provider. Physically mean he cannot sleep more than 1 week, he cannot eat well, he's all the time impacted, he cannot perform his job properly. There are some somatic symptoms like nausea, vomiting, headache. These are sometimes suicidal ideations. These need to be taken seriously and referred to mental health specialists. So we are giving this checklist to the peer supporter who are going to provide support for the employees so they can pick up those symptoms. And I remember we will refer one of them to mental health because he is not sleeping, not eating, and he's just staying in hospital till 12 midnight to do work because he wants to forget about one incident happened and a lot of things. So those need to be really picked up and referred to appropriate care. This support program, as I mentioned, done by non-healthcare, non-mental health specialists, so need to have some references to the team who are support. So these are what we did actually in our organization. We include the Code Lavender in hospital-wide orientation program. Plus, we included even in hospital-wide safety orientation program. In safety organization, we have like a code, hospital code, red, brown, black, yellow. So we add Code Lavender, and it is part of also safety codes. So we included there, and it is in every employee. They have their code card. It is there. Plus, we make it mandatory even departmental orientation and hospital safety code. All these were spread to all. The good, what we can say, the positive thing for this program was launched actually during the COVID crisis. And this was like, it's really needful program at that time. So it came together because matching our, so we start to do this one, but you know, because of this crisis, we start to use the, what can I say, virtual to meet those, especially those providers who are infected and, with COVID. So we need to reach them and to check with them and to support them because we are sure that, and looking after them. So we start to use this kind of virtual call with them just to make sure that they are good and we found a lot of things like one mother, she's isolated, she's a nurse, and then she was like her child, 5 years old, knocking the door, mom, just touch me, what happened? She cannot open the door to her child and she was crying. And then at that time we said to the hospital administration, even the healthcare provider need to be isolated in single villa and give them special support so they will not suffer and family not get impacted with such incidents. So a lot of support things done during the COVID era. And this is how, you know, the hospital information system, when you are going to enter the hospital information system, you will find down again the code lavender. So anybody just opening the system, he will find, if he want to call the code lavender, he will just press the button and then he will fill some information, and then the email will go to the code lavender team to initiate the response. And also there is a manual about the content, and this is simple basic data need to be encoded because this data are confidential, and even after releasing the result of this data, we are not mentioning any name of employee, rather just we want to make sure that everything is going in a systematic and structured way. And there are some special training for the staff for giving support, and some initiative as well done by the Code Lavender team. Like this is COVID unit, and then we give them some fan and everyday water and a lot of things, because really they are doing a great job, but actually they're suffering in silence. And these are organizations, they're offering also online training program for the how to do or how to practice. So we make it mandatory for the support team to get such kind of certificate to how to apply the first aid for the second victim. And of course, you need, after implementing all these things, to measure the impact or the effectiveness. And this is quite challenging because this is we need to have some data, otherwise it will be everything like subjective. So how we are measuring the impact? Actually, this was like a random survey done for those who received the Code Lavender, and it was from January to June. This is a time period when I were working there, and then so this was like who are the healthcare provider. If you see, most of them, 80% nurses and physicians have, and how the impact of the event was stressful for the providers. And then you will find down some very distress, and this is how, and then from whom they receive a support. This question was have multiple, you can select more than one answer. So actually, one of the things that really was interesting, that only one staff mentioned that he received a support from family. Most of them, they support received from colleague, and this is what our aim is really to have supported by. But 10 of them out of 18 was responded that they have support from their managers. And this is also showing that if you have like 1% only, or one candidate only said he received a support from family, maybe this is a very important part, because usually the provider, they're not sharing their suffer with their families. Usually there's, because, I don't know, but maybe because of the feeling more, the other part will understand him more if he talk to somebody, colleague, or from sharing the same level of experience or whatever. So this is very important to address the importance of organization to support the staff. Lastly, the staff satisfaction level on the program itself. So 100%, between 47 and 58, that's satisfied or very satisfied about the program, and 100% recommending the programs to the other. So there are a lot of published articles as well showing the relationship between how the second victim support program has an impact on organization safety culture, and with statistically significant data shown here. And this is the last, when after we introduced this program in Hira Hospital, if you see the purple color, this is the comparison between and after introduction of second victim support. If you see, there are a few increase in the supervisor organization learning, continuous improvement, teamwork, work within the unit, management support for patient safety, feedback and communication about error, the frequency of event reported. There are those, like we can say, positive changes in the patient safety culture survey after introducing the second victim support. Yet, this is like overall, the 12th component of the patient safety culture survey, the trend in the organization. Just we want to see the sustainability plan, and you will find that this is one of the organizations that we can say having a learning culture. They're learning from their, we can say their, and providing support to their staff, so the staff feeling they are working in a safe organization. And this is a positive trend we are looking usually lavender in that institution, and to the extent that if like the nurse get too much overwhelmed, admissions, discharge, and clerking, and data, whatever, she said, I want just to activate code lavender. So it became a part of their culture as well, that they are calling for support. During COVID, even they start to activate the code because they are working in ICU. And then they said, when we open the door, the air coming to us, and we are afraid that get infected. And then that patient already ventilated. So there is a closed air circuit. So they need some kind of support that to make sure that reassure them all the time. So this program actually was a great help, because we start to listen to the employee and their suffer. Even simple things, we are listening to them, and we are caring for them, and we are supporting them. And their voice even reaching to the hospital CEO to get approval to shift this nurse from this department to the another because of this conflict and these kinds of things. So really, this kind of program, with showing data, going really, we need all the organizations to develop such a program, and hope, inshallah, in the future, we have more and more to discuss and present about this. Thank you very much.
All right, Basma, thank you so much. That was absolutely wonderful and well needed. It's something we all need to promote. So thank you very much, Shukran, for what you've done. So here's your certificate for your...
Thank you.
Shukran. Thank you. That was really interesting. Our next speaker for this afternoon is Sarah Adris from Saudi. She's going to speak today on Saudi Arabian healthcare transformation journey. Sarah? I sent it in the email.
Hello, everyone. My name is Sarah Idris. I work as a healthcare project manager in the Ministry of Saudi Arabia, Ministry of Health in Saudi Arabia. I have a bachelor degree in healthcare administration from University of Houston Clear Lake, back in the States. And I'm currently pursuing my master in King Saud University in healthcare administration as well. So first, let me just do this. Okay. So it's an honor to be here with you all. I'm glad to participate in this sharing of knowledge. And let me start with, I already gave a background about myself. I would like to start by quoting a role model, actually, to me personally and the new generation in Saudi Arabia, Crown Prince and Chairman of the Council of Economic and Development Affairs, Mohammed bin Salman bin Abdulaziz Al Saud. He actually quoted, "The Vision 2030 is a bold yet achievable blueprint for an ambitious nation. It expresses our long-term goals and expectations, and it is built upon our country's unique strength and capabilities. It guides our aspiration towards a new phase of development to create a vibrant society in which all citizens can fulfill their dreams, hopes, ambitions, and to succeed in a thriving economy." This is what we're going to be covering today. We're going to be talking about the 2030 vision, the Saudi 2030 vision, the health sector transformation program, the need for change, the current to future state, the new model of care, and the achieved goals of 2030 vision in 2021. So the Saudi Vision 2030 was actually launched in 2016. It's as a roadmap for economic and development activities with goals, commitments, and responsibilities laid out. The Saudi Vision 2030 is based on 3 pillars: to have a vibrant society, a thriving economy, and an ambitious nation. They function in harmony to achieve the desired objective and maximize the benefits of the vision. So the 2030 vision have 11 programs. The National Transformation Program is one of these programs, and the Health Sector Transformation Program, which was recently kicked off. So the Health Sector Transformation Program wants to achieve the following: to have a healthy, improved life for the beneficiary, improved healthcare in the Kingdom of Saudi Arabia, improved efficiency of healthcare providers, a strong and a resilient health Saudi system. The health sector transformation is actually built on 4 strategic objectives, which is facilitate access to healthcare services, improve the quality and efficiencies of health services, promote prevention of health risk, and enhancing traffic safety. And the promoting prevention of health risks is actually one of the main pillars of this transformation, because it's actually what's the model of care, the new model of care is built on. The aim of the transformation is to develop a system that responds to the quadruple aim. So before it was a triple aim, without the better experience of care, without the increased employee satisfaction. But they figured that without having employee satisfaction, all these 3 aspects, they're not going to be achievable. So why do we need to change? Why is the health system is changing? We're actually having an increased number of chronic diseases because of the unhealthy lifestyles that we are living. We have 70% of no regular checkups, 60% overweight or obese. We have premature death, 46 of NCD deaths in case they are premature compared to under 25% of Western Europe. We have increasing chronic conditions, and we have ballooning cost, which is spiraling cost, an average increase in the government healthcare budget, 7% since 2010. So what is the objective of this transformation? So currently, the Ministry of Health is doing 3 roles. Basically, they're doing the regulating, they're providing the service, and they're actually paying for the service as well. So the key objective of this transformation is to separate the regulator, the payer, to a provider. The provider side will be basically an ACO, as Dr. Basma mentioned, which we'll be getting into details right now, an accountable care organization, and the payer will be the National Health Center for Insurance. So as we mentioned, that historically MOH has regulated, funded, and managed provision for the majority of the health system. However, to help realize Vision 2030 objectives, they designed a new system architecture that separates the regulator, provider, payer function as follows. So the MOH will retain the regulatory function. The MOH providers in each region will be grouped into a cluster. What does a cluster include? They have primary healthcare, they have medical cities, they have clinics, specialized clinics, high specialized clinics in one region, which is going to be serving a population, the population health needs. The third thing was just going to be the payer. The Center for National Health Insurance will act as a single payer on behalf of the public, financing the system based on the value, quality, efficiencies of outcome. So the health holding company. The health holding company was established actually to help the providers during the transformation journey. It's a temporary organization that will help manage the healthcare assets and oversee the transformation to the end state. So an accountable care organization, and it's a provider organization that takes collective responsibility for the care delivery, quality and cost for that care for a given population for a defined time under contractual agreement with a payer. They're going to be held accountable for achieving a set of pre-agreed quality outcomes with a given budget and rewarded based on the quality and financial performance. So basically, the Ministry of Health is shifting to a value-based healthcare system, which they are actually caring more about the outcome of that service that the patient is getting. The goal of the ACO is to achieve the quadruple aim, as we mentioned before. So the structure of the ACO is going to have a board, the health corporation, which is going to be to increase the financial efficiency and operational, and to have operational flexibility. Okay. And we actually, yes.
Let's talk about this point.
Yeah.
More details. Yeah. Now the system the health system in Saudi Arabia is how it works. So there is the private national companies.
Yes.
Who pay for the patient.
Yes.
But the Vision 2030 is to remove all these private national insurance companies, and then it will be national departments. The government will pay for all their patients?
No, okay.
No.
So what's going on right now is we have the private sector and we have the public sector.
Yes.
Right? The public sector is regulated by MOH.
Yes.
The private sector is also regulated by MOH, but they have, it's more regulated. Like they have auditing, and the Vision 2030 was actually established for the public sector. Okay, but the end state is to have unified health law for both the private and the government sector. So that's going to be the end of state. So whatever right now is, we have guidelines, we have policies and procedures that are already implemented on the private sector, but these procedures and policies are, these guidelines are not implemented on the public sector. So they are in the process of developing these guidelines to enhance the performance of the government sector, basically. Do you get what I'm saying?
No, let me understand the point. So if somebody is sick on 2030, he go to the hospital in
primary healthcare, yes,
and he will receive the treatment for free, yes, even if he doesn't have any insurance.
Yes, the end state is that every citizen will have a national insurance that will cover. Basically, there are some hospitals right now that they don't cover all the citizens. Like not anyone can access this hospital.
Yes.
The new vision is aiming to help the patient have access to care in all regions, in all hospitals, basically, and within their region, of course, within their cluster. You get what I'm saying?
Yes.
Okay. So
let me tell you a little about the insurance system in Sweden, which is the best in the world. In Sweden, private and public sector, they provide health services for free.
Yes.
And the national insurance department pay for everybody, whatever you are, as soon as you live in Sweden and you have the permanent residence.
Have you heard of the NHS?
Yes, of course.
Okay. So UK, basically, so when the Vision 2030 or the health sector transformation started, they actually benchmarked UK, Sweden, all these countries. So in UK, you have the NHS, which is the NHS Trust, right? Yeah, the NHS Trust. So basically, the NHS Trust is exactly as the cluster.
Yes.
It's going to be,
this is the public.
This is the public, yes.
But for also private sector in Sweden, they pay for them to treat their patients.
Yes.
This is
and that's where it's going to be the private sector participation is going to come in place.
Yeah, but not in 2030.
Within 2030.
Ah,
yes. Yes. Sure.
Actually, there was in Saudi Arabia for decades, the Saudi nations, they didn't used to pay anything when they are going to public or governmental hospital. This time, with the introduction of insurance company, now there will be an insurance for all national Saudi citizens to be treated. There will be again when they are visiting the hospital. There will be a payment, but this payment is not offered by the citizen, rather by it will be run nationally through the government. So there will be a payment and charge for the healthcare service, not like before, because charge free and not counted. So this is
basically there's going to be a benefit health package for each patient, for each citizen. There's something called health benefit package, which is going to be cover everything that the patient needs. It's going to be the insurance basically. So they're going to be having eligibility and like it's going to be similar as an insurance basically, but it's a national insurance.
It will be for Saudi citizens or for everybody?
For Saudi citizens. Hopefully. Yes. So here are some data insights. I actually benchmarked UK, and you can see here the average. Yes.
Thank you very much. I just want to, I appreciate if everybody agree with me, the questions should be after the presenter will finish here on his presentation, because really disrupting the idea. So if you call me and following me and interrupting, also we don't hear your comment question and inspire my idea. I appreciate you agree on that. Thank you very much.
Okay, so one of the actual initiatives in the health sector transformation is to increase the average life expectancy of the citizen. So in UK, you can see the average life expectancy at birth is above 80, and here in Saudi we have the average life expectancy is 75 almost. So by the end of the 2030, we hope that we increase the average life expectancy to 85. The mortality caused by road traffic injury which we mentioned before, one of the strategic objectives of this transformation is to decrease the road traffic injury. We can see here UK, the mortality caused by road traffic injury is very low comparing to Saudi. And the number of maternal deaths here as well is significantly significantly higher than the UK. And here the mortality for the cardiovascular diseases, cancer, diabetes is as well in Saudi Arabia is like higher than the UK. The model of care, the model of care was actually established to shift from the curative to a prevention wellness system. And the values are compassion, collaboration, respect, empowerment, transparency. So the national movement established something called a Vision Realization Office. A Vision Realization Office is basically an entity or like it's basically a governing body, or not a governing body, sorry. It's an office that will help the providers or help the regulator, the provider, the payer to transform the healthcare system. So in order for us to transform, we need enablers. What are these enablers? We need the government to work with us. We need a strong governance system. We need to enhance the quality and quantity of the workforce that we currently have. We need data and digitalization, which was really accelerated during the pandemic. We need to increase the private involvement by facilitating ownership or management of MH hospitals. And the last thing, we need to establish a value-based provider payment system, set up national health insurance with a gradual rollout. So as you can see here, here we have a 70-year-old woman. Her current health delivery system is not integrated. So basically, the patient is all over the place. They don't know where to go. The systems are not connected. It's fragmented. And this placed the patient in very high risk of having chronic diseases, mortality rate. The patient, there's no actually organized system or organized pathway for the patient to go through. Here, on the other hand, pleasant care experience in the target system, where you can see the patient is in the center. And all these organizations are coordinated. Sorry. I just wanted to move this here on the screen. Yes. So the healthcare here on the current healthcare system, it focuses on hospital treatment provided after the onset of illness. So there's no prevention. And this is what the transformation is about. To have a prevention system for the patient, it will decrease the cost, it will decrease the mortality rate. And the new system here, it focuses on the prevention and treatment, efficient quality care, benefiting from integration.
it Nadine?
Yes.
Nadine?
Pronunciation. I don't want to be disrespectful.
All right, welcome back everyone to the afternoon, late afternoon session for the day. We have had such a wonderful day. Thank you, UCG, for putting this on again. And our next speaker is going to be Naveen Rashad from Egypt, and she's going to talk about artificial intelligence in healthcare.
Thank you. Hello. Good evening. I hope you will take your coffee and get refreshed. I am Dr. Naveen Helmi Al-Modi from Egypt. My background is I'm a pharmacist. Okay. I take a master in hospital management and CPHQ. And I'm now in a diploma in equality and accreditation. This is the first time for accreditation diploma in the Middle East. So I am presenting today, it's the future topic all the time, is artificial intelligence. I think it's the topic all of us should have to hear or read about it or know even the simple definitions of it, because all of us after 1 or 2 years will transform all our work as a digital work. So we have to know some simple definitions or some idea about the artificial intelligence. So I will begin about artificial intelligence. This is a branch of computer science focuses on building machines that can perform tasks that typically require human intelligence. What is the tasks that require human intelligence? Like decision making, it's a character of human who can make a decision. So we want to machine to make a decision. So we use machine to make a decision in replace to human. So we use artificial intelligence, speech recognition, visual perception. The machine can recognize visually and transform this information into a decision or into interpretation, and language translation. And after that, we can know how it recognizes the language. What's wrong? Okay. Artificial intelligence health technologies are becoming increasingly prevalent in clinical settings worldwide, and the global spending on these technologies predicted to exceed $36 billion by 2025. It's a huge number for investment in technology. In the healthcare industry, artificial intelligence has provided healthcare practitioners with tools they can use to reduce pressure on their workload and redefine their workflows. So the target of the artificial intelligence, all of our aim or our target to reduce pressure or redefine the workflow. Here some fields of artificial intelligence and simple definitions. I searched for a simple definitions to understand all of us, because you are not specialized in artificial intelligence, and so I am not specialized, but I'm interested in the field and I want to know about this topic and can have definitions to understand. There is 6 branches or 6 subfields of artificial intelligence: expert systems, robotics, natural language processing, fuzzy logic, machine learning. As this word is expressionist is we deal with it all the time in neural networks. The first of all is expert system. Expert system considered the first successful model of artificial intelligence software, designed in 1970s, and after that escalated in the 1980s. For the 10 years, there is escalation of the expert system. What is the expert system? It refers to computer system that mimics decision-making intelligence of human experts by deriving knowledge from its knowledge base, by implementing reasoning and insights rules in terms with the user requirements. We can give it a knowledge. The expert gives the machine the knowledge, expert's knowledge accumulated in the knowledge base, and after that we can take the output of the system. So it depends mainly on the expert knowledge. So this is the first model of artificial intelligence. For example, expert system provides suggestions for spelling and errors in Google search engine. This is used in Google search engines by getting the system the knowledge, and after that we can use it in spelling and errors. This is one of its applications. Well, this is over the 10 years the escalation of an expert system application from 1970s to 1980s. After that, the subfield of artificial intelligence is the fuzzy logic. This is a strange topic or a strange expression. Fuzzy logic sometimes face condition where it's difficult to recognize whether the condition is true or false. Okay, there is no black and white in the healthcare. There is a gray period or a gray space in the healthcare. Okay, if we consider the statement, if the back pain is severe and the patient is old, then apply acupuncture to certain point for a long time. This sentence, if we define it to process this statement in a computer system, we need more than programming skills. All terms we need to model like severe. What do you mean by severe? You can't explain severe. What do you mean by old? You can say I am old. You can say someone older than me is old. So it's vague expression. I'm saying old. Certain point. What certain point? Long time. Vague and fuzzy. These expressions are vague and fuzzy, and they can determine the exact meaning of the statement. So, fuzzy logic is a technique that represents and modifies uncertain information by measuring the degree to which the hypothesis is correct. It is simply generalization of standard logic. We give it a standard logic. So if it is correct, it take 1. If it is incorrect or completely false, it take 0. If it is between, we can grade it. So we can, after that, give the statement points to know the meaning of each word in the statement. So this is the hypothesis of fuzzy logic. The third subfield of artificial intelligence Absolutely all of us know robotics, an interesting field of research and development, mainly focused on designing and constructing robots. Robotics interdisciplinary field of science, engineering, with mechanical engineering, electrical engineering, computer science, and many others. And I think tomorrow there is a lecture, intensive lecture about robotics will be very good, I think. Robotics determines the designing, producing, operating, and usage of robots, deals with computer systems for their control, intelligence, outcomes, and the information transformation. We use robots to deal with information to give us intelligent outcome. So this is a brief about robotics in artificial intelligence. The fourth subfield of artificial intelligence is machine learning. What is meant by machine learning? This enables machine to learn and make predictions by recognizing patterns about the data without explicit programming. So I want the machine to make predictions without programming on this machine. How it will be done? Machine learning is particularly useful for identifying patterns in large data sets by employing techniques that allow for more indirect and complex nonlinear relationships and multivariate effects than conventional statistical analysis. Machine learning is important in large data when it's a huge amount of data can't be managed by the human. We can use machine learning to deal with it and identifying the pattern and classifying the data. So this is the topic of machine learning. Multiple algorithms working together in sample machine learning can be used to calculate predictions and accuracy levels thought to be unattainable with conventional statistics. These statistics done by machine learning can be done by humans. So we can use machine learning. What is the application of machine learning in healthcare? For example, it can predict patient lung cancer staging by using International Classification of Disease, ICD, claims that alone with 90-30% sensitivity, 92% specificity, and 93% accuracy comparing with the human prediction. There is subtypes of machine learning, which is supervised learning, unsupervised learning, and the third is reinforcement learning. First of all, supervised learning, which is a subfield of machine learning, utilize partial labeling. This picture will tell us about supervised learning. We can enter into the machine data, label data. We say to it, this is gallbladder, this is gallbladder. And after that, the machine, if he saw a lot of pictures, he can recognize the picture of gallbladder. This is the output of the machine after I entered the data. So this is human labeling of training data. As I am training the machine to recognize the image. This is called supervised learning. But what about unsupervised learning? Unsupervised learning is the machine is clustering by himself without labeling. He can identify or classify without any input. So he can see number of images. So he classifies this is bleeding, this is not bleeding, without entering any data. This is what is I wrote here, utilize supervised learning, utilize partial leveling of the data, useful for training a machine learning algorithm to predict known result or outcome. In this type of learning data, experts feed labeled training data and define variable to algorithm for accessing and finding correlation. Both the input and output of the algorithm are particularly defined. So I enter data and take outcome. The other type, unsupervised learning, is the structure detected in the data itself. The searching for pattern within the data. The machine itself searching for the pattern and classify the data itself. This includes algorithms that train on unlabeled data. Algorithm analyzes data set to draw meaningful correlation or inferences. For example, one method is clustering analysis that uses data analysis to obtain hidden or grouping pattern or group in data sets. It makes clustering by itself. The third subfield of machine learning, programmers design an algorithm to perform a task and give it positive and negative signal. So I tell the machine to make a task, but make some defining or refining of the result or the task by positive or minus signal. I give it to the machine to act as algorithm execute to complete the task. Sometimes the algorithm even determine on its own what action to take to go ahead while learning from its own success and mistakes. It's like a human. If he did something wrong, the second time he can correct it and make the right thing. So it's like a practice for the machine to do the right thing every time, more and more. It will be perfect. So this this field can be used in driving a car. So the automatic driving of the car can like fine adjustment. It needs fine adjustment. So I can give it positive or negative for making parking. For example, I want it to make parking, so get right or get left, some right or some left to make the task. So after that, the fifth subfield of artificial intelligence is the natural language processing. Natural language processing subfield of artificial intelligence, crucial for large-scale analysis of content, such as the application of natural language processing is electronic medical record data, especially physicians' narrative documentation. What is mean that the physician narrative or unstructured documentation in the patient history or in the progress notes, any narrative documentation or unstructured, NLP can define this writing and extract from it the definitions or the meaning of the writing, even if it is not structured. So successful NLP system must expand beyond simple word recognition to incorporate semantic and syntax into their analysis. So it's not enough to translate the normal words. The successful NLP must recognize, the semantic and undefined words to make the explanation after that. For what we can use NLP in healthcare? What is its application in healthcare? For large-scale database analysis of the EMR to detect, for example, adverse events, post-operative complications. NLP is incorporated in many EMR systems now to achieve automated claims coding into their software to improve billing. So from the EMR, NLP can determine the adverse events, can determine the post-operative complications, can define the coding specialty by ICD, so we can improve the billing by accurate explanation of the specialty or the diagnosis. So it's very important, of course, for insurance system to use NLP. Sixth subfield of artificial intelligence is called artificial neural network. What is meant for artificial neural networks? It's like a neuron inspired by biological nervous system. It's like the biological nervous system of the human. How it's like the biological nervous system? Importance in many applications. So I will define this by process signals in layers of simple computational units, layer neurons. Connections between neurons are then parameterized via weights that change as the network learn different input-output maps corresponding to tasks such as pattern image recognition. I will explain this more deeply by receives data input similar to dendrites in the neurons. So it receives data like dendrites in the human, perform calculations inside these layers, the inside layers, perform the complicated calculations. After that, transmit the output like or similar to exons to the next neuron. So here we make input, so make the complex calculations here and give the output. According to the layers in between, it can be called deep learning. Deep learning networks are neural networks comprised of many layers and are able to learn more complex and subtle patterns than simple one or two layer neural networks. So as many layers in the neural network, so it comes deeper and deeper and it can make more complex or complicated calculations. Any industry has pros and cons. No industry have only benefits, but there is another harms or unbenefit from any industry. So I'll start with the cons of artificial intelligence from the point of many healthcare providers. Sometimes not agree with them. Sorry. The cons is increasing of unemployment because we can use machine instead of humans, so can increase unemployment. High initial investment because artificial intelligence investment need initial investment with large amount of money, but after that it can make containment of cost. Dependency on machines, of course, artificial intelligence make us depend on machines and take some tasks from human. Lack of creativity. This is the point of view of some healthcare providers that artificial intelligence make us lack of creativity. So I like the pros of artificial intelligence because it's much more valid than cons, aid in decision making, decrease the administrative burden on clinicians, cost containment, patient data, and well explain what is it, precision medicine, providers satisfaction. First of all is clinical decision support. Artificial intelligence is a support in clinical decision. It's a technology is already being used to support decisions made in data-intensive specialties like radiology, pathology, and ophthalmology. It delivers data to providers to aid in diagnosis, treatment planning, and population health management. Artificial intelligence enabled software can provide access to data from multiple sources, including medical images, EHR, electronic health records, data, and even consumer devices such as activity trackers, smartphones, and the connected medical devices. This will enhance the decision making. We can collect data from multiple sources to reach to the perfect or to the correct decision. Even there is application on smartwatches now to measure the heart rate or measure the blood pressure and collect this data and then transmit it to the hospital by the network and take the decision in the right time. The second pros of artificial intelligence, of course, to decrease the administrative burden on clinicians. With natural language processing, the technology can help translate clinical notes in electronic health record. That means the clinician only needs to enter data once to decrease the administrative burden on clinicians. As we said, NLP can understand the narrative documentation of physician from the patient history, and they can extract what is meant by the physician or what is predicted for that patient. So the physician wants to write again in each paper. So it's helpful in decreasing the administrative burden on clinicians. Of course, this is a big benefit from artificial intelligence, which is cost containment, even if the initial investment is huge, but after a long time or on the long run, it makes a cost containment. So this was an interview on HIMS TV interview. Dr. W advice for those beginning artificial intelligence implementation projects. You need to pick a problem with a really solid 5 to 1 return on investment. So you have to choose the problem which you will use artificial intelligence with. So you want to choose one problem that the investment on it will give you output is huge according to the natural way. So fall in love with the problem, not necessarily the solution. You want to love the problem to can reach to the perfect solution by artificial intelligence. So, okay, what is the application for cost containment by artificial intelligence? Artificial intelligence can help nurses determine the appropriate number of days a patient should stay in the hospital. That can enhance care planning and management to prevent complications, improve patient satisfaction, and reduce costly readmission. So this is an important application for artificial intelligence for cost containment. Fourth point is, pros patient data. This is where the power of innovation such as artificial intelligence comes into play. So what is all of what we need from artificial intelligence to collect the data and take a decision and give me information about collected data. So this is the power of innovation. As we see, smartphone use algorithms to get where we want to go or what we want to say. All of us carry smartphone. If you type anything on Google, it will give you another options and another options to like what you write. So it's collecting data from you and give you what you want to see or what you prefer. He predict what is your interest and help you to find it. So this is the point by artificial intelligence in healthcare. We can collect the data from patients and make the right decision. This will allow physicians to experience much less human for the patient. So allowing one experienced doctor to treat many more patients. And this is very, very important for shortage of doctors, and it was obvious in COVID-19, the shortage of physicians. So it will be very beneficial. Fifth is precision medicine. Precision medicine is emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle for each person. Artificial intelligence algorithm can take precision medicine to the next level by increasing the accuracy and the prediction of outcome through mining large quantities of. He can take the information from genetic, clinical, social, lifestyle, and preference data across a broad heterogeneous population where deliver major benefits to advancing precision medicine, not only in predicting the outcome of current patients, but even in predicting the probability of future patients having disease. So we can take the data from all these field, genes, environment, lifestyle, to predict what is the illness for the generation, or what is the illness, and generalize it for the whole population from the same from the same cluster. So it will help us to make preventive medicine, that we can prevent the illness before it appears. So providers can know the best care plan, not only for individuals, but for the entire population. Provider satisfaction, and it is very related to the topic before, the second victim. Our aim also for the healthcare provider is provider satisfaction. A human being can take into account about 7 different factors in making a decision. With the volume of data and the complexity of data in a clinical situation now, too much data now for the human being to make a decision. This is the benefit of artificial intelligence and getting its value out of the data, not replacing the human making the decision, but to support and guide the human to take the right decision. Okay, so it makes the healthcare provider return humanity to healthcare. He has the space and time and the feeling and relaxation to get back to the bedside and feel the communication with the patient and relief or release the burden of the administrative work, and return humanity to healthcare. Helping clinicians return to their patient bedsides, and this is actually will lead to patient satisfaction as well. And this is will lead to provider and patient satisfaction. There is many applications of artificial intelligence in healthcare, and I can't collect them all, but here some examples of application of artificial intelligence. So artificial intelligence assistance in keeping well, helping people stay healthy with the rise of Internet of Medical Things. In consumer health application, this application is growing in leaps and bounds in the last decade. Healthcare apps tracking cardiac health, fall detection, and emergency SOS. A report by Allied Market Research says IoT healthcare market will reach $136.8 billion worldwide by the end of 2021. So we are in the end of 2021, so it reached to $136.8. Second application of artificial intelligence is assisted robotic surgery. Artificial intelligence can reduce case-to-case variations in the surgery and even help improve the efficiency of even the best surgeons. Even the surgeons is very perfect. Artificial intelligence can assist him to be perfect or be more accurate. Artificial intelligence enables robots perform a basic acts of precision cutting and stitching. In 2017, surgeons using artificial intelligence assisted robotics to suture extremely narrow blood vessels from 0.03 to 0.08 millimeters across. So it's like in the retina or the eye blood vessels. It's very, very small, can be done by the hand of the surgeon. So the robotic can assist the surgeon in this application of healthcare. Of course, the surgeon still controls the robotic suturing. There are numerous lethal complex tasks during a surgical procedure which absolutely requires the skills of surgery. That don't mean that we don't want the surgeon to do the surgeon anymore, but the robotic can assist and they can help, and very accurate or very small surgery which can be reached by the hand of the surgeon. So we can't say the surgeon can't do these surgeries. Third is clinical judgment or diagnosis. So we can use artificial intelligence for early detection of disease, including cancer and retinopathy, and the use of artificial intelligence in analysis and review of mammograms and radiology images can speed up the process up to 30 times and with 99% accuracy. So with artificial intelligence, we can, with its analysis, we can predict or know the diagnosis more accurately, and this is more safer for the patient, of course. In a study in Stanford University describing successful use of artificial intelligence algorithms to detect the skin cancer against the diagnosis of 21 dermatologists. So this is the result of the study. Google's DeepMind technology successfully trained a neural network to detect more than 50 types of eye diseases by analyzing 3D retinal scans. By analyzing these retinal scans, they can detect more than 50 types of eye diseases. So it's very important and very beneficial in eye surgery or eye diseases. The fourth application, artificial intelligence in sepsis early prediction and diagnosis using unstructured data in healthcare. Of course, sepsis is a leading cause of death in hospitals. So there is a program or algorithm is called the SARA algorithm, which uses both structured data and unstructured clinical notes to early predict and diagnose sepsis. These algorithms with independent clinical notes achieve high predictive accuracy 12 hours before the onset of sepsis. So this algorithm can predict sepsis before 12 hours that the physician can predict. So it's very important for time in sepsis to make fast treatment for the patient. By AC 0.94, sensitivity 0.87, and specificity 0.87. Comparison between the algorithm in SARA against physician prediction show the algorithm potential to increase the early detection of sepsis by up to 32% and reduce the false positive by up to 17%. Early warning 12 to 84 hours before the onset of sepsis. So the algorithm can detect 32% of people of positive and false positive by 17%. And this will explain this graph by using the algorithm. We use this bar graph. This is the percentage of sepsis patients recorded by the algorithm, and this is by the physician. So the difference is obvious. Here is by the algorithm, percentage of non-sepsis patients predicted to be high risk of sepsis. This is predicted by the physician. So this is false and this is more accurate. So the difference is obvious by this graph. Finally, we say while human intelligence is best suited for integrating small numbers of very large effective factors, artificial intelligence is particularly adept at combing through and identifying patterns in vast numbers of very small effect and obscure factors. So the human intelligence can collect small numbers of factors with big effect, while artificial intelligence can collect a very large number of small effects, but of course it's very effective and they can save many lives. Okay, thank you. Thank you.
Thank you so much, Dr. Naveen. That was wonderful. Appreciate that. Just set this down. We want to present you with your certificate for speaking with us today.
Thank you. Thank you.
Thank you very much. Our next three speakers that we have remaining for the day will be online. So the next speaker that will be speaking with us today will be Amal Ibrahim from Palestine. Nope. Sorry. We're going to go down to Shazia from Saudi. And she's going to speak with us online as employee safety during COVID. Shazia.
Ms. Ajia, could you please unmute yourself?
Yes. Good evening. Hello. Can you hear me? Yes. Okay, let me share my screen. Okay. Can you see my screen? Yes, we can. Okay, so my voice is clear, I hope. Perfect. Okay. Bismillahirrahmanirrahim. Assalamu alaikum warahmatullahi wabarakatuh. Good evening, everyone. Thank you very much, UCG organizers, for having me today to share such a wonderful platform with all the experts from healthcare, management, nursing, and other fields across the countries. My talk is on employee safety during COVID-19 pandemic. As all of us, we know that in the context of COVID-19 pandemic, occupational safety and health takes on even greater importance. It is a core aspect of a decent work, and as such, it should be universally guaranteed. Also, the pandemic has taught us, and still we are keep on learning from it, that how important and the safety and well-being of healthcare workers, especially in healthcare industries, as well as in other industries. I don't have any conflict of interest. We are going to cover 4 main learning objectives by explaining the basic facts about COVID-19 pandemic, assessing the risk of workplace. Assessing the risk of workplace exposures to COVID-19, defining the key steps in worker protection and infection prevention and control, identifying the method to prevent and respond to COVID-19 exposures at workplaces. Okay, as we know that in March 2020, the COVID-19 was declared as pandemic by the WHO. Till then, it had caused severe illness and death. It features sustained person-to-person spread worldwide. Especially some certain group of the people were at high risk, such as 60+ older and people with pre-existing health conditions, such as blood pressure, heart disease, lung disease, and autoimmune disorders. The map, we can see how COVID-19 pandemic hit the countries across the globe. The virus is, as we know, it is respiratory virus, and it belongs to the family of the SARS virus. SARS, and it is characterized SARS-CoV-2. This virus is continuously mutating and change over the time. Some changes are the minor, and it affects minorly on the virus properties. However, some changes, they may affect the virus properties, such as how easily it is transmitted and the severity of associated disease. And we know till now we have several variants of concerns, variants of interest so far. Moving to the main part of the presentation, assessing the workplace risks and exposures for healthcare workers. Healthcare workers may be exposed to occupational hazards that can put them at risk of disease, injury, and even death in context of COVID-19 response. These occupational risks include, but not limited to, occupational infections with COVID-19, and in case of if prolonged use of the PPE, some skin disorder and heat stress, also exposure to toxin because of the increased use of disinfectants, psychological distress, chronic fatigue, stigma, discrimination, violence, and workplace harassment. Mitigating these hazards and protecting the health and safety of the healthcare workers, it requires the well-coordinated and comprehensive approach with the collaboration of infection prevention and control, occupational health, and the national authorities, as well as the country laws. Because insufficient occupational health and safety measures can result in increased rate of work-related illness among healthcare workers, high rates of absenteeism, reduced productivity, and diminished quality of care, which can directly impact to healthcare workers, also to patients. Occupational exposures in terms of the care workers, according to the evidence, this SARS-CoV-2 mainly spread between people when it comes in close contact with the infected person with another person. And this virus can spread from infected person, mouth, nose in small liquid particles, ranging from larger respiratory droplets to smaller aerosols, especially when person coughs, sneezes, and talks. Aerosol generating transmissions can occur in some specific and certain conditions. Till now, the evidences and the researchers and the studies until now, we have seen that if there are some special and certain conditions, such as poorly ventilated areas, then there is a chance of aerosol generating the airborne transmission. And especially procedures also, whenever there are aerosol generating procedure, there is a risk of airborne transmission. There is inconclusive evidence about aerosol transmission in healthcare settings in the absence of aerosol generating procedures. So mostly it is associated with whenever there are any AGPs performed. There is limited evidence regarding the transmission through fomites. Such transmission may occur through touching the fomites, followed by touching the mouth, nose, or eyes. However, there is emerging evidence of transmission in settings outside the medical facilities, such as indoors, crowded places, and especially inadequately ventilated areas, where infected persons spend long periods of time with others. This suggests the possibility of aerosol transmission in addition to droplet and fomite. Healthcare worker occupational exposures, they can be exposed anytime with the COVID-19 and SARS-CoV-2 while working in healthcare facilities, as well as in communities. Studies have proven and suggest that occupational risk for healthcare workers can increase in certain clinical settings or with suboptimal hand hygiene, and if there are long working hours or improper or suboptimal use of non-availability of PPEs. Therefore, it is very important to know and understand and to implement and to assess the workplace risk. This can be determined by the likelihood of coming into direct and indirect or close contact with the person who is infected with virus. This includes the direct physical contact or care, contact with the contaminated surfaces, object, through aerosol generating procedures on patients with COVID-19 without adequate personal protection, especially when the healthcare workers have inadequately wearing the proper PPE, the barrier protections, or in case when there is a shortage of the PPEs. And this is very clear. We know during this pandemic how much in some countries they have shortage of the PPEs. So all these factors can play a role to put the healthcare workers at risk of getting COVID-19. Risk of occupational exposure increase with the level of community transmission with SARS-CoV-2. Therefore, the employers, it is their prime responsibility that they should carry out the regular update regarding the workplace risk assessment with collaboration and support from the experts in infection prevention and control and occupational health. The purpose is to determine the level of risk for potential occupational exposures related to different job, work tasks, work settings, and to plan and implement adequate measures for risk prevention and mitigating and assessing the fitness for work of individual healthcare workers. If we categorize the levels of risk, there are four main categories: the lower, medium, high, and very high risk. We are going to see one by one each of them based on the International Labor Organization recommendations guideline. The lower risk examples such as administrative tasks, the people who do not involve directly or contact with the patient and visitors who have a COVID-19. So in such case, if the risk is lower, the mitigation measures the healthcare facilities should take, such as organizing a remote work and teleservices whenever possible and appropriate, organizing the regular environmental cleanup and disinfection, introducing the measures for avoiding the crowded places and social mixing, and encourage the healthcare workers to observe safe physical distances. For the workers, they can mitigate these lower risk if they are unwell, they have to stay at home. So by applying these measures, and they should observe their hand hygiene and respiratory hygiene all the time. What if the risk is medium, such as in the jobs or tasks when there is a close, frequent contact with patients, visitors, suppliers, and co-workers, but this does not require contact with the people who is known or suspected of COVID-19. In this case, the healthcare facilities, they can consider alternatives to face-to-face outpatient visits using telehealth services. Also, they have to organize regular environmental cleanup and disinfection. They can encourage workers to observe their practices, providing IPC training and adequate PPE in sufficient quantity and quality. Also, the healthcare facility, they have to ensure and establish the flexible sick leave policies in order to protect the workers' safety and health in case if they are exposed or they have any exposure with the positive cases. Workers, they have to stay home if unwell, and they should observe their hand hygiene, respiratory hygiene practices. And here they have to wear medical masks and other PPE according to their task and apply standard precautions. For the patient and visitors, also they have to observe their respiratory and hand hygiene practices. This is actually a basic infection prevention measures. And also they have to use the face mask. They can use fabric face mask also because it is acceptable in non-clinical areas and in communities. With regard to the high risk, such as the examples, if in clinical triage with the person interviewing of a patient with signs and symptoms of COVID-19, cleaning areas for screening and isolation, entering the room of the patient, those who are handling and known or suspected with COVID-19. In such case, the healthcare facilities, they have to start and implement engineering, environmental and administrative control for IPC's measures and provide adequate PPE in sufficient quantity and quality. The second most important mitigation measure for the healthcare facility should take in place to provide enhanced ventilation without recirculation, with clean to less clean directional design of the airflows. Workers and caregiver, they have to use PPE based on the transmission-based precautions and level of risk. And patient visitor also same like they have to observe their practices and wearing of the face mask. Lastly, what if the risk is very high? A very high risk example such as when work with the COVID-19 patients where AGPs such as like tracheal intubation, non-invasive ventilation, tracheostomy, and cardiopulmonary resuscitations, and so on, without adequate ventilations they are performing. So in such case, the healthcare facilities, first of all, they have to start with implementing engineering, environmental and administrative controls. Secondly, they have to provide mechanical ventilation by the use of high efficiency particulate air, which we call HEPA filters, without recirculation, and it should be exhausted directly outside. Introduce the measures for avoiding crowding and social mixing and for restricting the access to non-essential workers. This is the best example of the administrative control to limit the access whenever it's feasible and appropriate. Also establishing the flexible sick leave policies. Workers, they have to stay home if they are unwell. They should observe their hand hygiene and respiratory hygiene practices. Use of the PPE based on their task. They have to follow. So other than COVID-19, the healthcare worker, they might expose some other occupational exposures also while providing care to the patients infected with COVID-19, such as it could be bloodborne pathogens and other infections, commonly like TB. Therefore, the prevention and control of occupational infections among healthcare workers, it requires a comprehensive approach, always bearing in mind the hierarchy of the controls and close collaboration between occupational health services and infection prevention and control. In hierarchy of control, we know this is very well known that always we have to consider and start from what is most effective to the least effective steps. The most effective control is to just eliminate the hazard as much as possible, and if we can. This may be through working remotely, provision of telehealth services from individual offices, or tele-enforcing. This is actually what happened during the COVID-19 pandemic. Each country and each facility, healthcare or non-healthcare, even organizations, their employees were working from home, those who were not directly involved with patient care activities. However, if the hazard cannot be eliminated from the workplace, measures should be taken to avoid or reduce the spread of pathogen and its concentration in the work environment. Examples of engineering control is just adopting the structural design conducive to patient flow and spatial separation for isolating the patients, adequate ventilation, sanitation practices, infrastructure, touch-free technologies. All these are the examples of engineering controls. Those are actually very helpful. Administrative control measures may need to be taken to change the way how people work, such as I mentioned earlier, restricting the workforce access to essential workers only with specific training and skills for protection, ensuring the appropriate working hours, restoring and wherever possible, avoid the workers being shifted from high to low transmission settings. So for example, if the worker is working with the high transmission, so we have to contain them. We should not move them frequently during the surge of the COVID-19 or any other pandemic cases, the patient. Other helpful control includes the addition of the search personnel to meet the work demands, rest break, time off between the shifts, appropriate tasks, supportive supervision. Actually, this all based on the if the facility has really a strong and best leadership policies and they are implementing to protect and ensure the safety of their healthcare workers. A role of optimal use of PPE, these are the measures should be in place to protect individual health workers from exposure, including provision of adequate and appropriately fitted PPE based on the risk assessment. Appropriate training and monitoring on proper use and disposal of PPE is also very important, because for healthcare workers, it is not only enough to just use PPE. How to use appropriately, this is more important, and in fact, it is a critical aspect. The PPE used for protection against occupational infections should comply with the standard technical specifications, such as in case example N95, when we recommend to our staff wear. So the internationally it should be recommended the best N95 is if it's noise tested or no. So in general, as we know that PPE is intended to be used for a short period of time when exposure to hazard cannot be avoided or otherwise controlled. But we have seen that in context of COVID-19 pandemic, that heavy workload, patient flows, and shortage of PPE require healthcare workers to wear PPE for extended period of times. And it has been proven through researches, even previously, that prolonged use of the PPE, especially the gloves, and even frequent hand hygiene may cause or aggravate the skin existing hand eczema. So if healthcare worker has already a latex allergy, then they are advised to use non-latex or nitrile gloves. Frequent application of moisturizing creams, also a good practice to reduce hand irritation. Healthcare worker with sustained rashes or inflammatory skin symptoms, they should be referred to seek medical attention. This is so true to say here that a picture is worth 1,000 words. We can see here how the healthcare worker during this COVID-19 pandemic, they suffered due to prolonged use of the PPEs. Because that's why the WHO and International Labour Organization recommend that healthcare workers at risk of heat stress due to the prolonged use of the PPEs, they should be advised to monitor for their symptoms of heat-related illness, including the monitoring of the color of their skins and their volume of the urines and so on. So the time spent in full PPE should be limited and rest should be arranged. That's why this is an example of the administrative control that to reduce the shiftings, the duty hours of the healthcare workers and increase the frequency of the rest breaks during pandemic. Similarly, the increased use of the disinfectants in healthcare facilities as well as in public places may cause toxic effects among healthcare workers, cleaner and other sanitation workers. Therefore, the healthcare workers who are preparing disinfectants, they should be well trained and they should know how to prepare if it is not ready in use. And always the disinfectant solution must be prepared according to the manufacturer recommendations. Whatever the instructions IFU from the manufacturer, we have to follow. During the COVID-19 pandemic, as I mentioned, there was a heavier workload for the healthcare workers and insufficient time for the rest and relaxations. So these demands can result in chronic fatigue. These are all the parts of the occupational exposures during pandemic. And lack of energy with decreased alertness, coordination, efficiency, increased reaction time. So to cope up with this and to mitigate these, there are the recommendations to make and to implement a strategic health workforce planning, support and capacity building are required to ensure safe staffing levels, fair allocation of workload, and management of working times. Moving to the prevention measure, what are the main and important prevention measure with regard to the COVID-19 pandemic that we have to implement and follow accordingly? First of all, training and education. Everything, I believe everything starts with the training and education. Awareness is very important, especially during the COVID-19 pandemic when everyone was in a fear of the pandemic. And if there is no clear and no proper awareness about the disease transmission, how it spreads, so what possible measures we can implement to prevent ourselves and the others, then it is, I think it's not helpful if we don't have a good training and education. And the good point also, we understand and we realize and recognize the importance of even virtual education and trainings. There were several programs on basic infection prevention measures and occupational hazards were established by WHO through online for healthcare workers awareness. Because it is well known that the purpose of training and education of healthcare professionals is to ensure both individual understanding and a team approach with shared knowledge, skills, and attitudes toward the prevention and management. And the control prevention measure always, it starts from the very basic infection prevention measures such as hand hygiene and the use of the PPEs. So safe use and appropriate use of the PPE, as I have earlier said, not only wearing of PPE is important, appropriate and correct way of wearing is very important. So the workplace, there must be visual posters always available for the staff. They have to look at them before how to wear and how to remove the PPEs. Also, the healthcare workers should have the knowledge, training, and skills and understanding about what preferred PPE according to the risk assessment and tasks required to wear while handling the COVID-19 patients. And in case if preferred PPE are not available, there must be a supply for alternative. Another prevention measure is isolation. It is to be triaging, screening, and early detection of patient is always helpful. Which actually provide a clear picture and possible ways to take the right decisions on right time. Prompt isolation of infected cases, even suspected or infected both, can prevent the spread of disease and further transmission in healthcare facilities. Yes, actually the vaccination, as we know, it is very vital. It plays a vital role even in any vaccine preventable diseases, especially even in pandemics. The vaccine has a major role. And it is clear even until now, we can see how COVID-19 vaccine almost a year before. It was December 14 when the first dose of COVID-19 vaccine was administered. So until now, we can see significantly it reduced the mortality and even the severity of the disease, the symptoms. So it is to be believed that vaccines, they play a major role in ending pandemics, such as in the past, we can see like in a case of smallpox and polio. So therefore, we have a hope that vaccine against the COVID-19 also will protect those who are really receiving their doses on time and not delaying. It will not actually save us. Okay, the people, they believe that vaccines are not preventing, still we can encounter the infection. Yes, we can still have an infection, we can still encounter with the COVID-19, but the severity of the symptoms, the mortality, the complication, the vaccine helps to reduce all of these. Moving to the control measures. So other than the prevention, what control measures we can take into consideration during COVID-19 pandemic? This is just an example. I took the management of healthcare workers exposure, those who are exposed with the COVID-19. This is actually the guidelines and recommendations from Public Health Authority of Saudi Arabia. Very precise, comprehensive document, and this document has been regularly updated throughout the COVID-19 pandemic. Simply, we can categorize the healthcare worker based on the exposure category. If low exposure, then self-monitoring is enough and no need any work restrictions. They can continue self-monitoring for 14 days and while wearing a face mask and implementing and just applying the social distancing, there is no special restrictions. However, if they develop symptoms during this time period, then we will deal accordingly. And in case of if the exposure is high exposure category with infected person, then healthcare workers should be monitored actively by the collaboration with occupational health and infection prevention and control department of the facility. In this case also, if healthcare workers is asymptomatic, they can still continue their work while wearing their face mask. But on the day of 3rd and 5th, they should be swabbed, and then they can, if the swab result is negative, continue the work. But if positive and symptom develop anytime during the observation time of the 14 days, then they have to stop the work and should be deemed as a positive case. This is the guideline, actually based on the even CDC guideline as well. A very important note that we have to remember that information on COVID-19 rapidly changing. As we know, initially there was even everyday new update regarding COVID-19. So we have to educate our healthcare workers, and we have to understand ourselves also that we should always refer to reliable resources such as CDC, WHO, SHA-NICE, and each of us our local national guidelines. It is very important to stick with the science in pandemic. Under the part of the control measures, so the recommendation to prevent fatigue is shifting of the length, 5 8-hour shift or 4 10-hour shift is the preferred. Workload balancing of the shift of lighter and heavier work also could be implemented as a part of administrative control measure. Rest and recuperation, establishing the policies regarding duration of working hours and rest break, providing frequent brief rest breaks every 1 to 2 hours during the demanding work is more effective against the fatigue than a few longer breaks. So in interval, the short breaks, but with more frequency. Also, if necessary, then and if possible, the healthcare facilities and organization, they should provide accommodation to healthcare workers during emergency operations. And I'm sure because I have seen this in our here in Saudi Arabia or even in our facilities, and I'm sure other countries did the same. They provided the accommodation for those healthcare workers who were dealing the COVID-19 patients, especially for longer time. So they provided special place for them to just stay, not to go in their homes, in order to prevent and protect their family members from exposures, especially during the peak time of the pandemic. What are the prevention measures of violence, harassment, discrimination? As we discussed, this is one of the occupational exposure that could occur and could happen. Incidents of violence and harassment against healthcare workers have been increasing during the COVID-19 pandemic. The most widespread risk factor for workplace violence in the healthcare sector, we can see it is a stress and fatigue, long patient waiting times, overcrowding, the burden of the transmitting negative prognosis. Also, contact tracing or not allowing the access to the bodies of the deceased loved ones. This can cause really a big stress. Violence, harassment, discrimination, and stigma against the healthcare workers should be prevented and eliminated as much as possible, because this can affect the mental health to the healthcare worker, which will eventually lead to the physical illness also. Some countries, actually, they introduce specific legislation, for example, by criminalizing such acts and providing the regulatory protection for healthcare workers to prevent and eliminate the violence and harassment in healthcare workers. These are some recommendations from International Labour Organization addressing the workplace violence and harassment. I'm not gonna read all of this due to the respect of the time. Just in conclusion, they were emphasizing establishing the procedures to prohibit discrimination and harassment and promote fair treatment of the workers. Providing the timely and accurate information to staff and patients is very important. This will help to reduce the uncertainty and distress. Also, having a protocol in place for reporting, investigating, and responding to incidents of violence, stigma, and discrimination in order to promote and to give a blame-free environment to all. The importance and the part of the mental health psychological support, in addition to the previously we mentioned the occupational exposures and the pressures, studies, they review that healthcare workers' mental health and well-being can be affected in COVID-19. This can be caused by the contact with affected patients, perceived impediments to doing their jobs, insufficient organizational support. That's why the good leadership, good strong leadership and organizational support is very important in pandemic. Personal risk factor also can play a role to increase and to affect the mental health, such as lower level of education. If healthcare workers do not have enough awareness and education and they are just getting information from non-reliable resources and believing on those, so this can cause stress, fatigue, and which affect the mental health. Also, increased time in quarantine. Yes, loneliness. We have seen this, and there were several studies on it that the mental health, how much it is affected due to the loneliness, social isolation, having children at home, lower household income, younger age, and so on. There were several factors which can impact the mental health. This is the study actually. This is a peer-reviewed article which was published lately in this September 2021. In conclusion, this study actually, they found that perceived risk of being infected with COVID-19 at work, conceptualized as a job demand, was positively associated with emotional exhaustion. And overall, this study highlighted the importance of a good balance between the job demands and resources related to COVID-19 in preventing the possible detrimental consequences for workers' well-being in terms of burnout. There are some common preventive strategies which can help to improve the mental health support, such as by implementing the surveillance measures to detect critical incidents, to ensure the quality communication and accurate information updates, ensuring the availability of and facilitate the access to confidential mental health and psychological support, also providing the mechanism for early and confidential identification and management of anxiety, depression, and other mental health conditions. Under the part of the engineering control, this is also a good control measure to provide to ensure the availability of hand washing facilities with clean running water and hand hygiene products. Also to access the rest and relaxation rooms, safe drinking water, supplies for personal hygienes for the healthcare workers, also food and rest opportunities. Also the places where healthcare workers sit in during their rest times, there should be daily cleaning protocols to ensure the workplace, workstations, equipments, and facilities are clean and tidy, and a system for disposing of the bin contents and disinfecting of the bins based on their regular schedule.
Shazia, thank you so much, but I'm afraid due to time constraints, can we finish this up so we can go to the next?
Sure.
I apologize. I'm so sorry to interrupt.
No, we are about to finish,
but we're running out of time.
Yeah, we are about to finish. Just 2 minutes.
Thank you. Shukran.
As a part of the occupational health services, in the context of COVID-19, there are some focal points that it should be followed, such as carrying out the regular workplace risk assessment, providing the instructions on training of workers, advising additional measures, also to identify the groups of healthcare workers and organize immunization campaigns. Some healthcare workers need a special considerations, such as if they are at high risk, so we have to deal them accordingly. And healthcare workers assessment should be done periodically, particularly for the development of the skin and mental health disorders and other health related problems. And lastly, what are the responsibilities, duties, and rights as a healthcare worker and employers? Actually, the employer, according to the international labor standards, employer have overall responsibility to ensure that all necessary preventive measures are taken to minimize occupational exposures, such as they have to provide information and instruction on training, they have to provide adequate supplies, they should maintain the supply chain management, they have to consider and provide the access. The employer should promote the cooperation between management and healthcare workers, also ensuring the healthcare workers covered with employment. And as a healthcare workers, they are responsible to treat the patient with respect and compassion, providing or reinforcing accurate IPC and public health information to patients and the public, especially taking off the disposing of the PPEs correctly and appropriately. Also, in case of exposure, even inside the healthcare facility, outside, they are responsible to inform immediately to their immediate supervisors. Lastly, what are the responsibilities of national authorities? National authorities, they must ensure that healthcare workers, especially those who are at medium, high, and very high risk of infection, they have early access to COVID-19 treatments, vaccination programs. They should also ensure that all healthcare workers are covered by schemes for employment injury benefit according to their national laws and regulations. To just conclude the talk at the end, we can summarize that occupational safety and health should not be sidelined as a service delivery issue. Healthcare worker health and well-being is an important aspect of workers' motivation and satisfaction, which influence the productivity as well as retention. Because what is good for the employee health is definitely good for the patient health. These were the references being used during this presentation. For more information, I would like to end with this note that safety is not something that can happen on its own by accident. We have to work towards it with the right measures, right tools, and mindset. Stay safe, stay healthy. Thank you. I'm sorry if I took more time.
No problem, and thank you so much. That was wonderful. Our final speaker for the evening or for the day is Sharafat Olagan, and I apologize if I said anything incorrectly. I mispronunciated. The speaker will be online, and they will be speaking on health professional leveraging online opportunities. Thank you.
Can you hear me?
Yes.
And can you see me?
Thank you.
Right, okay. Hello, hello. Assalamu alaikum. Welcome, everyone. It's a great pleasure to be amongst you all. My name is Sherifa Tolaogun, and this is what we are doing today. And because I know time is a very important factor, we are going to move quickly. We are not going to waste any time. So this is our topic for today: leveraging online opportunities for expert positioning, networking, and branding. So let me present this. Let me put it in one moment. Right, okay, so that way is more fun. Right, okay, so this is what we're going to be talking about today, and this is how we are going to be looking at this topic. Let me see, let me move my camera so that you can see only the necessary part of my little room. Okay, so this is how we're going to deal with this topic. This will be our discussion points for today. I'll introduce myself very quickly. I am very conscious of time, believe me. We're going to look at what positioning, what do we mean by that? What opportunities? I'm going to discuss very quickly my journey with positioning online. I'll discuss my discovery with my activities online and what I was able to come up with. And also I will talk about the mindset and strategies is needed for positioning, and then we'll round up. Right, okay, so we're going to move forward. Before I go on, this is me. I'm not going to go through everything. You feel free to take screenshots. I'm a mindset and business coach. I'm a part-time practicing pharmacist, and I'm the founder of Impact for Life Academy. I'm not going to go through all of that. This is more about what I do. I inspire and empower my clients with tested framework to do what? To transform their gifts, be it their passion, their skills, or experience, into a profitable coaching or consulting or online course business. And I cater to professional or career women, entrepreneurs, and aspiring coaches. What do I do for them? I help them to bring their brand visibility, to monetize their gifts, and to launch their businesses. I offer coaching, mentoring, blog posts, and all of that. So quick check-in before we go on. I always like to check in with my my listeners, my audience, and see what they are thinking. Like when you saw this topic, what came to mind? I would love you to engage with me. I love engagement. I love engagement. I see 17 people, maybe it minus me, online right now. So what I'm saying is that the more engagement you give me, the more you're going to get from me. I love engagement. Engagement is my own icing on the cake. I am here for the engagement. You are here for this. So let's do a symbiotic relationship. So I'll be looking forward to you really engaging with me and really giving me all the energy I need. It's about 9 a.m. here in Windsor, Ontario. So I'm still sleepy. I've got my cup of tea. So I'm going to need you to wake me up with your engagement. Are we ready for this? Right. Okay. So what are your thoughts? I'd love you to share with me. Let me find where is the chat box. I would love to hear from you. When you saw the topic, leveraging online opportunities for expert positioning, what came to mind? Like, what were you thinking you're going to be able to take away from here today? So I'll give you a couple of seconds to drop things in the chat box for me, and I'll move on still. So I'll just remind you, whether you are familiar with this subject matter or not, beginner or experienced, you are in the right place. There's something for you to take away. And during the course of my presentation, if you hear anything that resonates with you, I would love for you to share it in the chat box to also steal for the energy. If you have questions, I'll be happy to take them at the end. Also, you might need to take a lot of screenshots because I'm going to go very quickly. Well, as quickly as I can, but still making sense. Right, okay. Like I said, engagement, I love it. At the end, I have a freebie for you. If that's something that you need, you might be of benefit to you. So I'm going to move on, but I'm still going to want to come back and read some of your engagement. Let me see. Is there one? Right. Okay. None yet. I love engagements. I haven't seen any comment in the chat box. Come on, people. Give me some engagement in the chat box. I love engagements. Engagement is the life of the party. Come on. We're having a party here, aren't we? Or maybe we've listened to too much of academic stuff. We are tired. Okay, I'll be waiting in the chat box. I'm going to move on right now. Right, okay. We're going to do a deep dive. What do I mean by deep dive? We're going to explore the common concept or keywords in this subject matter. And in doing that, what connection? when we say connection, what's the connection between positioning? What's online opportunities, and what is nurses got to do with it? Why are you here telling me about this? Why, I want to hear only about PPE and COVID and prescription and patient safety and patient collaboration and all of that. No, we are trying to find a balance. What's the connection between all of this? Okay, this is the connection that I find. Would you agree with me if I was to say that nurses are leaders? Nurses are experts. Nurses are natural team players. We are natural problem solvers. Will it be right to say nurses are angels with wings? Would I be right in saying that they are heroes even in capes? So the connection still further is showing up to leverage on any opportunity. Showing up is the very first step. And online opportunities cannot be tapped. You can't have success if you don't show up. Showing up is the most important thing. It's like you showing up for your patients. No matter how much knowledge or expertise you have to show up at work. You have to show up in the patient's home. You have to show up in the hospital. You have to show up at your place of work. You have to show up for the patient in care-wise, in mindset-wise, in helping them find solutions to problems that is not even documented. So when you show up, opportunities start to show up. Do you agree with me? Okay, Manuela Lamonaca, lovely to engage with you from Italy. I'm from Windsor. Thank you. I love engagements. Engagement is my oxygen when I'm doing presentation. Right, okay. We're going to move on. Expert positioning. What do I mean by expert positioning? I'm trying to move this out of my way. Okay. So positioning is to influence how you stand in the mind of others. Being intentional, acting with awareness to showcase your expertise. You might have a lot of knowledge, experience, but if you're not intentional about projecting that, it might be difficult for anybody to see. And sometimes it's in how we create our profile bios. For example, on social media, it's about maybe the kind of content that you share on social media. It could be, how the standards of how you're seeing, the kind of, let's say, pictures or graphics that you have a professional photo, or do you just put any photo that you went to a party on social media? Imagine putting a picture of you and your friends as your bio, as your profile photo picture. Of course, you can put it as your content if you have something that you want to share from it. But imagine somebody coming to your page or so you have social media handle, and what they see first is you maybe driving a car. Does that position you as an expert? Of course, if you're a driver, that's fine. But if you're a professional, a healthcare professional who is looking to leverage on online opportunities, the way you position yourself online matters a lot. So these are the different ways, and also how you engage with other people. Also, you have to be conscious of being professional so that you are seen as an expert that you are. So what opportunities? There are many opportunities, and it's different for everyone. What's an opportunity to me might be different for what opportunity will be for somebody else. And so it means it all depends on our unique goals, depends on what you're trying to do. Are you trying to, make more impact health-wise, maybe as an health coach, maybe as an educator, maybe as an advocate, or maybe you're even trying to monetize, which is my own journey coming online. Or maybe you're just looking to network with professional colleagues. Let me mute this. Let me remove this for now. It could be monetizing or networking with career, or maybe you're want career progression or expansion or pivots, which was the case for me as well. So like we said, opportunities will vary from time to time or for seasons in our life cycle. I'll tell you a little bit more story about that. I've been a pharmacist for about 21 years. I've been a pharmacy manager for about 15 years. So I got to a point in my career cycle where I wanted more. I knew I have already gotten so much experience. So where I was at that time, I felt was underutilizing my skills or my potentials. And there was a lot I was already doing behind the scenes, empowering women with their goals, motivating people. When I see people, I see the skills they have in them. I see what they could be doing. When people are complaining, I see how they can, leverage on what they have and go to do lots of things with it. But I was doing it for free, of course. I was doing it informally. And, when you do things for free, people don't really put their effort on it. So I always say that transformation starts from investment. Okay, I'll tell you more about that story later, about my journey from being a pharmacist. I'm still a pharmacist part-time, and now coming online to, teach online business coaching and mindset coaching. So what opportunities? Opportunities could also be connecting with your ideal clients. Maybe you are a health coach, maybe you are a nutrition coach, maybe you are maybe you choose to be a health fitness coach, because we already have all those skills from our training, from our, from school, from our degree certification. We have so much that we are underutilizing, and we are a very important part of world leadership, education, advocacy. So it's important for us to step fully into those roles and explore the opportunities there. It could also be collaborating. Those are some of the opportunities. What we are doing now is a form of collaboration where Amal has invited me to be a guest speaker here. Also, fundamentally, whatever the opportunity is, it starts with you showing up with value. And when you show up, opportunities start to show up. We'll talk more about that as we go. So like I started saying before I even got here, my journey, being a pharmacy manager, being a pharmacist, and then coming in doing online, because I already had passion for doing all of these things, helping people, coaching people, guiding people, mentoring people to achieve their goals. So I like, okay, how can I? And then I came across the concept of online coaching, business. I'm like, okay, this sounds like something I'm already doing. Maybe there's a way I can now formalize it, make this a little bit more professional, so that I can say fully that this is what I do without, feeling like, oh, what will people say? What will people think? What am I even saying? So I went through a lot of coaching, a lot of training programs and courses to help me to, stabilize and standardize my offer, my processes. And then this is where I am today. I've had a lot of benefits. I started doing in-person workshops. That was another journey of mine, another milestone. When I decided that this is the time to do this, I started doing face-to-face online workshops. But then, even then, there were limitations. What do I mean by that? I would have people ask me, I want to attend your program, but I can't come because I have kids that don't want to look after them, or you're far away from me, or I'm not in the local community. I see you advertise something, I want to be there. I ignored the request for a very long time until it became unbearable. Until one day I thought, you know what? If I truly care about these people, as I claim, why am I allowing people to miss out on the opportunities that I provide? So if I, as a student of knowledge, at some point or the other, I've been able to do a lot of programs and courses without being in the same physical spot, online access, remotely, is there a way I can convert what I have into the same way? So I did even more research, did more learning, and then with God's will, I was able to now start to do online masterclass. And then COVID happened. Then like a big confirmation that I was on the right track, even 1 year, 12 months, 16 months before COVID happened, like really now being online. Right, okay. So these are some of the personal dividends I've had leveraging online opportunities. I've been able to create programs and coaching courses. I've been able to build a community. I've had awards. I've had endorsements. I've been able to build a blog. I have a website. I have a learning management system. Those are all progression. They didn't all happen overnight. It started from me wanting to achieve something. It started from me showing up, wanting to help, wanting to serve, wanting to impact and influence. And then as each challenge came, I've tried to find ways around it. So sometimes when you're looking at it from the outside, it might look like it's impossible, it's difficult, I'm too busy, I have too much work. There's a lot of ways around there. Once you have this zeal, the passion, the drive, the experience, and you're willing to learn and take action on your learning. So if I can do all of this, it is very possible for you too. So this is my prescription for you with leveraging online position. When I tried to come online, I had a lot of challenges, even though I was already doing one-on-one workshops. Like I said, I enjoyed that tremendously. After the coaching or the training session, we would, put our feet up, we would chat, we would just, but there was a limitation for me personally. I wish there was a way I could just focus on my content delivery and be the coach that I am, and not have to set up the venue and not have to clean up after. So coming online was an absolute game changer for me, where I could spend quality time really perfecting my processes and procedures and delivery on what I offer and what I offered. So in the course of doing so many courses and coaching programs from so many different coaches, I found that they were all teaching the same thing to a large extent, but they would come to it from different angles. Teaching you how to leverage online opportunities, teaching you how to position as a professional, teaching you how to brand, teaching you how to network, teaching you how to create offers or products that people can exchange money from for you, so that your time on social media is worth it. Each one of us, we spend not less than 2 hours, I dare say, on social media, and that includes WhatsApp every day. Is there a way we can be intentional about that? Is there a way we can, it's okay to socialize. I mean, we all need that break, but within that, can you passively learn? Can you passively, learn from others? Can you passively explore opportunities? That can you passively position, until you are ready to go? There's this quote that I shared on my page a few days ago, like I can't remember verbatim, but the biggest secret to success, I'm not quoting verbatim now, the biggest secret to success is starting before you're ready. So it's important for all of us that we are all on social media now. COVID, thanks to COVID, even those of us that really didn't want to do it, even for our kids, now that we are there, how are we going to make sure that we are using it to benefit us? Why are we going to be there to make sure that we are using it positively? We're not just there wasting time. Sometimes, if you're not careful, you can be on social media for an unbelievable amount of time. Children struggle, believe me, adults struggle too. So how can we now begin to shift what we have and use it in a way that is 360, serving us in a 360-degree kind of way? It's helping us, and you're using it to help others too. So I came up with this prescription from learning from all the different coaches, and I'm continuously learning. This is what I came up with. I came up with a prescription which I use in my signature coaching program, Gift to Business Mastery, and I call it the GTTB framework. So basically, your success path from A to Z of, I have a gift. What is my gift? My passion, my expertise, my experience, my certification, my whatever. Maybe it could be health-wise, it could be parenting, it could even be relationship, it could be marital, it could be business, it could be anything. Just because you're a health professional, that's not all there is to you. And that even being a health professional is enough. You have a bucket load of experience and expertise that a lot of people can use and leverage on. It's now important for you to look inwards and be absolutely clear that this gift is valuable. And then you need to find people that need what you have. And then you need to be able to have products, which will be consulting, which could be coaching. I'm sure everyone here has attended one program, paid program or the other, where you have exchanged money with somebody to be part of their programs, coaching course, consult, whatever. You can do the same. And also the fourth part is building your brand or your business, right? Okay, so this is just a summary because we can't go through all of that prescription, but for me, this is the summary of it. It starts with you valuing your value, embracing the gifts that you have, and doing the mindset work. Mindset holds back an unbelievable amount of people. You would not believe it. A lot of us, we have strategies, we have skills, we have experience, we have knowledge, but our mindset holds us back. What do I mean by that? Who am I? What will people think? I had that experience. Oh, I'm a pharmacist. If I now come online and say I'm a coach, what would people think? What would people feel? I'm like, what is she looking for? She has enough money now. She's making enough money now. She's a professional. What's all this about you being a coach? But this, I refuse to live up to people's expectation of me. I refuse to fit in a box that people have created for me. I know this is what I want. I know this is what I'm capable of doing and delivering very well because I'm already doing it behind the scenes. So that mindset work is a big part of you taking ownership of what you have and really stepping forward and shining your light. When I say shining your light, I mean show up. That's another story entirely. I had lots of knowledge. I did a lot of courses and still coming on and acknowledging and really saying, this is what I do, this is who I am, was a struggle. And that is why I believe very strongly that mindset and strategies work hand in hand. So as a coach, I always focus extremely on the mindset going along with the strategies because I've seen from experience and from working with clients that mindset holds us back. So when you now show up, what do? Is in giving value. Is in education, is in entertaining, is in engaging. You don't want to just come online and be coming and giving us textbook stuff. We have enough of that. Life is too boring. Don't take out social out of social media. So you want to have a balance of content where you're entertaining your guests, your followers or your audience, you're educating them, you're engaging them as well. If you hear something that resonates with you, I want to hear it in the chat box. The chat box is too quiet. Is anyone sleeping? Is anyone awake? Is anyone with me? Let me hear you in the comment section. So we're going to move on. Clarifying your message is another important part of this framework. Who do you help? What problem do you solve? You can be a health coach but what else? What specifically do you do? Just like we have many doctors with different specialties. Are you an emergency doctor? Are you a family physician? Are you a specialist? So you have to clarify who you want to help and how you help them. Also, creating your solution. No matter how much you know, the real thing, the only way you can really help somebody is to package your solution in a way that it can be exchanged, maybe for money, even as a freebie, but at least somebody, you have value. Somebody wants to take advantage or benefit or leverage on that value. How? Is in your solution that you create. And then when you create it, you have to flaunt it, sing about it, sell it, sell it. It's not going to sell itself. You have to be unapologetic about it. Like, I made this, I wrote this ebook, I created this, coaching program. I created this course, make avail of it. Right. Okay. What are the positioning strategies? Those are the meat of today. And I'm going to go really quickly. Okay. So these are the strategies. You can take screenshots. I've talked a lot about mindset already. Visibility, showing up, the content, what kind of messaging are you giving on your platform that positions you as an expert, that attracts the people that you need, that, clarifies for me how you can help me, and what offers do you have, and networking as well. Those are all online opportunities if you learn how to do it. So mindset issue. So how do I fix it? Identify it, what the problems are, you resolve it, and then preferably you prevent it, because you don't want to be also always reactive. You want to be proactive. Prevention, they say, is better than cure. You nurses know about that more than I do. Prevention is better than cure. So you want to start with the end in mind, know your why, and that would really help you. Affirmations help a great deal. If you find that what fear is coming up for you as per what will people think, or what if I fail, or who am I, or is your fear coming from lack of know-how? So you have to be able to identify what yours is specifically and be able to deal with it. Right, visibility. Excuse me, let me take a sip. What do I mean by visibility? To leverage online opportunities, you have to be visible. And it starts with choosing a platform to engage people in. How would I engage? How would I engage them? What would they engage? You have to interact with other people for them to interact with you. You don't just create content, put it on social media and walk away. So the more you do, the more the algorithm is going to favor you. Just because you've made a post doesn't mean that people have seen it if you are not engaging with other people, collaborating with other people too. What groups can I join that I can learn from to improve what I'm trying to do, and also so that more people can see me? And those content is how you engage with other people. What kind of post am I going to make? A lot of people get stuck here too. Yes, I want to do X, Y, Z, but how do I don't even know what to do. I'm a professional. People like professors, people that have a lot of knowledge, and they are like, I don't know what kind of content to create. So these are the ways. These are the things we need to learn. These are the things we need to know to leverage the online opportunities. So via your content, you can project your expertise. You can find people that you need help for. You can even sell what you offer. Branding. This is like positioning too. If you as human beings, we are very visual. So if you don't position right, just let me use the example of physical products, for example. You might have the same item in two different packaging, and one would be worth more, or one would be more attractive just by the way they are packaged, the way they are wrapped. So that shows the power of the way you position with intention. So branding starts with, how do I want to be seen? What kind of pictures? What kind of content? How do I find the people that I'm here for? Am I a health coach? Who am I looking for? Am I looking for 50s and above? Am I looking for working moms? Am I looking for professionals? Am I looking for young adults? Then experience is the biggest part of branding. Branding includes a lot of people. When they think of branding, they are thinking, oh, your logo, your website, your font, your colors, but that is a minute part. The biggest part of branding is how people experience your brand, your page, your profile. When I come on to engage with you, what experience do I get? Maybe as clients, maybe as a prospect. Do I feel listened to? Do I feel looked after? Do I feel, like an important part, a member of the team in your, journey as well? And, those are the assets. And the offers, like I've mentioned before, those are the ways that you can exchange value for value. I've read your social media posts. You're very good. I love what you're sharing. I love what you do. I want to want to go further with you. I want to leverage more on what you have. How is with your offer? This is what I do. This is my coaching program. It's a 3 months program. You learn about content creation. You learn about messaging. You learn how to find your ideal clients. You know how to brand yourself. You know how to clarify who you help and how you help them. That is the offer. So it's important. And then pricing it right too. Okay, I don't want to waste so much time. And then also actually sitting down and creating it is important. Networking is a big one for most of us as professionals. Well, networking is how I can say I got Amal to an extent. If I didn't show up on social media, on LinkedIn, she won't find me. So networking, I've done a lot of things via that networking opportunity where we've collaborated, where we have referred one another. Somebody comes to me, I can't help them with what they have. I know a friend who can help them with, there's a job opportunity somewhere, I see it, but that person doesn't, she's not aware of it, but I know she's the right person for the job, I refer her. And also networking is very key, as we all know. And then you have to be absolutely okay. If you're doing joint conferencing, joint presentation, it has to be mutually beneficial. What do you want to do? Why do you want to do it? And how you're going to be doing it. Round up. Said I was going to try and be really quick, right? Okay, this is the roundup. So we've talked about positioning. We've talked about the opportunities online. I've just mentioned very few of them. There are so many more. This is just me encouraging you. If it's something that you have thought about before, if it's something that you have not thought about before, there are many opportunities there. If I can do it, and I'm a non-techie, I used to call myself a non-techie. My kids usually have to help me. But with the things that I do now, because I have passion for it, if you see my studio is all set up, like I'm now the techie girl, not because, like I have a passion for it, but because it became a need to, meet my clients or patients' needs. I had to do. If there's anything that has an A to Z, you can do it. It might take a while, it might take time, it might take some learning, but you can do it. I've also shared my journey, how I came positioning online, and I've shared some of the benefits that I have, very few of some of the benefits that I have. I shared my prescription with you, what I discovered, learning from so many people, so which made me to now create mine, using my experience in pharmacy, in management, in coaching and counseling clients, and merging it with all the things I've learned across the board from different coaches, and I created my own. And then we talked about the different strategies. And this is another summary. If you want to take a screenshot. Okay, let me leave it 1 minute. Screenshot. Call to action. My darling nurses, my healthcare workers, we are natural leaders. We are experts. We have a lot of knowledge. I'm calling you out to step forward, embrace your expertise, your knowledge, your experience, your passion, your skills, and position online. The world needs you, your tribe needs you. I'm running a program right now where I was taking people from, engaging online for the first time. There was a lot of fears, there was a lot of worries, there was a lot of mindset blocks. Oh, I don't know how to do it. What will people say? What will people think? People were literally shaking just before the very first action. And straight after, within 24 hours, within 24 hours of taking action, they start to see the benefits, literally, because the fear is unfounded, usually. Your fear does not know your strength. You just need somebody to hold your hands, to support you, somebody to show you the know-how, and then you will be amazed at it. So I'm calling you out to position, to brand, to network, make impact, go serve, go influence, go monetize. Right, freebie, if you're interested, you can take a screenshot of that as well. I was going to leave it in the chat box, but I don't know. Freebie, and then another freebie. If you're interested in extra bonus, reach out, take a screenshot, and that is it. Thank you for watching. Lovely to be here.
Hello.
Hi.
Listen quickly, me. I'm going to contact you, okay? My name is Annette.
Lovely. I'll be looking forward to it.
Yeah, I'm a fellow coach, but you actually have it, girl. You have it.
Fantastic. Thank you.
Okay, I will contact you. I see your details here. Okay. Thank you.
Bye-bye.
This is nice. Sharifat, thank you so much. I absolutely love your energy. What a great discussion that you did. So thank you very much for hanging in there with us. And we enjoyed it here in Dubai.
Thank you, thank you.
All right, this is the end of the conference for the day one. We'll be closing it out now. We will begin day two tomorrow morning around 8:30. So please come back and join us for day two. Thanks everyone that participated. Thanks to UCG for the wonderful organization and setting this up. It has been a really great day today. So thank you everyone. Thank you to the speakers, and we will see everyone tomorrow. Have a great night.
Bye-bye.
Bye. I really